We are live. Doctor, we are live.
Welcome to the 4th Global Neuro-Ophthalmology Case Festival 2024. It is my immense pleasure to greet you all as we embark on this enlightening and collaborative journey over the next 2 days. In the spirit of the upcoming Paris Paralympics, which carries the inspiring motto, "Alone we go faster, but together we go further," we gather here today to exemplify the very essence of this message. Our collective goal is to advance our understanding and practice of neuro-ophthalmology through the power of shared knowledge and discussion. 9 years ago, the Neuro-Ophthalmology Special International Group was born in India with a singular purpose: to facilitate in-depth case discussions among neuro-ophthalmologists from across the globe. Our mission remains steadfast, and today we are thrilled to see the growth and development of special interest groups in neuro-ophthalmology emerging in various corners of the world. For the next 2 days, our sessions will be expertly moderated by 6 of our esteemed members, guiding us through a series of engaging and insightful case discussions. To ensure an interactive experience, we encourage you to submit your questions via the chat box on the provided web link. Your queries will be addressed as we delve into each case, fostering a dynamic and collaborative learning environment. As we dive into 6 episodes of thought-provoking discussions and enjoy 2 evenings of both scientific exploration and stimulating interaction, we hope you find this festival not only educational, but also an enjoyable experience. Here's to a memorable and productive global neuro-ophthalmology case festival. Together, let's make these sessions both splendid and scientifically enriching. Thank you for joining us, and let the festival begin.
It's my immense pleasure to introduce Dr. Satya Karna, who is the man behind the whole show. He's the director of ophthalmology and cataract and refractive surgeon and a great neuro-ophthalmologist. He is also at the Karna Eye Clinic in Noida and at the Max Hospital. His areas of interest include teaching basics of neuro-ophthalmology and neuroimaging. He has authored the Shankar Netralaya Atlas of Neuro-Ophthalmology, both the editions, and he was the joint secretary of the RENOS from 2018 to 2023. He's the specialty reviewer for the Indian Journal of Ophthalmology. He is a great, one of the pioneers in neuro-ophthalmology in our country. Here's to Dr. Satya Karna.
Thank you, Meenakshi. So now let me introduce the panelists for the first session. We have Dr. Meenakshi, who is the professor and head of ophthalmology at Amrita Hospital and Amrita School of Medicine, Faridabad, Delhi. She has a special interest in multiple sclerosis, IIH, visual fields, drug-induced optic neuropathy, and OCT and neuro-ophthalmology. She has over 200 presentations at national and international fora and has 30 publications to her credit. She is a dedicated postgraduate teacher and has been so for the last 20 years at Amrita Institute in Cochin. Next is Dr. Padmavati, who is the Chief of Neuro-Ophthalmology Services at Arvind Eye Hospital, Tirunelveli, Tamil Nadu, India. Her areas of interest are disc edema, supranuclear palsies, OCT, and neuro-ophthalmology, and she has 18 publications in various journals. Next is Dr. Savita Rath, who is a senior consultant, Department of Pediatric Ophthalmology, Strabismus, and Neuro-Ophthalmology at Dr. Shroff's Charity Eye Hospital in Delhi, India. She is an alumnus of the L.V. Prasad Eye Institute, and her areas of interest include optic neuropathies, ocular motility disorders, and complex strabismus. She is also actively involved in the various teaching and training programs at her hospital, and she has various publications and awards to her credit. And now let me introduce the first speaker for the session, Dr. Andrew Lee, Professor Herb and Jean Lyman Centennial Chair in Ophthalmology, a founding chairman of the Blanton Eye Institute Department of Ophthalmology at Houston Methodist Hospital in Houston, Texas, a professor of ophthalmology, neurology, and neurosurgery at Weill Cornell Medicine, an adjunct professor of ophthalmology at Baylor College of Medicine, Texas A&M College of Medicine, and University of Iowa and the University of Buffalo, a clinical professor at the University of Texas Medical Branch in Galveston, Texas, and the UTMD Anderson Cancer Center. He is a past president and chairman of the board of the North American Neuro-Ophthalmology Society and is currently the senior vice president for advocacy at NANOS. He has received the teaching award 15 times, and he's an invited speaker at over 400 national and international medical meetings with more than 500 peer-reviewed publications and 14 full-text books, and has given 15 named lectures. Over to you, Andrew.
Thank you so much, Satya, for having me and accommodating my crazy schedule. I'm actually coming to you from Quebec, Canada. So you can see this slide, I hope. Yes, Satya?
Yes.
So we're going to be talking about inside out, and you'll see why that's the case in just a second. So this is a 68-year-old white female who came to me with the diagnosis of thyroid eye disease. She had had a past medical history of some sort of thyroid abnormality, but she was not on any treatment at this time. She had a 20/20 acuity, 6/6, normal field, normal OCT, normal fundus. And the reason she was sent to me was she had proptosis, which was asymmetric on the left eye greater than the right eye, and the lid was just at the superior margin, consistent with possible mild lid retraction. She had an ultrasound which showed enlarged extraocular muscles diffusely, but the interesting thing was the SOV, the superior ophthalmic vein, was also slightly enlarged in the left eye, and a CT and an MRI scan of the head, but not of the orbit, were reportedly normal. She was seen by oculoplastics and given the diagnosis of TED, thyroid eye disease, and she was about to undergo orbital decompression for TED, thyroid eye disease. But before they did that, they wanted us to look at her because her proptosis and her SOV seemed to be enlarged on the imaging study. So here was the supposedly negative head MRI, and you can see she was referred as thyroid eye disease, but this is the superior ophthalmic vein that is enlarged here. And what you can see on this CTA is that it's not just the SOV, but there's these little round peas in a pod, which are enlarged vessels in the lid and in the face. So here's the report. It said, I do not see evidence of arteriovenous malformation in the left eye, and the vascular structures do not show abnormality in left eye, and there was no evidence of proptosis by MRI criteria, according to the report. And so in football, in American football, we have a thing called instant replay. And so they call that upon further review. So we always look at the imaging studies for upon further review if they don't match the clinical findings. And so this is just a clinical photograph showing the patient in a kind of a worm's eye view, showing her inferior show, her lid was just at the superior margin. She had this mild injection, and there was perhaps some fullness right here. And that CTA, this is a reconstruction angiogram showing that there is this abnormal blood vessel connection between the superior sagittal sinus and the extracranial facial veins and retrograde flow into the superior ophthalmic vein. So normally on the superior sagittal sinus, the transverse, the sigmoid down the jug, really shouldn't see anything over here. And certainly inside should not be connected to outside. So the inside vein, the superior ophthalmic vein, is connected to both the SOV, the superior ophthalmic vein, and draining extracranially down into her face on this standard catheter angiogram. So upon further review, of course, the ruling on the field is overturned. It not only showed a vascular lesion, it showed that there was inside out. And the main question, as you know, in vascular malformations, is it arterial? Is it venous? Is it cavernous? Is it capillary? And so the main dangerous thing is asking the question of whether or not there is an arterial component to the malformation, which would make it an arteriovenous malformation. Of course, not all vascular malformations are equal. And so this thing where you have inside out through a connection in the skull is called sinus pericrania. It is peri because it's around, and it's crania because it's on the outside and also on the inside. And this is the angiogram again, showing the superior sagittal sinus, the venous outflow, but the SOV is enlarged and the drainage down the facial vein and the angular vein in the lid. After onyx embolization, you can see they have complete obliteration of this vascular venous connection, but there was no arterial component to suggest it was an AV fistula or an AVM. So it was completely a connection vein to vein. And so this condition is called sinus pericrania, and the dominant venous outflow can flow out into your lid and backwards retrograde into your orbit and the SOV. So this has been reported before, but this is actually the first case that I personally have seen of sinus pericrania. And so this is a different patient, but this is how it normally presents: a superior sagittal sinus, transverse down the jug, but you see the extracranial connection between the sinus and the vein at the top. And so it often presents in a kid with this like blue mass on their head. It's a rare thing. It's usually congenital, but in our case, it was acquired. Probably there was some predisposing thing there or dehiscence or something. It usually presents in a kid as an epicranial venous malformation, a blue mass on their scalp, and represents an abnormal connection between the intracranial and extracranial venous pathways. And it's often treated for both aesthetic reasons and for a prevention of bleeding. So here's the typical case: like a blue mass on a kid's head. The blue mass is venous. It is passing to the superior sagittal sinus and connected from the inside to the outside. Often the superior sagittal sinus is the sinus involved. So the main take-homes from this case are, in addition to the normal things that we always consider in dilated superior ophthalmic veins, carotid cavernous fistula, orbital arteriovenous malformation, and of course the less common TED, thyroid eye disease, you should add sinus pericrania to the list of the differential diagnosis. And in this case, the dilated superior ophthalmic vein, which normally means there's an orbital vein that's dilated. And if it's just venous, I'm thinking orbital varix, but you also must consider the possibility that it is inside out. The intracranial superior sagittal sinus is typically the vein that's connected to the external vein, and that thing is called sinus pericrania. It can rarely involve the orbit, as in our case, and as someone mentioned, it can cause increased intraocular pressure. In this case, there was no increased intraocular pressure, and there wasn't any redness of the eye. And in order to make the diagnosis, even though you can see it on CTA and MRA, typically it requires both a diagnostic and ultimately a therapeutic catheter angiogram to perform endovascular treatment, as was performed in this case with endovascular coil and onyx obliteration of the fistula. In this case, if you want to read all the details of it, is a published case in the Journal of Neuro-Ophthalmology. And so now you know, inside can be out. And I think there's some questions there, Such. I'll let you turn it back over to you.
Yeah. So did this patient have an ultrasound of the orbit?
They did, and it showed extraocular muscles were enlarged, but one of the tip-offs was that all the muscles were enlarged. It's not the typical order, which is, I'm so lucky not to have thyroid, inferior, medial, superior, lateral. They all seemed to be enlarged, and it was asymmetric between the two eyes because the SOV was markedly enlarged on the left side.
Okay. The coronal scan, the MRI doesn't seem to be showing thickened extraocular muscles. Am I right?
Yes. So the ultrasound has better resolution. So that's why it wasn't read out as thyroid eye disease, because it's just venous congestion. So the MRI, if you're just looking at it, you might pass it because it's so symmetric between the two eyes, but the ultrasound has got more resolution for size. So you're talking about 0.1 to 0.2 millimeter resolution versus 1 to 2 millimeter resolution on the MR. In addition, the original MR was head only and not really optimized with a FATSAT orbital MRI. So I don't really blame them that much, but you would have passed that. The SOV enlargement is the main finding.
Okay, Gordon has a question.
No comment, really. It's a really very useful case. The SOV is very special to us because it's part of our territory, but it is actually just one of the cranial emissary veins. And the characteristic of emissary veins is they have no valves, and the blood can flow and does flow and needs to flow in either direction, depending on posture and valsalva and all that kind of thing. So it's important to remember that there is normal flow in either direction. And the other point here is the lack of episcleral venous hypertension, because that's what really does the damage with the arterial based fistulas, and that's what causes the glaucoma, of course. And there is, in terms of management of glaucoma, there is no treatment for that. There is no other treatment than getting rid of it. And that's the sort of saving grace here for the patient, that they don't have that, and they don't have their dilated episcleral vessels, which we see. So it's a fascinating case. Thank you.
Yeah, to both your points, as you know, the lower extremity veins have valves, but that means we have no valves above the heart. And so that's the basis of the, danger triad. Don't pick your pimple right here, because it go right back into your cavernous sinus and get a cavernous sinus infection. But also, to Gordon's point, all the facial veins also no valves. So all the veins that were enlarged in her face. And this is like a wide-eyed venous connection. So her eye was not red. So sufficient collateral flow was diverting it away to prevent the IOP elevation, the glaucoma. The eye was not red at all. So you literally can have a vascular malformation or sinus pericranii and have a white eye.
Do we also classify these lesions as low flow and high flow?
Yeah, that's the main reason to do the arteriogram, is to establish that there is no arterial component. So this wasn't really an arterial venous malformation. It's what Gordon alluded to, which is there's this abnormal connection, but it's vein to vein, and it just flows the direction of the pressure. Wherever the pressure can go lower, it'll go that direction. It's just completely hemodynamically gradient driven. So it just flowed right out into her face and to the SOV.
So in the case of suspected thyroid eye disease, what would be the atypical features making us suspect something else?
Yeah, so I think this patient had many atypical features for TED, thyroid eye disease. It was markedly asymmetric. That enlargement of the SOV does occur in a thyroid eye disease, but it's rare. And the muscles weren't that big on the MRI, as you alluded to, only the ultrasound. And she didn't really have that much lid retraction. It was just at the superior margin. And so I think a lot of confirmation bias. You want it to be thyroid eye disease. You want it not to be something bad. But I typically will consider doing a standard catheter angiogram, or at least a CTA MRA on any thyroid eye disease, even if it looks like thyroid with SOV enlargement, because I'm worried about varix and vascular malformation. I wasn't really thinking about sinus pericrania, to be completely honest.
A word from Neil.
I've operated on a number of these over the years, and they can be much more complex than what you showed, Andy. And in the old days, before we had Onyx and some of these other drugs, trying to do something for these was really difficult. The bone is very pockmarked and very abnormal, some areas thick, some thin. But trying to either tie them off or occlude them was really difficult. But as you point out, the key issue in these cases is to make sure that there's no arterial supply, because then at least you have, as Satya said, it's really a low flow situation, and it depends a lot. Of course, the patients, if they lie down, sometimes things are a little bit easier, and then they sit up or they strain at stool or something, and they're really bothered by it. But the availability of these various compounds like Onyx has made life a lot easier in terms of treating these patients.
Yeah, I would just echo that point, Neil. She was about to literally go to orbital surgery, and that probably would have been a very nasty surprise for them. And if they had had any type of bleeding, or even just the incision, might have produced potentially dangerous, life-threatening hemorrhage because it's hooked right up to your superior sagittal sinus. So I'm impressed that you had operated on these in the past, but I was so happy to tell
I didn't say I liked it.
To cancel the surgery. So she not only didn't have to have surgery, miraculously her thyroid eye disease went away.
Yeah, the neuroradiologists, the interventionalists have changed the whole area of this type of lesion and obviously others.
Veena is here. Any comments, Veena? Meanwhile, Gordon, do you have a comment?
Dr. Satya, I have a question.
Yes, please.
Do all these cases require surgical intervention, or is there any specific indication you do surgical intervention in these cases?
Yeah, as Neil alluded to, Onyx and endovascular interventional radiology has totally changed this to a non-surgical thing. It's basically an endovascular procedure now, and she was cured on day one. I mean, it just cured it. So, and it's because it's venous and low flow, the risk is actually quite much lower than our arterial venous malformation closure. So this is completely slow flow venous.
The main reason to do something is generally cosmetic, and it just really drives the patients crazy. There's no pulsations or anything like that because it's venous, but the patients are very self-conscious about it. And as Andy pointed out, these are usually present since birth. So the person has an abnormal appearance. They've been teased in school. And so it really is very helpful now to have the ability to treat them.
I would just echo that little point you made in passing, that thyroid eye disease doesn't cause equal enlargement of all the extraocular muscles. I mean, that's such an important point.
So there's this question. So you have a child with a bluish lesion on the upper half of the face and no other neuro-ophthalmic signs. Would you neuroimage the patient?
Yes. So that bluish is the dangerous part. And of course, we wouldn't want them to cut on it without knowing if there's an arterial component to it. So that arterial component is the thing that drives the danger zone. And of course, retrograde is the other word we don't want to hear, and cortical venous drainage. So if we hear those words, retrograde, arterial, and cortical venous drainage, venous hypertension, these are bad words. So you can only see that on angiogram.
There's another point. I reviewed a paper recently, and they were talking about dilated conjunctival vessels in a fistula case. And to my understanding, there are only capillaries in the conjunctiva. These are episcleral vessels, and they also are important in this very peculiar condition, the radius Mormoni syndrome, which looks like a fistula, but there is no fistula. But they do get glaucoma, so it's a sort of idiopathic episcleral venous hypertension. But again, that's the point. It's the episcleral venous hypertension that is the real danger in terms of the optic nerve and so on.
Okay, so we had a very interesting case here, Andrew, and thank you very much for your presentation, and have a nice day.
Bye.
Bye. So we move on to the next presenter in our session, and that would be Dr. Hazel. She is senior consultant, neuro-ophthalmologist and cataract surgeon, a deputy head of ophthalmology at the National University Hospital in Singapore. She's also an assistant professor there, and she completed her residency and fellowship training at the National University Hospital in Singapore, and she practices comprehensive neuro-ophthalmology. Over to you, Hazel, to share your case.
Thank you, Prof, for the kind invitation and the introduction. Good afternoon, everyone. Today, I'd like to share a patient of mine with all of you. And this patient is 60-year-old Chinese male. He has a background history of a non-small cell lung cancer. And this was diagnosed many years ago in 2012 with a solitary T12 vertebral metastasis. At that point, he had undergone multiple treatment modalities. Firstly, surgery to the primary lesion, followed by chemotherapy, including cisplatin in 2012, radiotherapy to the solitary metastasis, and was kept for the next 4 years on gefitinib maintenance therapy. He was doing well with this, and periodically, he actually had surveillance scans to look up for any other new disease in other places of the body. And unfortunately, he was noted to have a left frontal lobe gyrus enhancement in 2015. Because of the enhancement, he underwent a lumbar puncture as well, and that came back with normal CSF. There was suspicion that that could have been disease, and hence his chemotherapy was initially switched to afatinib, followed by osimertinib because of a better CNS penetration. He had partial response on serial scans to this with reduction of the size of the enhancement by 30%. However, 2 years later, he actually had to switch chemotherapy again because there was some progression of the enhancement. And subsequently, the thickness of the presumed brain metastasis increased at the end of 2019. He underwent image-guided resection, followed by stereotactic radiosurgery to the cavity. And unfortunately for him, this was complicated by radiation necrosis, for which he underwent resection about 6 months after. The following year, he again presented with a new basifrontal lobe metastasis, this time noted by his primary oncologist, and he started undergoing 2 cycles of SRS in July 2021. He was referred to our center for consideration of gamma knife surgery because he then complained of blurring of vision, which was noted. He mentioned it before starting the 3rd cycle of his SRS. So he presents with a left eye painless progressive blurring of vision, and on further history taking, actually that began 2 days before his SRS. This was associated with dyschromatopsia, and at that point in time, he was already on some oral steroids of dexamethasone 4 milligrams once in the morning to treat the associated edema with the radiation. On clinical examination, he had slightly reduced visual acuity of 6.9 on the left, and his pupils, there was a grade 2 RAPD, and slower, he was reading the issue hierarchy much slower on the left-hand side. Otherwise, ophthalmic and ocular examination was unremarkable, apart from abnormal perimetry, which you can see on the right. The right eye was largely normal, but he had a visual field defect on the left, which was more prominent temporally. These were images of his fundus, including a fundus autofluorescence on the Optos imaging, which was unremarkable, and his macular OCT was also normal. So at that point in time, we were considering what differentials could be affecting him, knowing his complicated background history of malignancy. Our primary thought was that of an optic neuropathy, whether it could be cancer or his cancer treatment related. Was it an infiltration? Was it a new lesion or direct compression of the optic nerve secondary to his cancer? Was it due to the RT that took place in 2019 or any of his chemotherapy agents? Although with a review with his oncologist, nothing that was recent in the last 1 to 2 years would have raised a suspicion for an optic neuropathy and could have been a paraneoplastic phenomenon. If it's unrelated to his cancer, could just been really unlucky in having a second disease that's affecting him, something inflammatory or demyelinating, or even infiltration, or worst case, second malignancy. We also considered the possibility of a retinopathy in the case of a carcinoma-associated retinopathy. As such, we decided to proceed with repeat neuroimaging for him, including the orbits in the brain with contrast, and for serological testing after the MRI scan guided by the findings. We had also pre-planned for him a lumbar puncture and a visual electrophysiology, which would depend on the findings of the first 2 tests. So these are the images of his MRI scans. The top row shows the axial cuts, T1 with contrast, with fat suppression of the orbits. And there was no frank enhancement or thickening of the optic nerve all the way to the chiasm. Of note, there's a small area here in the middle slide, which we felt that could have been a little bit brighter on the spot over here. But after discussion with several neuroradiologists, they were not convinced that this was an area of enhancement. So it was possibly maybe just a dural fold or even a vessel or possibly even artifactual. On the bottom row, the image on the left showed the metastasis for which he was undergoing SRS treatment for with slight surrounding edema. And the subsequent cuts shows that the nerve was largely normal. There was a large space between that lesion and the nerve. There was no direct compression or anything that was causing the nerve to be infiltrated. So we proceeded with the visual electrophysiology, which showed that the presence of delayed pattern VEP on the left eye with a fairly normal functional flash VEP, and his pattern ERGs, both of the standard and extended fields, were also normal, suggesting no retinal ganglion cell dysfunction. His full field ERGs, both dark and light adapted, were also normal. And so the conclusion was he just had a left optic neuropathy with no retinopathy. At that point, we didn't have a diagnosis. We encouraged him to undergo a lumbar puncture for further evaluation. We also did serological testing for potentially any inflammatory, infective, or infiltrated disorders. We're hoping that maybe, we imaged him a little bit late. We don't see the signs anymore, but could we try and find something from the blood test? The preliminary test came back negative, and he was not keen to proceed with any lumbar puncture. So his primary team decided to increase his dexamethasone to 4 milligrams twice a day, and this went on for 2 weeks. And he actually responded very well. As you can see, his visual acuity improved. Ishihara plates, he was reading very briskly. His visual fields, he felt almost completely back to normal. He felt good about it. And his repeated scan actually showed reduction in size of the frontal metastasis. Subsequently, he tapered and stopped the dexamethasone, but within close to just about a week to 10 days after, he again presented with the same symptoms of blurring of vision. His visual field defects started recurring again, and his radiation oncologist actually restarted him on dexamethasone 2 milligrams once in the morning. That wasn't enough, and during the course of the month, that had to be increased to 4 milligrams twice a day before he actually did not have a decline in his visual fields. We were urging him to undergo further treatment, but he was still, further investigations, but he was still not keen to have anything invasive. So towards the end of the month, unfortunately, he suffered from side effects of steroids. He was getting more Cushingoid. He was having sleep difficulties. His blood sugar levels were getting a bit out of control, and he opted to taper and stop his steroids. Again, we tried to convince him to undergo a lumbar puncture, but he was still not convinced. He said, no, I think I don't want anything done at this point in time. I'll just accept that my vision is not going to be good. Hopefully, it just remains at this level at this point in time. Serological testing, more tests came back. By then, everything that we had sent for, including CRMP5, anti-recoverin, everything was negative. We didn't know what we were dealing with. He didn't want anything else of that to be done. And what came to our surprise was a few days later, he walked in and he said, okay, I really can't see now. I think I'll accept it, and I would like to go for the lumbar puncture. So we, over the course of the next 10 to 12 days, we tapered and stopped his dexamethasone. We wanted to establish a new baseline for him, as well as give ourselves and him the best chance of obtaining a CSF sample that hopefully will give us an inkling of what the diagnosis would be. A repeat scan that month, this was 2 months later, actually showed almost complete resolution of the frontal metastasis. And at that point in time now, the radiologists were a little bit more convinced there was a small spot of enhancement close to the chiasm on the left-hand side, both on the coronal as well as the axial cuts. So immediately after his scan and his lumbar puncture, we had a discussion with the neurologist, his primary oncologist, and a radiation oncologist, and with him. And he was very keen to resume some steroids at that point in time, because he said, "Okay, let's try some steroids, and hopefully it can buy me some time, and that maybe you get some answers by then for a more definitive treatment." By then, his vision had dropped very significantly to 660 centrally, and he could not read any plates on the Ishihara testing. Subsequently, he had a tapering of steroids. He had some visual improvement, but as you can see, that the visual fields did not return as well to the baseline months ago, despite him having very high dose steroids at this point in time. Investigations finally returned. The CSF findings revealed atypical cells consistent with the adenocarcinoma that was seen. The other findings were all negative. There was no evidence of any lymphoproliferative disease. And after tapering his dexamethasone, he actually had targeted therapy directly to his optic nerve to prevent disease progression. Unfortunately for him, he ended up with no light perception of his vision, although transiently he had a little bit of improvement during his RT, but that was not sustained. Following multiple team discussion, there was no further systemic or intrathecal therapy recommended for him for his metastasis and optic nerve infiltration. Steroids, as we know, is not a great long-term recommendation, and immunomodulators or immunosuppressants, other than steroids, were also not recommended in view of his health, and did not want them to affect any of his disease and his other treatment modalities as well. A trial of radiation therapy was given to him for the left optic nerve. Unfortunately, he did not come back for further ophthalmic follow-up and suffered from further complications of his metastatic disease and passed away 6 months later. Thank you.
Okay, that's great, Hazel. That's a wonderful case. Patient has had to undergo multiple episodes of complications related to the primary disease. However, he has had significant longevity in these post first surgical treatment that you mentioned. Are steroids also given along with stereotactic radiosurgery to prevent an optic neuropathy when the lesion is close to the optic nerve?
So in this case, the steroids were not given primarily to prevent the optic neuropathy, but I think it was meant for the treatment of likely surrounding edema that will come, which is expected with the radiation.
Okay.
And it was intended actually at that point in time for him to undergo a very short course of low dose of dexamethasone. Hence, I was only on it for once a day when he presented to us.
And I presume he had fractionated stereotactic radiosurgery.
That's right. That's right. Yeah.
Why were we not able to continue steroids in his case?
He was already suffering from a lot of side effects. He was very Cushingite. He started developing steroid-induced diabetes. It was interfering with his sleep, and even was getting gastritis as well, despite PPIs given to prevent any gastrointestinal complications. We also were not keen for him to have steroids in the long term, because it's also known to affect the treatment of non-small cell lung cancers, according to the oncologist, and they did not feel it would be beneficial for him in the long run just to preserve the optic neuropathy.
Because the other condition which I can think of is a giant cell arteritis, in which we need to continue long-term steroids, even though the patient may have side effects which can be managed, because it is a primary factor that we need to protect the vision. In this case, was there any possibility of a cancer drug-induced optic neuropathy?
So we considered that as well, and I think apart from cisplatin, which was given to him several years ago, nothing that was recently given or is known to at least cause an optic neuropathy based on his drugs. So
we needed to stop the steroids, but would any immunomodulators or suppressors help suppress the optic neuropathy?
So for this, I actually sought the help of the internal medical specialists, a neurologist and a rheumatologist. We had this discussion because we said, something probably, we're wondering whether it would help, as you said, but I believe the primary problem now is that the cancer cells were infiltrating the nerve, and the steroids were likely just a temporizing measure, as you can see from the repeated, as we repeated his fuse down the line, and even with higher dose steroids, he never really quite returned to baseline. So although it was not evident on the scan, it was possibly the steroids were probably treating a bit of edema associated with the infiltration, and that was helping to hold back the disease a little bit, and helping to preserve the visual fields for a short period of time. So they were not very keen on immunomodulators, because it didn't really fit a disease category of any of the other known infiltrative or autoimmune diseases as well, which would be difficult for them to follow up, and they were afraid it would interfere with his primary chemotherapy.
Any intrathecal anti-cancer therapy would have helped this case?
According to the oncologist, nothing.
Okay. Dr. Gordon? Are you there?
Yes, it's a really, can you hear me?
Yes.
It's a really, really interesting case. I'm just wondering, I don't know what the panel think, whether actually this may primarily have been leptomeningeal involvement of the optic nerve rather than infiltration. Certainly, the nerve wasn't thickened or looking abnormal itself on the scan, and I haven't seen quite this steroid responsiveness with that. And also the way the visual field was involved, periphery of the visual field was involved predominantly and early. So I think the clinical presentation and the response to steroids, perhaps this was more leptomeningeal than optic nerve infiltration. What do you think, Neil?
Yeah, I had the same question. When you see a lesion in that location, Hazel, you mentioned that it was near the chiasm. Actually, it was right at the end of the optic canal. And I suspect that this was around the optic nerve rather than infiltration, but there's no way to know. What's fascinating is how the frontal lesion dramatically responded, and yet whatever was around or in the optic nerve, which supposedly was tumor as well, didn't. But you don't have, the canal is very unforgiving. And so whether it's around the nerve or in the nerve in that area is really difficult.
But everything was responding to steroids initially, including the visual loss. No, it's quite remarkable.
So would you have continued steroids even then, even though there were side effects?
Are you asking me?
Yes.
Well, what I have done in this situation is not situations like this in very, very general terms is give intermittent IV steroids, because you can do this without many of the long-term effects. So maybe a weekly dose of IV methylprednisolone, something like this, or 2 weekly. Sometimes you can keep things like this under control without running into problems with the corticosteroids for longer if you do that. That's my only suggestion.
Yes. And perhaps are we having a combination of radiation-induced optic neuropathy along with the infiltration here? Hazel?
Well, we wanted the same. I mean, the last SRS, the last treatment to the previous frontal metastasis was in 2019, so that was about 2 years, quite within the time frame you could expect for radiation optic neuropathy. But we had a discussion with them. They said that, you know, it's probably very unlikely because the radiation field was really small at that point in time, and it was quite far away from the optic nerve, so they didn't really think so, although it was definitely something we had considered.
Any other questions here?
Actually, I have a quick question for the panel. If I'm just wondering, you know, what could we have done anything else earlier before he, you know, his vision really went back so badly down to 660 at that point in time? Was there anything else we could have done to perhaps arrive at the diagnosis a little bit earlier?
Yeah, so
the CSF.
Yes. CSF, yes.
Yeah, which unfortunately he was reluctant.
Yes.
Yeah, and also the CSF is very good for excluding a paraneoplastic problem, because then you get evidence of inflammation. And before we had whole body PETs and so on, which, I mean, obviously you already know you've got a cancer, usually we have a potential paraneoplastic syndrome. We don't know that there's a primary, so we do a whole body PET, and that's although you have to be careful because they often miss out various bits of what they call whole body is not what we call whole body. They often miss out the lower legs and lower bit of the legs and things like that. But before that era, we used the CSF all the time, because there's always some evidence of inflammation, lymphocytes, etc. So I think that would have helped early on here.
Hazel, could you go back to the MRI scan, the first scan itself?
Because also, you know, these cells are trafficking. If you have leptomeningeal disease, these cells are trafficking through the CNS, and you will find them in the CSF, which you don't necessarily do with discrete metastases.
So Veena, who is a neuroradiologist, in the panel right now says that it was present in the first scan as leptomeningeal itself.
Over here, will it be the spot here?
Veena, are you there?
Satya, yeah, Satya, can I comment?
Yes, please.
Yeah. So if you have these optic nerve involvement, especially in the canal level, whenever you're studying the optic nerve, it's always better to see them in both planes. And if you see the canalicular segment on the lower right most, you can see it's the cranial end of the canal, and you can see the enhancement compared to the right side.
Okay. Yes.
Then there is a dural enhancement in the paraclinoid region.
Yes.
Okay, so it's almost contiguous.
Yes.
Thank you.
And in the follow-up scan, if you see the intraorbital optic nerve, it is showing enhancement of the sheath, the subarachnoid space and the sheath. Yeah, you look at the previous one.
This one?
No, this is the last one. There's one in between.
One before. This one.
Yeah, so you look at the intraorbital nerve here on the left side, lower, you can see the very slight enhancement around the nerve.
Okay.
So that indicates that there is some kind of leptomeningeal disease going on.
Okay. Any other questions?
You know, so that also fits very well with this peripheral involvement of the field, you see.
Yes.
Because even with compression, with a compressive mass, we expect to see the central field affected first, and it also is very important in terms of looking for retinopathy in this case.
Okay, so thank you, Hazel, for a wonderful case.
Thank you. Thank you very much.
To the next speaker now. And let me invite Dr. Carmen, who is the Chief of Service and Consultant Ophthalmologist at the Hong Kong Eye Hospital. And she is a clinical professor at the Department of Ophthalmology and Visual Sciences of the Chinese University of Hong Kong. Overall, she has published over 80 papers in peer-reviewed journals, and she is an editorial member of the Journal of Neuro-Ophthalmology, Asia Pacific Journal of Ophthalmology, and the Hong Kong Journal of Ophthalmology. She is the convener of the Hong Kong Neuro-Ophthalmology Interest Group, a council member of the Asia Pacific Neuro-Ophthalmology Society, and a member of the NANOS International Relations Committee. Over to you, Carmen.
So thank you, Dr. Satya, for the kind introduction. So let me share my slides. So we have a case of a patient with the long and winding diagnostic road. So this is a 55-year-old Chinese woman who is a civil servant. She first presented to our unit about 5 years ago. She was referred from an outside ophthalmologist with left eye progressive blurring of vision for the preceding 2 years. This was an isolated symptom. She had no headache and no other neurological signs or symptoms. She was of good past health, except for hysterectomy for fibroid, non-smoker, non-drinker, and no relevant past ocular history. So at first presentation, the right eye was normal. The left eye had reduced visual acuity and color vision, and there was mild dyspallor. There was no abnormalities of the extraocular movement, and the facial sensation was normal. And this is what her visual field looked like. So, which is consistent with reduced vision in the left eye. So with unilateral optic neuropathy, of course, the first thing we do is imaging. So before we do imaging, we do the OCT as well. So the retinal nerve fiber layer is reduced in the left eye, especially temporally, and right eye was normal, but interestingly, the GC-IPL were reduced in both eyes. So neuroimaging was performed. This is the T1 weighted fat sat axial image of the orbit, which showed a mass at the left anterior clinoid process extending to the lateral margin of the left optic foramen. So it was reported as being likely meningioma. Therefore, with a compressive optic neuropathy due to meningioma, we proceeded to, the neurosurgeons proceeded to do a craniotomy, optic canal decompression, and also subtotal removal. Intraoperatively, they found there was a lesion encasing and infiltrated to the left optic nerve, adherent to the left ICA. There was also a lesion around the left third nerve lesion, extended along the plenum en plaque to encase the right optic nerve as well. And they were not able to remove it completely, and there was residual lesions on the left optic nerve, left ICA, and left third nerve, and the lateral side of the right optic nerve as well. So interestingly, the histology came back as saying there was no monoclonal proliferation of B cell or T cells. The Zeal-Nielsen stain and the AFB stains were negative. They also did immunoglobulin and T cell receptor PCR with no clonal rearrangement, which indicates polyclonality. So the conclusion was that they were reactive cells, and there was no evidence of lymphoma or meningioma. So because of that, they were obviously curious as to what this could be. So extensive systemic workup was done, including the basic bloods like CBC, renal liver function, ESR-CRP, lactate dehydrogenase, which is sometimes raised in systemic lymphoma. The IgG4 was repeated a few times, which has remained negative. All the autoantibodies were negative. Protein electrophoresis was normal. A whole body PET-CT scan showed no hyperbolic metabolic foci. And she underunderwent an extensive microbiological workup, which was negative for HIV, Hep B, Hep C, syphilis, and a whole host of other things, which I can't even pronounce. And they even did stool microsporidia, which is beyond my imagination. EMU, AFB, TB PCR, IGRO were negative, and the CMV PP65 was negative. So the working diagnosis was lymphoplasmacytic-rich meningioma. So she received no further treatment apart from the neurosurgical decompression, and she felt better with traditional Chinese medicine only. So immediately postoperatively, the vision was not much different from preoperatively, but it spontaneously improved after decompression 4 months later. So the visual acuity returned to 20/30, and the color vision also improved as well. And so did the visual field, which improved remarkably in the 4 months post-operatively. So all good and well, except there was progressive thinning of the retinal nerve fiber layer on the left side. So perhaps, well, at that point, we thought perhaps this is just a delayed effect, and we remove the compression anyway, and let's see what happens. So in the ensuing 2 years, she had no specific treatment except traditional Chinese medicine, and her visual functions remained stable, and she was quite happy. So, however, as we monitored her, there was gradual deterioration of the retinal nerve fiber layer thickness in both eyes, especially in the left eye compared to the right, but both were deteriorating. So what happened next was that at that point, you may remember that we were all in the middle of COVID, and at that point, without COVID vaccination, you could not leave. Well, you could not, in fact, go out in Hong Kong. So so everyone had to have a COVID vaccine, unless you can obtain exemption certificate. So she asked me for many times, and I refused to give it. So eventually she had it, and 1 week later, lo and behold, she had presented with both eyes photophobia and left ear tinnitus. And to be honest, I was really suspicious at that point. So indeed, the right eye visual acuity decreased to 20/50, the left eye the same, and both eyes, the Ishihara was underwent slight deterioration, as so did the visual field. In fact, she had an MRI not long before that, and on the MRI, 2 years later, it still showed left optic canal and optic nerve involvement. In addition, by then, she had left internal auditory meatus and also cerebral pontine angle involvement. So perhaps her symptoms were not all imaginary after all. So the management plan was, first, we need to consult ENT for the left IAM involvement, further workup, including blood and repeat LP, lumbar puncture, and also start steroid after lumbar puncture. So ENT assessed her and performed pure tone audiometry, which showed some left high tone loss, otherwise was fine. Serum IgG4 was normal again. And the LP was done, which was non-contributory once again, with predominantly lymphocyte count, but the protein and glucose were normal. And the patient declined steroids due to some subjective spontaneous improvement. So 6 months later, she had a repeat MRI. At that point, the distal intracranial and intracanalicular segments of the left optic nerve became more swollen, and then the plaque-like enhancing lesion along the posterior aspect of the left petrous apex showed similar appearance, but there was now new plaque-like enhancing dural lesion at the middle of the anterior cranial fossa behind the crista galli. So at this point, the working diagnosis changed to idiopathic hypertrophic Pachymeningitis. So at this point, despite the progression on MRI, in fact, she was quite asymptomatic. The right eye 20/30, left eye 20/20. Right eye Ishihara was full, left eye Ishihara slightly impaired, and the visual field was almost normal. So at this point, we have an audience response question, but I was told that we can't do the poll. So what should be the next step in her management? 1, radiotherapy, which was recommended by an outside neurosurgeon. Number 2, repeat biopsy of the MRI lesions, which was recommended by our own neurosurgeon. A diagnostic trial of steroid, because of course no one should go blind without trial of steroid, or continue with traditional Chinese medicine, which has worked in the past, in the prior 3 years. So Dr. Satya, are we allowed to have some, to get the response from the audience, or shall I move on? Or anyone from the panel who might want to recommend something or type in the chat box.
Dr. Chan, do you think the first at the first MRI itself, on the MRI, it was a bilateral involvement rather than a unilateral involvement?
I think, to be honest, that that's what the radiologist only commented on this lesion there. But of course, with the abnormal OCT on the right side, there must be something there as well. So
there's abnormal enhancement around the anterior clinoid on the right side.
Yeah. So something missed by our radiologist at that point. So Dr. Plant, who has put up his hand, and Dr.
I have a question.
Yes.
Ina here. Did you do the immunohistochemistry?
On the brain biopsy?
Yes.
No. Or they did something, but it was non-contributory.
Okay, could this be a Rossi-Hoffman was my question.
I think that's certainly one of the differential diagnoses, yes.
And I think a review of that previous biopsy, by somebody would help.
Do we have the picture, the slide of the previous biopsy?
The previous biopsy.
Yeah.
Only one biopsy was done.
Yeah.
I don't have the slides to show you.
Yeah, I was going to ask the same thing about Rossi-Dorfman, which is it's another durally based condition.
Yeah.
which is often mistaken for meningioma.
Mm.
And we've had some unusual success in treating this recently.
So with Rosa Dorfman, what would you treat with? Immunosuppression or?
Well, in fact, all the cases that I treated did very badly. Is this relevant? I don't want to talk about Rosa Dorfman. It's not relevant.
Okay. Well,
steroids as well as radiotherapy work for Rosa Dorfman, but the histology is so different from meningioma. You have the emperipolesis that's really quite obvious with these macrophages eating up the lymphocytes. So I wouldn't think that a competent pathologist would miss the diagnosis.
I agree, but I think it can happen.
Yeah.
It's just the durally based nature of this, and if it's that's all. That's why I mentioned it.
Since the vision was not markedly affected, we could go ahead with the biopsy first, because if we give the steroids, then the pathology would get altered.
Yeah, I definitely agree with another biopsy. I'm sure Neil does as well.
Yeah, I do.
Yeah. Okay, so let's see what happens next. Okay, so that was what we would have recommended her to do, but she refused a repeat biopsy, but was happy to have a diagnostic trial of steroid. So what happened was, so it was started on 1 milligram per kilogram. She's quite light, only 50 milligrams. Over 4 months, it was tapered off, but by the end of the 4 months, in fact, her vision almost returned to normal, together with the visual field and her color vision as well, which is well, very steroid responsive. So I was almost afraid that my case would overlap with Hazel's case. Anyway, so what happened next was, in the next year, she received no further specific treatment apart from traditional Chinese medicine, but then she experienced very slow, gradual deterioration 6 months after being steroid was tapered off, and then eventually she had a repeat LP, which was once again non-contributory. So at that point, she had a repeat MRI. So in fact, the anterior cranial fossa, left CPA, left IAM, left optic nerve involvement were all similar to the last scan done in 2022, which was before the first course of steroid. So despite this, despite a similar appearance and her quite preserved visual functions, in fact, it was very worrying that there was progressive optic atrophy as evidenced by the reduction of OCT RNFL in both eyes. In fact, the left eye has gone down to 55 and 56, right eye 80. And as we know from our previous publication with Dr. Miller, in fact, and that eyes with no light perception vision from non-glaucoma to optic neuropathy has an OCT RNFL thickness of about 55 on the serous OCT. So this is getting quite dangerous. Okay, we have our neuroradiologist would like to make a comment. Dr. Veena.
Yes.
Or perhaps if not yet, perhaps I'll finish the case and I'll let you comment a bit more. Okay.
Finish.
Okay. So at that point, 3 months ago, we thought, well, it worked last time, so why don't we do it again? So we did. So we put her on a second course of oral steroid. And now when earlier this month, when I assessed her again, in fact, she had almost intact visual function. So 20/30 vision in both eyes, Ishihara full, and almost a full visual field, despite established optic atrophy in both eyes. So so far, the plan is to maintain her, well, because she's doing quite well on just a very low dose of prednisolone, and because last time she relapsed 6 months after steroid being tapered off. So we're going to maintain her on prednisolone 5 milligrams, and then if there's deterioration, we may need to increase her steroid and start her second-line immunosuppressant. And to answer your very valid questions, in fact, we have requested a slide review for from the initial brain biopsy for IgG and IgG4 immunostaining in the original brain biopsy. So if it comes back positive or anything exciting, perhaps I could submit this to NANOS as a Walsh case in the future. So, and just to answer a few things on the chat box, yes, sarcoid can certainly do this. Sarcoid is very rare in Chinese patients, but not non-existent. And but in her case, they didn't show the granuloma on the initial brain biopsy. But I think we'll have a more careful look when we've got the slides. So I'm just going to spend a few minutes on the different entities that we talked about. The first one is the lymphoplasmocyte-rich meningioma. So it's a rare variant of meningioma, which is less than 1% of all meningiomas, which is characterized by a copious infiltration of polyclonal plasma cells and lymphocytes and some meningothelial elements. It's a WHO grade 1 meningioma. It can affect patients of any age with equal male to female distribution. And the symptoms depend on the location. Interestingly, they can have prominent peripheral blood abnormalities in 21% of the patients, like anemia or polyclonal gammopathy. I mean, this is the reason why she had a protein electrophoresis. But in her case, it all came back negative. So the treatment of LPRM is surgical excision, and recurrence after complete resection has not been reported. But the problem is it's quite difficult to completely resect the lesions because they have a tendency to stick to other lesions. Okay, and next question is, what is idiopathic hypertrophic Pachymeningitis? So for the ophthalmology residents in the audience, Pachymeningitis is inflammation of the duromater. Arachnoiditis is inflammation of the arachnoid, and leptomeningitis is inflammation of the arachnoid and pia mater together. So, so there are lots of causes of hypertrophic meningitis, Pachymeningitis. As you said, Rosai-Dorfman is one of them, but also IgG4 disease, GPA, sarcoidosis, as Dr. Miller pointed out, PAN, rheumatoid arthritis, relapsing polychondritis. But in her case, we have not been able to identify any of them. So, when we call it idiopathic, it has to be a diagnosis of exclusion. Increasingly, in the past decade, there's increasing association with IgG4 disease. Just a reminder of the IgG4 disease diagnostic criteria. So she does satisfy the clinical and radiological features, but she does not have a serological raised IgG4. However, serum IgG4 can be normal in localized disease, and we lack the pathological diagnosis. So we hope that by reviewing the slides, it will give us some answers. So so for IHP, the clinical diagnosis, the clinical characteristics, a lot of them have headaches and also cranial neuropathies like optic neuropathy, trigeminal nerve lesions, and vestibulocochlear dysfunction as well. And our patient has the optic neuropathy and also the hearing loss. So the diagnosis of IHP depends on the MRI, a dural biopsy, and also by ruling out other etiologies. Treatment consists of corticosteroids, and if they can't be weaned off corticosteroids, other immunosuppressants can be considered, including methotrexate, cyclophosphamide, and azathioprine. So that concludes my presentation. After acknowledge a lot of other colleagues, including those at Queen Mary Hospital and also at Queen Elizabeth Hospital with our friendly pathologist and a radiologist. So just before I finish, let me just put in an advertisement for the ASOS meeting in Hong Kong in December. So the abstract submission deadline is coming up very shortly. It may be extended for a little bit if you hurry up. And so we have lots of esteemed speakers, including Dr. Neil Miller as one of our keynote speakers. So thank you all. So I know that there are quite a few comments and questions. So,
Dr. Miller, would you like to comment?
Well, I think Carmen has said everything beautifully. It's a complicated case. We see these hypertrophic Pachymeningitis cases, and as she beautifully pointed out, that they can be idiopathic or they can be from a number of things. We reported a case of Pseudomonas Pachymeningitis some years ago. The recent, well, not so recent, recognition of IgG4, all important. I think the real issue is the pathology involved. And as Gordon said, in these cases, in many cases, you've really got to get decent pathology. The one thing I thought was really interesting was that you showed that was it facial nerve on the right side was involved? And that would be unusual for a lot of these cases. I mean, the Pachymeningitis is usually more peripheral, but I think in these cases, in many cases, you just have to go ahead and biopsy. In terms of treatment, we've tried all sorts of things, and it's like Gordon's point about the last case. Sometimes with Rosy-Dorfman, sometimes it works really well, sometimes not so much.
Dr. Gordon?
Yeah, I just wondered if this type of meningioma they were talking about originally, is there any evidence in the literature of this kind of corticosteroid response?
It's not supposed to be steroid response.
It's not supposed to be.
Well,
I mean,
but Gordon, that meningiomas can cause a significant inflammatory reaction, and they can respond dramatically to steroids. Think about we've had a number of cases, I'm sure you have too, where the neurosurgeons went in and removed a benign, grade 1 meningioma, and the patient had severe postoperative inflammation. So they actually can respond dramatically to, and we've had optic nerve sheath meningiomas that responded to steroids at least temporarily. So there can be some of the meningiomas. I don't know that it has to be the type that Carmen mentioned, but some meningiomas really incite a significant inflammatory response and can really confuse you as to what's really going on.
Yeah, I have seen that rarely, but we also use corticosteroids as a diagnostic distinction between meningioma and other things. The other thing about IgG4 to remember is that it's often elsewhere in the body. A case I was very much involved with, it was the first cavernous sinus biopsy I have ever, actually the last as well. The only cavernous sinus biopsy I've ever asked for was the first case of IgG4 diagnosed at Queen Square, but she already had it in the lungs. And she was a patient at the Brompton. They didn't have the diagnosis either, but do look at the rest of the body. And the peripheral levels are not very helpful. And you also have to remember that IgG4, it's a physiological substance. People with asthma have high levels. It's just the type of immunoglobulin that deals with a chronically present antigen. That's its physiological function, if you like, in pathology. So a lot of people can have high levels, and it's not very helpful. You do need tissue.
Ambika has a question. Would you like to speak out your question, Ambika?
I'll say it for her.
Okay.
Can IHC give added value like gamma globinopathies? Will they respond to the treatment?
What is IHC?
Hi, am I audible?
Yes.
Yeah. Did you get an immunohistochemistry after the protein electrophoresis or something with the biopsy? Yeah.
Protein electrophoresis, it was negative.
Ah, okay. So can a glomoglobinopathy present like this, which will respond to treatment, any light chain or anything abnormalities? Can they also present like that?
I'm not sure myself, but does any of the panel know?
You're talking about myeloma.
Yep.
It's usually extradural.
Mm-hmm.
I don't know what other people's experience is, but it's often extradural and causes its effects by extradural compression.
And involvement of the bone as well.
Okay.
Yeah. Oh, absolutely. Yes. But in terms of, I mean, for example, the first case I was ever involved with decompressing the sagittal sinus to relieve papilledema, that was a case of known myeloma who on his skull x-ray had a big hole right over the torcular in his skull. And the neurosurgeon removed this metastasis at my suggestion, and he said he just watched the sagittal sinus expand in front of his eyes after he'd removed it. So that's my experience is that with myeloma is its extradural involvement because that's where the bone is.
Okay.
This seems to be a nodular type of IHP, which is having multiple sites, both anterior and posterior. Some of the authors, they divide them as the anterior spread and the posterior spread. So this has both. So we'll have to wait for after the your histopathology slide is reassessed, and maybe then we'll have some cue.
Yep. Hopefully I can update you next year. Okay. So thank you very much.
Thank you, Carmen. Thank you, Meenakshi. So shall we proceed on to the next case in this session? And our presenter is Dr. Samira Irfan. She's a consultant pediatric ophthalmologist, strabismologist, an oculoplastic surgeon, and ocular surface diseases specialist in Lahore, Pakistan. She's a vice president of the Oculoplastic Society of South Asia, a member of the American Association of Aesthetics, and a Commonwealth Mentorship Program. She has 72 indexed publications, 4 books on strabismus and oculoplastics, and 12 book chapters. She has received several awards from SARC, UK SOS, and IESRF. Over to you, Samira.
Thanks very much, Dr. Satya. Thanks a lot for the invitation and the kind introduction. So I'll just share the screen. So what the mind does not know, the eyes cannot see. So my patient is a 29-year-old female who presented to us 6 months ago with loss of vision in her good right eye. The vision deteriorated gradually over a period of 4 to 6 weeks prior to presentation, accompanied by left temporal headache, and there was no pain.
Samira, the slide's not moving.
I'm still on the first slide. You didn't see the slide?
Only the title.
Oh. But it's
Doctor,
moving.
you're on first. If it's on first slide, it's okay. You want to shift the slide? You can click on the next slide, please, just to check. We are on the first slide. What the mind on the title slide?
So what do I do?
Just stop share and reshare, please.
Okay. Is it visible now?
Yes.
The second is visible now?
Yes.
Okay, I'll make it full screen. Is that okay?
Yes.
And it's moving now.
Okay. It's not moving to the next slide. It's on case history right now.
Yeah. So my patient is a 29-year-old lady who presented to us 6 months ago with the loss of vision in her good right eye. Vision deteriorated gradually over a period of 4 to 6 weeks prior to presentation, accompanied by left temporal headache. There was no pain in the eye, but a dull discomfort and heaviness. On inquiring about her general health, she was having intermittent low-grade fever towards the evening with loss of appetite and weight. She's had aches and pains in the muscles, but not in the joints. There was no history of dyspnea, cough, abdominal pain, or urinary symptoms. She was married for 7 years and had 2 healthy children. Her past medical history was quite interesting, that she brought a thick file of previous medical record. Can you see the next slide now?
Samira, we are not able to see your slides. Sorry.
Stop again.
Maybe send them as not as a slideshow, then they will probably move as a last resort.
Okay, I'll skip the slideshow. Is
Yes.
it okay now?
Yes.
Okay.
Can you move to the next slide? Yeah, that's fine now. Okay. Okay, good.
Okay. So she brought a thick file of previous medical record, according to which she was perfectly healthy till 2010, when at the age of 14 years, she developed bilateral upper eyelid swelling with ocular discomfort, heaviness, and drooping of both lids. There were no generalized symptoms at that time. She was seen by a general ophthalmologist, diagnosed as having bilateral lacrimal gland enlargement. As her symptoms were mild, she was only prescribed lubricant eye drops and no investigations were done. The swelling gradually reduced. A few months later, a painful ulcer developed inside the nasal cavity, along with a rash on the skin over the nose. She was given steroid cream by the local ENT specialist. This was followed by the collapse of the nasal bridge and broadening of her nose. Again, no investigations done. Then 4 years later, that is in 2016, she developed recurrent swelling of the left upper lid. This time she was referred to the oculoplastic surgeon, who found a mass on the median side of the left upper lid, along with moderate, non-tender enlargement of the lacrimal glands bilaterally. An excision biopsy was performed of the mass and a bit of the palpebral lobe of the lacrimal gland. The histology report read that the mass comprised of fibrocollagenous tissue with collection of epithelioid cells and multinuclear giant cells forming a granuloma with dense infiltration of lymphocytes forming follicles. There was focal necrosis present as well. The periodic acid shift staining revealed numerous fungal spores and occasional hyphae. The diagnosis of chronic fungal infection of the orbit was made. She was given systemic antifungal therapy for weeks, after which she remained asymptomatic for the next 3 years. Then in 2019, ptosis in the right eye increased due to lacrimal gland enlargement. Right ptosis surgery was done, along with lifting up of the prolapsed lacrimal gland. At that time, she had good vision in both eyes. In 2021, she developed gradual proptosis of the left eye with discomfort. No pain still. She was seen by the orbital surgeon, had an MRI of the orbits, but the films and the report were not present in the file. From the surgeon's notes, I could see that the surgeon had removed a large mass from the left orbit via an anterior orbitectomy. Biopsy report read a non-caseating granuloma with histiocytes and few lymphocytes. No fungal spores or hyphae were noted this time. She was given a short course of steroids, after which she was fine. After the orbital surgery, the droopiness of the left lid worsened. She had to manually lift up the left lid to see. Therefore, she managed with her life with the good right eye until the recent visual loss. So on examination, we have a young lady with complete ptosis of the left upper lid, with elevated left eyebrow as indicated by arrow 1, which means that she is trying hard to lift up the left lid but could not. The arrow number 2 shows deep upper lid sulcus, which means that the levator muscle has recessed far up into the orbit. Number 3 points to nodules, and which are non-tender and plaques on both the upper lids. And number 4 points to the broad and sunken nasal bridge with a hyperpigmented area extending on to the left cheek that looks like a butterfly rash with sparing of the nasolabial folds. And then looking up for her ocular motility, after lifting up the left ptotic lid, she focused with the left eye while the right eye became exotropic. As shown in the remaining pictures, ocular motility was reduced in both eyes in all direction of gaze, but especially in up gaze. There was absent convergence and inverse Bell's was present. So the likely cause of this total ptosis in the left eye with the restricted up gaze in the patient, I prepared the question for the audience, but I will answer that total third nerve palsy is unlikely because there is a movement present. It could not be a paresis of the upper division of the third nerve, which supplies the levator and the superior rectus, because in that case, the eyeball, the left eyeball should be should have severe hypotropia. But in this case, she could focus with the left eye after lifting up the left lid. So the most likely cause was a total ptosis due to levator disinsertion of the left eye, as noted by the high upper lid crease, deep sulcus, and absent movement, which was done during orbital surgery, while the absent vertical gaze must be due to a lesion in the midbrain affecting the up gaze center in the rostral reticular formation. And this is also evidenced by the light near dissociation and absent convergence. So on examination, her vision was CF in the right eye, but she was 618 after lifting up the left lid. Color vision was markedly reduced in the right eye. She has a mid-dilated pupil with RAPD, while on the left side, the reaction to light was small, but it was reacting to near. On examination of the cornea and conjunctiva, there were many punctate staining spots with reduced tear meniscus and reduced tear film breakup time. Shivers were markedly reduced. The pressures were okay. Fundus shows left swollen disc with congested vessels. The left one was okay. And this is a picture of the right disc. Left I couldn't take because she was unable to focus. So on retropulsion, which is a very simple test, I could feel fullness or resistance on gently pressing the right eyeball, which meant there is something pressing the eyeball forwards, though there was clinically, there was not much proptosis. So early proptosis can easily be confirmed on a CT scan or an MRI with the axial cuts parallel to the plane passing through the optic nerve head with the patient looking straight ahead. And 1/3 of the globe must be posterior to the interzygomatic line. As you can see in this MRI scan, there is a bilateral proptosis, while in the B picture, there is moderate right proptosis. So retropulsion test gives us a very useful information. So now our patient is a 29-year-old female with painless progressive optic neuropathy with orbital fullness, with history of recurrent granulomas in the orbit, bilateral lacrimal gland enlargement, and systemic symptoms. So the most likely cause of optic neuropathy was, I think, compression or infiltration with granulomas, since there were no acute symptoms and signs, acute inflammation or infection was ruled out. And there could be ischemic as well as toxic or nutritional element added to it because she wasn't eating well. She's had a fungal infection of the left orbit in 2016, but recurrent fungal infection in the right orbit remain unlikely in the absence of acute inflammatory signs and symptoms. So the first question was, why would a healthy young teenage girl develop fungal infection of the orbit? There must be an underlying illness that has sufficiently caused immunosuppression that wasn't looked into at that time. Could be TB or autoimmune disease or malignancy. Her problems started with bilateral lacrimal gland enlargement. So in a young person, these are the causes: infection, autoimmune disorder, lymphoproliferative or idiopathic orbital inflammation that have to be considered and ruled out one by one. And the diagnosis actually rests on the biopsy report. So the investigations that we did were focused on confirming whether this is inflammation or autoimmune disorder, excluding underlying infection, particularly TB, which is endemic in our part of the world, assessing optic nerve function and imaging studies. So the CBC is a very simple and important test, which is often underrated by ophthalmologists. It gives us very important information that from the red cell count, red cell morphology, and hemoglobin in my patient indicated microcytic hyperchromic anemia, which occurs in all chronic illnesses. On the other hand, if you find megaloblastic anemia with large-sized RBCs, they indicate folate or B12 deficiency as a part of toxic or nutritional optic neuropathy. The platelet count was slightly high, which also pointed towards chronic inflammation or autoimmune disease. The normal white cell count excluded acute or chronic infection, as well as leukemias, lymphomas. The differential leukocyte count also gave important clues. A normal neutrophil count excluded bacterial infection. Normal lymphocyte count again indicated no viral infection, lymphoma, leukemia, or lymphoproliferative disorders. Monocyte count was slightly raised, and it rises in chronic inflammations like TB, syphilis, autoimmune granulomatous disease, sarcoidosis. The monocyte to lymphocyte ratio is a strong indicator of TB before the specific TB test results are available. So in this patient, it was normal. Then we did both ESR and CRP. CRP turned out to be normal, but ESR was 67 millimeters. Now, the thing is that both are indicators of inflammation. CRP rises quickly, peaks rapidly within 24 to 48 hours, and then decreases quickly. So if you have missed that window, then you will have a normal CRP. But if you have checked ESR as well, which is an indirect measure of inflammation, it increases slowly and can take weeks to return to normal levels. Therefore, both must be done as they give useful information. We also did her hemoglobin A1C, just to rule out diabetes. So to test for TB, we requested the quantiferon gold test because it requires a single patient visit. It is not subjected to bias or errors associated with tuberculous skin placement and reading it. It is unaffected by previous BCG vaccination. Results are available within 24 to 48 hours. It came out to be negative. So regarding the autoimmune profile, we tested for the 25 IgGs as a patient could have multiple autoimmune disorders. The chest regarding imaging, chest X-ray was done to look for tuberculous lesions or hilar lymphadenopathy. It was normal. Abdominal ultrasound done for hepatosplenomegaly, lymph node enlargement, status of kidneys. That was also normal. The MRI orbits and brain, the patient did not bring the films, but we only had the photos. The OCT confirmed that there was swelling of the disc with congested vessels and there was an increased thickness of the retinal nerve fiber layer. I couldn't get it for the left eye because she wasn't focusing. So the MRI, I only had the report, and which said that there was a large intracorneal mass of 4 by 3 centimeter present in the right orbit, surrounding and displacing the optic nerve medially and causing mild proptosis. Another smaller lesion was noted in the left orbit, and a similar lesion in the posterior fossa. They were hypointense on T1 and hyperintense on T2, but unfortunately no films to prove that. So in view of the urgency of situation, my patient needed IV steroids to save the vision in her good eye. So once we had excluded acute infection like TB, syphilis, and diabetes, she was admitted to the hospital after consultation with the internist, and IV methylprednisolone was given 1 gram daily for 3 consecutive days, along with oral tetracortal 60 milligram daily after breakfast, along with omeprazole, vitamin D, and calcium, good diet, and topical lubricants to be continued for the eyes. And the patient was educated regarding chronicity of the disease, need to monitor steroid-induced side effects, maybe need for further immunosuppression and regular follow-ups. So the autoimmune profile came after 1 week. Their serum ACE was normal. Only thing positive was the anti-Sjogren syndrome antibodies. That was highly positive. The other tests for IgG4 or SLE or sarcoidosis were all normal. So my differential was that we have a young female with waxing and waning symptoms and signs, with nasal granuloma, with bilateral lacrimal gland enlargement, with Sika syndrome, with butterfly rash on the face, and with systemic symptoms and diffuse hair thinning. So they all pointed towards SLE, but there were no joint kidney problem, normal neutrophil count, which is actually high in SLE, and negative ANA titers. I mean, ANA is 99% specific and sensitive for SLE, and so is anti-double-stranded DNA. But the biopsy also did not relate to SLE, because in granulomas in the first instance are rare in SLE. And if there is an occasional granuloma, they have plasma cell infiltration along with vasculitis and thrombosis of small vessels. So none of these were present in the biopsy, which was done in 2021, which showed non-caseating central necrosis with epithelioid cells, giant cells, and lymphocytic infiltration. So SLE was safely ruled out. The next diagnosis was the granulomatosis with polyangiitis. The features suggestive of that were that there were recurrent orbital granuloma with the nasal granuloma, lymph nodes were enlargement. There were no lymph node, but the bilateral dacryoadenitis with dry eyes and hoarseness of voice. But absence of pain in the eye, no lung or renal involvement, and normal C ANCA and neutrophil count. Again, we went against with this diagnosis. And also in granulomas, in giant cell arthritis, granulomatosis with polyangiitis, the granuloma must have scattered eosinophils, which are diagnostic. My patient had lymphocyte infiltration. Then vasculitis and large areas of necrosis, they are also present in GPR, but they were absent in my patient. So I ruled this out as well. Third was IgG4 related disease, which is mostly in middle-aged to elderly and rare in children. Again, should be in the granuloma dense lymphoplasmacytic infiltration with fibrosis in a basket weave fashion and obliterative phlebitis. Also, blood tests didn't support IgG4 disease because of normal serum IgG4 with no eosinophilia and no raised Ig levels. So this was also discarded. And then finally, we had sarcoidosis. Now, the waxing and waning symptoms in my patient with recurrent granulomatous disease, with generalized symptoms, skin rash, and the histology, it matched with sarcoidosis. But there was no joint kidney involvement as yet. Serum ACE turned out to be normal. But again, it is very variable because it has a sensitivity of 22 to 86% and specificity of 54 to 95%. So it could be negative in a patient, normal serum calcium levels, no lymphopenia, but there were raised monocytes and normal chest X-ray. So this probably was the diagnosis, and therefore, the patient is supposed to be on long-term steroids. Patient is kept under close watch for the appearance of new symptoms. On the 5th day, after having systemic steroids, her vision started improving. By 8th day, she had 618 in the right eye. We requested a new MRI scan to note the response to steroids and if she needed further immunomodulation. But she was very reluctant. And so now we are considering biopsy of skin nodules during ptosis surgery for her left eye and performing a reticulin stain, which is diagnostic for sarcoidosis. So important thing is that these diagnosing autoimmune diseases is quite challenging. And because they are multi-system involvement and there is considerable overlap of symptoms and signs. Final diagnosis rests on biopsy of the granuloma, proper patient education regarding their recurrent disease is very important part of management because these granulomas can appear in any body part, any time in life. Systemic steroids they constitute a primary and emergency medication to save the patient's vision, but it's important to rule out tuberculosis, especially in our part of the world where it is endemic. Then diabetes, hypertension, especially in a young patient in which we are not suspecting, then it can flare up for a fungal infection and herpes. So all these things need to be considered and informed to the patient. Thank you.
Thank you, Dr. Samira, for a wonderful case and a very well given elaborate differential diagnosis. I would like to have a question. What was the presentation earlier as a fungal infection? Now the total picture sync. Why this total change in the picture?
Yeah, that initial episode happened in 2016, and she had pain in the eye, and the eye was swollen and inflamed at that time, according to the patient, and the notes in the case notes of the clinician. So this was now the picture was different. That the eye wasn't inflamed at all. It was a white eye, non-pain, no pain, non-tender, and only on compressing the retropulsion was positive, which indicated that something is pressing the eyeball forward, not allowing it to go back. And therefore, we did MRI and all the blood tests confirms that there is no underlying infection.
Would you take this as a compressive optic neuropathy with restrictive myopathy?
Yeah, compression, the granuloma is pushing the optic nerve and surrounding it and compressing it, yes, as well as causing ischemia. So yes, restrictive myopathy, I mean, I think at the time when she developed in 2016, the acute painful red eye, the left and with ptosis, I think at that time, the myositis can't be ruled out. Also, at that time, the underlying sarcoid granuloma could not be ruled out. She maybe had that at that time, but it wasn't diagnosed. So, and that caused the fungal infection to appear, causing immunosuppression.
So, having both the lacrimal glands involved, what is any comments on the status of the salivary glands?
Salivary glands, she was having dry mouth. So, of course, yeah. I think they were involved as well. She had a dry mouth. So they both go together. Why lacrimal gland involvement is common in teenage girls, because there is a hormonal imbalance, and then the tears are the main area where we are exposed to all kinds of antigens, and they react and they cause bilateral lacrimal gland enlargement. I get many patients, young teenage girls with bilateral enlargement.
So the last, my final question, what is the incidence of tuberculosis in your place?
Very, very high. I was looking at the WHO report. I think in India it's 25 lakh and it's on the top in endemic. And number 2 was China, then Philippines, then Indonesia, and 5th was Pakistan. We have about 15 lakh cases per year, new cases. So it's a lot.
Because any granulomatous lesions or caseating, the first diagnosis, what we think is a tuberculosis. So that's why.
Absolute. But this was non-caseating. So
yeah. So could you label this as an atypical presentation of sarcoidosis?
Not really. I mean, she's having this since 15, 14 years. And it appears sarcoidosis is known to be waxing and waning, and it can stay quiet for years and then appear in any organ. So I don't think it's atypical. It can affect any part of the body, and patient has to be informed that she should stay under follow-up. If any new symptoms appear, she should see us.
Okay, thank you. Any comments from other panelists?
Okay. If there are no other comments, thank you, Samira, for your interesting case. And do keep us posted on the follow-up of this case, which has such multiple clinical presentations at different times. Thank you.
Thank you so much. Thanks for the invite.
So let's move on to the next presenter, and that is Dr. Claire Fraser, who's a consultant visiting medical officer at Sydney Eye Hospital and Liverpool Hospital, also in private practice in Sydney. She is an associate professor of neuro-ophthalmology at the University of Sydney, Australia. She trained at the Sydney Eye Hospital itself and did fellowships at Moorfields and Emory Eye Centre. And she has specialized in neuro-ophthalmology, strabismus, and visual electrodiagnostics. Over to you, Claire.
Thank you so much, and thank you for the kind invite to speak today. So I'm just going to try to share my screen. Hold on. Sorry, it's just decided it's going to have a security problem and not let me share it for a moment. Just give me 2 ticks. Oh, I'm so sorry. We tried all of this before.
Meanwhile, any questions for Samira can be discussed in the chat.
All right, hopefully that should be allowed to share now. There we go. Sorry about that. All right, hopefully you can see my screen now. Is that working?
Yes, it is.
Lovely. Well, so this is a difficult case that we had through Sydney Eye Hospital. This patient was referred, she's a 31-year-old Australian lady who was referred with disc swelling from her optometrist, and she had a few months of blurred vision, no headaches, no tinnitus, but she had gained weight about 10 to 13 kilos in the last 2 years. She was on some perinatal vitamins.
Go to slideshow. We can't see the details.
How's that?
It has not yet gone fully to the... Can you stop slideshow and then do it again?
Sure, sorry about that.
We have a blank screen now.
Okay.
Okay, you have a Mac or Windows?
It's a Mac.
You've given the permissions, right?
Yeah, I just did the permissions.
Just make it full screen with once.
Pardon?
You need to make it full screen at the bottom. Yes, yes. It's not getting full screen. You've given the screen access, right? Not the particular window access.
Okay. Do you want to
Can
move on to the
you
next speaker while I fix this?
Yes, please, if possible.
Okay. Sorry about that.
Would you like me to run your presentation from here?
I've changed it since
Oh,
I
yeah.
gave it to you.
Okay.
So why don't you move on to the next speaker and I'll come back.
Okay. Let me do that then. The next session, actually, the speaker from the next session would like to start, Luciano. So Shikha, are you there? Can you introduce your panelists? And also, I'll first introduce Shikha. Give me a moment here.
Good evening, everyone. Great cases going on till now.
So I'd like to introduce now Dr. Shikha Basi. Is it visible? Okay. Dr. Shikha Basi is a director at the Arepuram branch of Shankar Nethralaya, Chennai, and she's also the deputy director of Neuro-Ophthalmology services at the same hospital. Her areas of interest are in OCT, in neuro-ophthalmology, optic neuritis, optic nerve head drusen. She is a member of the Optic Disc Drusen Consortium. She has been the organizing secretary for many national and international conferences in cataract as well as neuro-ophthalmology, with several talks in national and international meetings. She is the reviewer of several journals like The Eye, BMC, Neurology, PLOS ONE, and International Ophthalmology. Over to you, Shikha.
Thank you, Dr. Satya. With that, let's start the second session. And to do that, I'll share my screen. I'm not able to share the screen. I've been given the permission. Yeah.
Yes.
So are you able to see the full screen?
No, we have the slides, all the slides.
Now?
Now it's fine.
Yeah. So to start the second session, it's my pleasure to invite the panelists, to invite Dr. Revathi Ramesh. Dr. Revathi Ramesh is a senior consultant with Dr. Tony Fernandez Eye Hospital at Cochin. She had her education at Stanley Medical College in Chennai, and then she moved to Kerala, where she has worked in different private hospitals. She came to us at Shankar Nethralaya, Chennai, for her neuro-ophthalmology observership, and thereafter went back again to Kerala to Dr. Tony Fernandez Eye Hospital, where she is heading the neuro-ophthalmology department. Welcome, Dr. Revathi. Next, we have Dr. Digvijay Singh. Dr. Singh is a director at Noble Eye Care at Gurugram, and he is head of the ophthalmology department there. He is also affiliated to Narayana Super Speciality Hospital and also to Madhukar Rainbow Children's Hospital. His special interest is in neuro-ophthalmology, pediatric ophthalmology, strabismus, and glaucoma. And he holds to his credit 20 awards, 75 publications, 20 book chapters, 1 book, and 60 abstracts and proceedings. He has delivered numerous lectures in the national and international fora. And he is also the treasurer in the Indian Neuro-Ophthalmology Society
and he was also the, sorry about that, he was previously the president of YOSI, that is Young Ophthalmology Society of India. Welcome, Dr. Digvijay. Next, we have Dr. Veena Norona. Dr. Norona, as we all know, is a very learned, very experienced, accomplished neuroradiologist. She is a consultant at Shankar Nethralaya and has been there with us for more than 20 years. And she's also affiliated to VRR Scans. She has authored the Atlas of Imaging in Ophthalmology at Shankar Nethralaya. She has more than 21 publications to her credit. And she has also authored several chapters in ophthalmology, radiology, and neurosurgery books. She has given lectures in various national and international conferences. Welcome to the session, Veena. And with that, let's move on to the first talk of the session. And to give the talk, I'll have to invite and introduce Dr. Luciano Simao. Dr. Simao is an associate professor of ophthalmology, and he's also the head of Neuro-Ophthalmology services. He's affiliated to Faculty of Medical Sciences, Belo Horizonte, Minas Gerais, Brazil, and he has published some peer-reviewed articles and co-authored some books on ophthalmology for residents. He has given numerous lectures in national meetings. He is a specialty reviewer for ABO and also to RVO, and he's a co-founder of BRANOS, that is Brazilian Neuro-Ophthalmology Society. He has published the major series of neuro-ophthalmology patients profile of Latin America in the Journal of Neuro-Ophthalmology. Over to you. Welcome, and over to you, Dr. Luciano. Can't hear you.
Hello. Hi, everybody. I'd like to thank Satya and all the scientific committee for being here for the fourth time in this outstanding meeting. Thank you so much. So, the case of bite blinds refers to...
Luciano, sorry to intervene. Your audio is not very loud.
Not ready. Sorry. Hello. Are you listening to me?
You'll have to speak a little louder.
Okay. So we have a 50-year-old woman with rapid progressive of visual loss, and she also complained about right ocular pain with eye movement. She presented additionally by the second day of visual loss, paraparesis and also paraparesia. And her past medical history was non-relevant, including no recent vaccination. However, she had dengue infection with classic symptoms and 10 days before the visual loss bilaterally. Her past ocular history was relevant to glaucoma suspect. The medications, allergies, family, and social history are non-contributory. And here you have the last ophthalmic follow-up 1 month before dengue infection that revealed normal findings. However, her first neuro-ophthalmic evaluation 1 month after visual loss revealed no light perceptions bilaterally. The pupils were poorly reactive with dynamic mydrias with no RAPD. Futility was full, slit lamp exam and IOP were normal. However, her fundus revealed mild edema of the optic nerve of the optic disc 1 month after visual loss. And we have here a very interesting picture taken from a smartphone that shows optic disc edema with no cupping by the first day of her hospitalization. Here we have the OCT by the first neuro-ophthalmic exam that revealed increased retinal nerve fiber layer bilaterally with the normal GCL. And her first neuroimaging revealed the normal findings on MRI of the brain and orbits and also MRA. However, in a spine MRI, there was a cervical right T2 hyperintense posterior central region of the spinal cord, extending over C2 to C3 with no gadolinium enhancement. And by the second MRI done 2 weeks apart from the first one, revealed hyperintense edematous lesions in the optic nerves, but with no gadolinium. And here you can see the difference between the first and the second one scans. And also we can see that there was a sparing of both chiasms in the 2 scans, and no gadolinium enhancement was seen in these exams. And then our first diagnostic impression was that typical post-dengue fever NMOSD, as she had a severe visual loss with myelitis symptoms. Her dengue infection was confirmed by IgM and IgG positivity high titers. The other serologic markers were non-revealing, including a negative aquaporine IgG. CSF analysis was no contributory. Then she underwent IV steroids with no recovery of her symptoms. And then she followed up with the treatment with plasmapheresis and also IV IgG, but unfortunately she didn't have visual recovery, but a great improvement of cervical symptoms. And by that time she had the anti-MOG done, but it was negative. This year, there was an impressive outbreak of almost 5 million cases of dengue fever in Brazil, and it was estimated 1% of complicated cases. And here we have our town, Belo Horizonte, the capital of Minas Gerais state, that was considered the second state of more incidence rate of dengue fevers in Brazil this year. And dengue is considered the most frequent human arboviral infection serotypes due to serotypes 1 to 4. And the CNS complications are most frequently seen due to dengue virus 2 and 3. And the mean CNS disease onset is 10 days after dengue infection. And after a systematic review, the prevalence of CNS manifestations is around 10%, including transverse myelitis around 2%. And what is expected that longitudinal extensive transverse myelitis may occur much more uncommonly. Bilateral optic neuritis is expected in 10% of the cases. However, there were only 4 cases of NMOSD associated to dengue fever until now. And here we have the 4 cases. 3 of them are from Brazil, and the 4th one is from a Philippine girl that was seen in Canada. Only 1 case have the aquaporine IgG negative. The 3 others were positive, and 2 of them presented with longitudinally extensive transverse myelitis, and the other one brainstem symptoms, and the other one optic neuritis. And regarding the infections in NMOSD, some studies have proposed that the pathogen may induce the autoimmune system to produce aquaporine IgG by non-specific inflammatory stimulus or by another pathway as a molecular mimicry. But the precise mechanisms that underlie the antibody production and the blood-brain barrier damage and oligodendrocyte jury are really unknown. There are 25% of cases that present viral illness on clinical history before disease onset. And that's the reason that we cannot exclude that infections may trigger or exacerbate the disease in genetically susceptible patients. We have another MOGAD as a relevant differential to NMOSD. And The comparison shows that the visual acuity is initially impaired in both conditions, but it has a favorable course in MOGAD and not in NMOSD. The orbits MRI may show bilateral and longitudinally extensive lesions in both conditions, and the anterior optic neuritis is often seen in both conditions. We have also the spinal cord with severe lesions, and recovery most often seen in MOGAD than in NMOSD. And regarding the lesions load, we can see MOGAD with may see single or multiple longitudinal extensive lesion, and in NMOSD we expect single longitudinal extensive lesions according to the international diagnostic criteria. And here we have the brain MRI that might be neuromonopneuritis or myelitis presentation. And here we have the present case that presents with overlapping features between MOGAD and NMOSD. And besides the biomarkers were negative, the final diagnoses were more associated to MOGAD than to NMOSD. Here we have a very recent release of bilateral optic neuritis after dengue infection in Taiwanese man with the aquaporin IgG negative, but he also present no light perceptions in both eyes. The MRI showed bilateral optic neuritis, but the spinal cord was normal. And the last follow-up of our case revealed at least hand motion bilaterally, but the fundus revealed the pale optic disc with increased cup disc ratio bilaterally. And the OCT confirmed the decrease of the retinal nerve fiber layer and GCL complex bilaterally. The last neuro imaging of the patients revealed mild decrease of the lesions. And the last slide, I would like to show there's new hope that Brazil and other countries are fighting dengue with the bacteria-infected mosquitoes. The Wolbachia Aedes aegypti mosquito bites a dengue-infected person, and the mosquitoes with the Wolbachia blocks the dengue virus. And then the mosquito bites the other healthy person, that person doesn't get dengue. And what we said is that dengue cases declined by 69%, 56 drop in chikungunya, and also 37 reduction in Zika in the areas which Wolbachia mosquitoes have been used. So I'd like to thank for watching. Yeah, for the discussion. Thanks.
A great case. A rare presentation, very good case. Most of the things were very well explained. I would like to ask, we have the very learned panel and speakers in this session. My question to all of you, the speakers and the panelists, and Luciano, to you also, is that how often do we see a cup disc, almost like a glaucomatous optic atrophy in a case of neuromyelitis optica associated optic neuropathy?
Yeah, that's a very good question, because we expect an NMOSD, a great decrease of the cup disc, a great increase of cup disc ratio as is corresponded to OCT findings, and also after the visual function outcomes. But that was a very striking situation, because as MOGAD may offer less decrease of the retinal nerve fiber layers and also the GCL complex, even being a disease that the optic neuritis recurrence is very high, and we often see more preserved OCT findings in MOGAD than NMOSD and MS.
Yeah. So probably here we can like it tells us a lot about the like the pathophysiology of what probably has happened. It's a very rare case that you've presented, dengue triggered neuromyelitis optica. The phenotype is that of neuromyelitis optica. Both the optic nerves are affected and there is myelitis, though not a very long segment of the spinal cord, but the phenotype and the blood test, their serology is negative for NMO. What is this is what we would call probably the cavernous atrophy of the optic disc, right? So I would like actually Dr. Plant is there with us. His comments on what is usually this kind of optic atrophy. It's the kind of optic atrophy where the disc is completely cupped. It's a so usually we see it in toxic optic atrophy, this kind of deep cupping immediately, and also in probably giant cell arteritis associated when it's a very severe affliction of the optic nerve. Dr. Plant is there with us.
Yes, I agree entirely. I think it just reflects the severity and the short time course of the severe loss of axons, and certainly with something really drastic like methyl alcohol poisoning, you will see this. So I think that's it. It's the proportion of axons that are all being damaged simultaneously.
Any other comments?
Yeah, and as I told, as she had a past ocular history of glaucoma suspect, made that previous excavated cut disc radial may be something that doesn't favor the final outcome, as she had almost 0.5, 0.6 cup disc, and then unfortunately the very severe visual loss happened by the dengue virus. And then that's a weird situation that unfortunately I don't know if she gonna have more vision than hand motions, but at least she has a hand motion. By the first time that I saw her, it was very sad because she started complaining. Obviously, because of that, I was just okay in my house, and then I had dengue fever, and then in less than 10, 24 hours, I started decreased vision, and that was a very difficult situation. It's something that as we don't have the biomarkers positive in this case, I'd like to ask the panel if I may consider as a MOGAD case, seronegative MOGAD case, but the truth is that we ordered the MOG after the therapy, after the steroids, after the plasmapheresis and the IgG, and then it makes the possibility of being positive very low, and then maybe I'm gonna try to ask for another titer again, so that we can be assured that it belongs to MOGAD, because the first aquaporin IgG was done by the first day of hospitalization, but unfortunately MOGAD was almost 1 month after the onset of the disease.
I think it's worth thinking back to before NMO, when we had Devic disease, and it came in two varieties. It came in a post-infectious form, which was monophasic, but it also came in a relapsing form. And I think that that's what we don't know with a case like this. Is it purely monophasic, or is it going to be a relapsing disease? I suspect it's monophasic, actually.
Actually, she is monophasic until now, but she is on rituximab, and her next cycle of rituximab will be in September, maybe we can order the anti-MOG antibody test before that, and maybe we'll have some clue about the final diagnosis. But it's there a fact that it's very worthy to mention is that we have positivity of the MOGAD in only 40% of the optic neuritis with great optic disc edema. And then maybe you are facing a seronegative, a real seronegative MOGAD in this case.
There's a question in the chat whether it was the infective optic neuritis. I think Dr. Martinez has written. So to discuss the pathophysiology, this is very clearly, since it's looks like an immune mediated thing. It's an immune mediated demyelination. It's kind of a molecular mimicry against the myelin sheath. Our own, that's what I think. What's the panel's view on that? It's not the actually dengue arbovirus which has caused the optic neuritis. It is usually, I think long back, there were 4 papers of optic neuritis. All were almost bilateral cases, optic neuritis, no myelitis, associated with dengue. And they all presented around 7 days after the initial infection, and they were all thought to be immune mediated. So the same is happening here. I think it's unlikely to be the virus itself causing this problem.
Oh, I think so. We have seen optic neuropathy with dengue, but it's vascular. We see very little dengue, I have to say, but a case I was involved in was written up by Liz Graham, and it was a classic ischemic posterior optic neuropathy.
So in that case, Dr. Plant, I think it could be, Dr. Martinez could be right, because if it was a posterior ischemic optic neuropathy, then it has a more likely chance for the way the case has, progressed. It was a very devastating course and never recovered, and the kind of cupping that has occurred. I was also going to say that any vascular lesion is more likely to cause this kind of optic nerve damage. So,
well, that's right. But I think that as soon as you have bilateral simultaneous optic neuritis, then it's much more likely to be antibody mediated.
Yeah.
If it's truly bilateral simultaneous, it's much more likely to be antibody mediated.
Right.
And systemic antibody, because we don't see it in MS. So to get bilateral simultaneous optic neuritis in MS, you have to have 2 separate lesions occurring simultaneously in the 2 optic nerves. You can get chiasmitis, and then both eyes are involved. But yeah, it's just what was classic Devix, that it's bilateral simultaneous myelitis and optic neuritis. It's a systemic antibody.
That's a very nice point that you told, that there used to be a post-infective Devix. So it's classically fitting into that.
Yes, absolutely.
Yeah, I agree. As she had the first symptoms just 10 days after the dengue infection, she was quite good, and then everything just goes upside down. Yeah, unfortunately.
Any other comments from the panelists?
In many of these para-infections, especially para-viral infection induced autoimmune picture, what we see is a molecular mimicry, isn't it? The epitopes of the sides of the infective agent and the host, they're the same, and that is why the whole cascade of events happens. So the binocular or the bilaterality could be explained by this kind of molecular mimicry?
Oh, yes, absolutely. Yeah. But there's clearly some individual susceptibility to it as well, isn't there?
If there is a
Very rare
yeah,
for a start.
there is already an autoimmune mechanism in the host, then perhaps these kind of viral scenarios are possible in those patients. Could we explain why some patients are susceptible more than others?
So there is some kind of genetic predilection. He has shown that out of the 4 patients, 3 were from Brazil, right? So there is some kind of genetic predilection also. Okay, so with that, I think Claire is ready with her case. So we'll give a break in this session and we go back to the session 1. So over to you, Satya. So you may invite Dr. Fraser to present her case. Then
Claire,
we
you could share your presentation now.
Thank you. So I apologize for the troubles that I had before. So hopefully this one works now. Can you all see my slides?
Yes, that's right.
Perfect. That's great. Right. So this was a 31-year-old lady who was referred to us with disc swelling from her optometrist. She'd had a few months of intermittent blurred vision, but no headaches or tinnitus. She had gained a little bit of weight, 10 to 13 kilos in the last 2 years, and she was on some perinatal vitamins because she was hoping to get pregnant. Vision was normal, 6/6 N5 with full color vision. Her cranial nerves were normal and the anterior segment was normal. Unfortunately, we don't have fundus photography for her, but here's her OCT and her visual fields. She has quite swollen discs bilaterally with slightly enlarged blind spots on both sides. We did our initial workup for a presumed syndrome of raised intracranial pressure. Her blood pressure was normal. We did some basic blood tests, including a pregnancy test, which were normal. We did check her pregnancy vitamins to make sure that there was no vitamin A derivatives in them. They were fine. Her MRI brain and orbits with gadolinium showed features suggestive of raised intracranial pressure with dilated nerve sheath complex, partially empty cella. And her MRV was normal. And while she did have stenosis, there was certainly no thrombosis. That's what I mean by normal. But when we did her lumbar puncture, her opening pressure was 21, which is normal. However, she had very swollen discs with normal vision and the other features of raised pressure on her MRI. And so we made a presumptive diagnosis of intracranial pressure despite this lumbar puncture. She had a BMI of 29, and so we advised her to lose some weight. At 85 kilos, we advised her to drop to 75 if possible. She was started on Diamox 250 milligrams 3 times daily, gradually increasing. When we saw her back again, she'd had very little response to the Diamox dose, and she still had the slightly enlarged blind spot. She had managed to successfully lose weight. She'd done really well, dropping down to 77, and her BMI was now 27. She had no visual obscurations. She did have a high-pitched tinnitus since the Diamox, but none of the classic pulse-style tinnitus. She had no headaches except when she got a bit dehydrated. The OCT showed a slight increase, but the visual fields had remained stable with just the slightly enlarged blind spot. And the plan had been to increase her Diamox to 500 milligrams TDS and to advise her on some hydrolyte to help with the dehydration headaches. However, she then failed to attend our clinic for 5 months, and she returned 10 weeks pregnant off her Diamox. So we had a discussion about pregnancy planning during all of this and suggested that needed to be put on hold. And we had told her about the risks of medication in pregnancy, but this is unfortunately what had happened. And at this time, she now did have morning headache. Her vision was 6/6 N5 in both eyes, and the visual field still just showed the slightly enlarged blind spot, but her OCTs were continuing to worsen. I know that the OCTs aren't very reliable when you're looking at swelling, but the measurements there are sort of in the 400s, which is certainly very swollen. So we did a repeat lumbar puncture, and this time the pressure was certainly high, 35 centimeters of water. Her headaches did improve for 2 days after the lumbar puncture, but unfortunately then returned. By this point, we're now at the 12 weeks into her pregnancy, and after a discussion with her about Diamox and the potential risks, as well as discussion with her obstetric team, we restarted Diamox with the aim to titrate that dose back up to 500 milligrams twice daily. Unfortunately, the Diamox was causing some nausea and vomiting, and she was really only taking 250 milligrams twice daily, and her OCTs continued to worsen. So at this time, we wanted to refer her for consideration of some interventional management. She had worsening OCT and headaches. She really didn't feel that she was tolerating the Diamox very well. And while her visual field was being maintained, we didn't want to have to do anything urgently. So we thought an early referral into a hospital with capacity for interventional management was the most appropriate for her. So this is her at that time. You can see the nerves are looking really nasty on those infrared photos there. The nerve measurements are certainly getting worse. She had a repeat lumbar puncture initially, which was 25 centimeters of water, which gave some initial encouragement that perhaps the Diamox was having an effect, and the delay, we weren't seeing the OCT responding in time. The MRV was repeated again given the pregnancy to make sure there was no dural venous sinus thrombosis. Her blood pressure was rechecked and was still normal. And after discussion with her, it was decided that she would prefer to increase the Diamox and try again and push through the nausea a little bit rather than going straight to any surgical intervention at that time, as her fields were being maintained and she was watched very closely through this time. Unfortunately, despite this, her nerves just weren't responding. She had very swollen discs on every visit. She still had morning headaches. She just has the enlarged blind spots, so she's not dropping any vision at this stage, but now we're getting to nerve fiber layers up towards 500 on these measurements, and certainly to examine her clinically, the disc swelling is getting much worse. This is just showing that her fields are holding stable. So she had another lumbar puncture at this time. We're another few weeks down the track, and the pressure is very high again at 35. The scans were again repeated, and at this point it was decided that while she had not lost field, she did have headaches, and these discs were very much at risk of her starting to lose some vision. We really couldn't push the Diamox anymore, and she just didn't seem to be responding to it. And she did have a very thorough workup looking for any other causes of raised pressure that we needed to be aware of by checking the CSF constituents and the protein, the blood count, all of those were normal. Further imaging, down through the neck, down to the heart, that was all absolutely fine. So at this point, it was elected with the expertise at our institution that she would have an optic nerve sheath fenestration, first in the left eye, followed by the right eye a week later. And you can see here on the slide the arrows where she is fenestrated, and she does get a reasonable response with the nerve fiber layers starting to drop, and there is some improvement at this time. Unfortunately, I don't have the macular ganglion cell layer OCTs for you, but I can reassure you that they were fine, and this drop wasn't because she was becoming atrophic at this time. So this is how her nerves are looking now. They've kind of stayed this sort of almost champagne cork type appearance now at this time, but at least things are stabilized. Her headaches are better. Her visual fields have been maintained, and she's on a tolerable dose of Diamox, and we're sort of holding our breath at this moment, hoping that she will get through the rest of her pregnancy. But the questions that I wanted to ask, and I thought would be interesting to discuss, would be firstly, in her case, weight gain really wasn't an issue through her pregnancy, so we didn't have many room to move there. The fenestrations had been done. She was on the maximum tolerated dose of Diamox for her, and her vision was holding. But our question is, what should be the general advice for pregnancy? What are we going to offer if her vision does drop? Or what could we offer if her headaches become more of an issue? So in general, I really haven't had many issues managing IAH in pregnancy, and patients in clinical remission or stable with minimal papilledema often do really well and are very easily managed. And typically with a lady like this, we would like to get her in a much better position before she then tapered off her Diamox and then went through her planned pregnancy. But often if they're not well treated at the time they become pregnant or are newly diagnosed with IIH or raised pressure at the time of the pregnancy, they do seem to have this more aggressive course. This is from a paper by Dr. Sinclair and Dr. Molan, which is they look at the weight gain through pregnancy with some guidelines for the amount of weight that should be gained depending on your original starting weight. She was, you might remember, her body mass index was 27 when she started, so she was just in that overweight category and she was maintaining that normal weight gain. Serial lumbar punctures are something that we don't really like to do. I mean, this lady did end up having several lumbar punctures through this course, but it can provide some short-term treatment. And the recommendations from the guidelines are to use a cutting needle almost to induce a small CSF leak to keep some better control of the pressure. And it can certainly be useful in first trimester. And a lumbar drain is something that could be considered and perhaps could have been considered in this case, but our neurosurgical colleagues weren't particularly keen on this. We can't use topiramate in pregnancy because of the risks of congenital malformations. Acetazolamide in a study of 50 humans has been shown to be safe, but that's very small numbers. And in England, the guidelines certainly are not advocating for the use of Diamox, where I have seen some American literature where they do seem quite happy to use this. After discussion with her and her obstetrician, obviously this is, we did decide that Diamox was a reasonable option for her. In vision-threatening disease, optic nerve sheath fenestrations are certainly our local expertise. Lumbar peritoneal shunts would be the preferred shunting procedure in pregnancy, as the high intra-abdominal pressure in pregnancy may cause a ventricular peritoneal shunt failure, but our neurosurgeons really don't want to do this. While Sydney does seem to love stenting patients, they don't like stenting patients in pregnancy, obviously, because of the risk of anticoagulation during that pregnancy. There are some guidelines for headache management that we can use if this becomes more of an issue. So I thought it was just an interesting case to have some discussion about the management of IAH in pregnancy, and that in this case, we did use nerve sheath fenestration to good effect to keep her nerves safe while we hopefully get her through the rest of her pregnancy. And just finally, for her delivery options, there are really no good evidence either way for normal vaginal delivery versus cesarean section, and really that's based on obstetric requirements. So thank you very much.
Very well presented, Dr. Claire. And most of the points what are needed for management of IIH in pregnancy has been covered. But I would ask one question, and to the panelist as well as you. Why did we prefer an optic nerve sheath fenestration versus a shunt in this case? She had consistent headaches. Her vision was 6/6 when she revisited us at 10 months pregnancy.
That's an excellent question, and she was referred into a hospital with neurosurgical expertise, which we don't have at Sydney Eye Hospital for that reason, but the neurosurgeons refused to intervene. We were worried enough that these discs were very close to starting to cause her trouble, and we didn't want to have to do a nerve sheath fenestration on a Sunday night when she suddenly dropped her vision. So it was decided to do controlled fenestration in hours, and that's why it was planned that way. So it was mainly local expertise, and neurosurgical intervention was refused by the team.
So there's a question in the chat whether how well was her diet monitored, and was she checked for sleep apnea, and was she anemic?
They're all excellent questions, and we were checking her for all of these other causes of, syndromes of raised pressure or what could have been called pseudotumor all throughout. She did not become anemic. She did not become preeclamptic. Her blood pressure was fine. That's why she had the repeated lumbar punctures to check for, protein. She had the repeated scan. She did have repeated blood tests throughout. And so we were looking very carefully for all of these other things that could be causing her raised pressure. As I said, she started with a BMI of 27 and really didn't gain anything beyond the expected weight that are in that graph. She had been questioned about sleep apnea, and we used the stop-bang questionnaire, which has been shown to be sensitive in patients with raised pressure, and she scored very low on the stop-bang questionnaire for sleep apnea, but she did not have formal polysomnography.
Another question, how frequently can we ask for serial lumbar punctures in pregnant patients?
That's an excellent question. It probably depends on what your local people are prepared to do. I mean, we all know CSF reaccumulates within, I think it's 8 hours, which is why the guidelines recommend using a cutting needle to try to create a little bit of a leak that's going to give you a little bit of decompression for longer. This lady was getting them about every 2 weeks. But I'd be interested to know if the panel has done serial lumbar punctures more frequently than that. I see Dan shaking his head there. Gordon's got his brow furrowed.
And Dr. Miller says that serial lumbar punctures are the best way to ensure that the patient will not return.
That is very true. I would have liked a lumbar drain when we found the pressure of 35. I think to decompress her with a lumbar drain for sort of 5 days would have given her known low pressure, might have helped kind of reset the system. But again, unfortunately, that wasn't the preferred option by the rest of the team.
We used lumbar drains for an acute process, and they work really well, but usually it's just to, as you said, over the weekend until you can actually do a sheath fenestration. We would have done exactly what you did. We're always worried about foreign bodies in terms of stenting, and you can certainly do even a VP shunt in pregnancy, but obviously we're worried about that. I would just make a very, very basic point, which is it shows you that a single lumbar puncture doesn't necessarily tell you what the intracranial pressure is doing. I'm sure the patient had, and we did a study back in the 70s where we had a transducer, an epidural transducer, and you could see the pressure going up and down in patients with IAH.
I agree, Neil. I mean, we did, particularly in patients who weren't susceptible to IIH, we would always go to pressure monitoring because they may be having intermittent spikes of pressure and other things. I presume, Claire, you did image the whole spine.
Yes, we did. Yes.
Yes. And I've been very enthusiastic about lumbar drains, but there is one problem with them, that if the pressure is reduced very rapidly, then you get expansion of the venous compartment intracranially, and this can actually lead to thrombosis because of a relative stasis. But I think probably, I mean, I have seen it, but it's probably most likely in patients where there's an underlying thrombosis. I remember one case, I thought there was a thrombus in the region of the torcular. No one else agreed. The surgeons put in a drain, and this patient thrombosed her entire intracranial venous compartment, and she had a JAK2 mutation. So, nothing is without potential harm. But certainly, if you think there's any suspicion there might be a coagulation problem, then that may be a relative contraindication for for lumbar drains. Otherwise, I think they've been really helpful, and you can monitor the situation minute by minute, and it's just amazing to see the great bag of CSF there appearing. Yeah, we've saved a lot of people with that. People's sight, anyway.
Thank you for your comments. And just to answer some of the ones in the chat. Yeah, I mean, I agree that nerve sheath fenestration could be reserved until visual function deteriorates, but we did this because we didn't want to have to do it, you know, as I said, on a Sunday night. So, and with consultation with the patient, that's what she was consented for. And I completely agree with Neil that her first pressure was spurious. I suspect the 25 pressure was also incorrect. I suspect she was sitting at 35 and above for all of this. So thank you all for your comments.
That was a great case. Thank you. With that, we'll go back to the session 2, and we'll go to our second case. I have to stop sharing. Dan, I have to introduce you first.
Oh, sorry. Apologies.
Can you see my slide?
Yes.
Yeah. So to present our second case, I invite Dr. Dan Millier. Dr. Millier is head of the Neuro-Ophthalmology department, director of visual neuroscience group at Rothschild Foundation Hospital, Paris, France. He is also an adjunct clinician scientist at SNEC. And he has created an international consortium gathering more than 40 expert academic centers, BONSAI, that is Brain and Optic Nerve Study with Artificial Intelligence, which has been published in various journals, including the very prestigious NEJM, Neurology, Annals of Neurology, and Journal of Neuro-Ophthalmology. He has published over 250 peer-reviewed papers and textbooks in ophthalmology and neuro-ophthalmology. He has lectured at more than 200 medical and scientific meetings. And Dr. Millier is currently the co-editor-in-chief of the journal Neuro-Ophthalmology. So very happy to have you in the second session. Over to you, Dan.
Thank you very much for the nice introduction. Thank you, Dr. Satya and Shika, for your very kind invitation. It's a pleasure to be here and to see so many friends, even remotely. So it's interesting, Claire, I really enjoyed your case, and I think my case somehow connects well with that. I'm not sure if it's on purpose or not, but in fact, part of the diagnosis is in the title. So this is a story, a quite straightforward story in 3 chapters. Chapter 1 happens in Africa. This is a 32-year-old female who has no significant past medical history other than a gynecological problem, and she has an epidural anesthesia for fibroma surgery. This is uneventful surgery. When we looked back at what happened, she had just some standard anesthetic injecting a small amount, 20 milliliters, which is standard. And the next day, she woke up with very intense orthostatic headache, nausea, and a diagnosis was made, a post-dural puncture headache, which was quite severe. Chapter 2, we're dealing with a lady with post-dural puncture headache who now has been treated symptomatically unsuccessfully, and she undergoes an epidural blood patch. Again, a standard procedure, which went with no serious complications during the procedure. And we're going now to episode number 3, chapter number 3, when the patient comes to our institution. In fact, the next day after the epidural blood patch, she had floaters and blurred vision bilaterally. And this is how she presented. And you won't be surprised that there is a bilateral papilledema in the picture on the left eye. It's partially because she couldn't fix it very well, but also because there was obvious vitreous hemorrhage. So at this point in time, I would like to ask people in the audience how often, so you suspect there has been intracranial hypertension secondary to the epidural blood patch, but how many of you do you see vitreous hemorrhage in conjunction with papilledema? That was our first interrogation to start with. And she had some reduced vision, not dramatically, but although the epidural blood patch was extremely efficient, within hours, her headache, her very bad headache was gone. She started again to have headache, and she said, my headache has moved somehow. It has moved, it was in the back, and now it's more in the front. It's really a different headache. But interestingly enough, the remainder of the neurological and ophthalmic examination was with the normal limits. And this is the quite severe bilateral papilledema. And again, to show you the fundus at presentation, and you probably, so my question is, do you think this is really papilledema, not papilledema, or not only papilledema?
Neil?
Drew, I see you disagree with everything I'm saying. What do you think?
No, not at all. But I think it's interesting that it always worries me, as it does you, when you see a lot of hemorrhage, especially circumpapillary.
Right.
But the most common setting in which I've seen it is sudden elevated intracranial pressure. It just, and I've seen that when people have had CSF leaks and the ENT people go in, close the CSF leak, the pressure goes up, and you see papilledema with this type of hemorrhage. So that's what worries me. The other issue is, does a patient have some sort of blood dyscrasia or something of that nature?
Absolutely. So, hyperviscosity, that's one of our concerns, of course, or dyscrasia, as you say. But then we wanted to look closer, because I think there are not only peripapillary hemorrhages, as you say, but there are also some pre-retinal hemorrhages. And we wanted to look with OCT or what's going on there. And you probably agree that there is pre-retinal hemorrhage, there's intravitreous hemorrhage, that there's nothing surprising about this picture. This is with magnification. But this is the next image is the one that I really enjoy about this case, which is here. You can see there is clearly intraretinal hemorrhage associated to what we thought was bilateral papilledema. Anybody has a new idea now? I really enjoyed, Neil, your words about acute raise in the intracranial pressure, which must have happened. But what's happening in her retina? Gordon.
Yeah, I think I agree with Neil. I mean, the classic, of course, is subarachnoid hemorrhage.
Right.
Because there's a lot of people believe that Thurston syndrome is subarachnoid hemorrhage literally getting into the eye.
Right.
But this is not the case. It's just that the rise in pressure you get with subarachnoid hemorrhage is probably the most abrupt rise in pressure that can possibly happen under any circumstances.
Right.
And so it is just straightforward, very, very high, massive venous hypertension, very abrupt. And you can get, and of course with Thurston's, you can get vitreous hemorrhage, hemorrhages anywhere. And with regular papilledema, I am very unhappy about any hemorrhages that are off the disc with regular papilledema.
Right. I absolutely agree. I absolutely agree. I fully agree with you, both of you, in fact. So I think that's what we call this is bilateral papilledema with somehow a strange occurrence of Thurston syndrome after a blood patch. So what happened? I'm not sure I have the answer, but we try to understand. So the lady had an MRI brain, and she also had an MRV. She had no CVT. There was nothing wrong with her brain MRI once at our institution. But what was more interesting is this. She had an MRI of her spine, and you can see that there is leptomeningeal enhancement right where the blood patch was. And not only that enhancement, but on a T2, a sagittal flare T2, there is an interruption there, of course, but there's also edema which is quite strange. And interestingly enough, the patient did not have any neurological dysfunction. So we pursued, she had a lumbar puncture. The opening pressure was 44, obviously very high. There was a hemorrhagic appearance, full of plenty of red cells, white cells, proteins. And of course, we were very concerned that this could be meningitis or an infective process at the beginning, but all the workup came back negative and there was no sign, no signature for malignancy. So in the end, our hypothesis was that this was an epidural blood patch that caused intracranial hypertension. Now, there are some very rare situations where rapid intracranial hypertension, onset of intracranial hypertension can cause by themselves a Terson syndrome. Those are anecdotal, but they exist. But also, what I think is very interesting is that EBP, blood patch by itself, can cause a Terson syndrome. Now, do I have an explanation what would happen there? Did this patient had two different events, intracranial hypertension plus a Terson syndrome related or not? I do not really know. But in terms of therapeutics, the patient was treated with acetazolamide and did very well. She had no vitrectomy for her Tersons because we thought it was not enough intravitreal blood to be treated. And in fact, looking at the literature, there is literature, of course, about rebound intracranial hypertension after hypotension. This could be either spontaneous intracranial hypertension or any other cause of intracranial hypertension and blood patching. And as in our cases, the features of the headache have changed from hypotension to hypertension. Now, I think this is a quite remarkable paper by Jacqueline Leavitt and John Chen, who were on this paper. A patient who had bilateral, obviously, Terson syndrome without intracranial hypertension after a blood patch. And I thought that was quite a remarkable paper. There were a few papers describing Terson syndrome after injection of saline or steroids, massive quantities, more than 100 milliliters, and that's quite understandable. But having a Terson syndrome after 20 milliliters or 60 milliliters of blood, it is quite remarkable. And also, as I said, there are some situations, anecdotal situations, where a rapid rise of the intracranial pressure can cause an associated Terson-like syndrome. So under this regimen, the patient did quite well. She recovered vision. This is after 1 week. Subnormal visual fields, and she did great also in terms of the papilledema resorption. So Terson syndrome, neurologists are very curious about this. They don't know, read a lot about it. I think it's a curious thing, and as Gordon said, it is interesting how this concept has evolved. I mean, even New England publishes a case every now and there about this full-blown picture about a Terson syndrome, which is characteristic that there is a combination of pre-retinal hemorrhages, intraretinal hemorrhages, subretinal hemorrhages, and intravitreous hemorrhages. So Terson syndrome, as everybody in this audience know, everything in medicine has been discovered by French, including Albert Terson, who discovered and described this syndrome. And it is interesting because I'm of course very ironic because it's not true. The syndrome bears his name, but it was a German who in fact described it for the first time. Not a Brit, Gordon, I'm so sorry. And now what is interesting is that Terson syndrome was initially described as vitreous hemorrhage plus subarachnoid hemorrhage. And then little by little, that concept has changed. Because in fact, it's not only vitreous hemorrhage, but any sort of intraretinal, subretinal, preretinal hemorrhage plus subarachnoid hemorrhage has been accepted as equivalent of Terson syndrome, just as a cause of a massive increase of the ICP after subarachnoid hemorrhage. And now, in fact, today, this has even evolved into a different stage, is that any cause of ICP, including pseudotumor cerebri, can cause intraretinal hemorrhages, and this would be called, again, a Terson syndrome. So in conclusion, just to remind that, because we were so liberal about lumbar puncture, etc., and pregnancy, I think there was a nice connection with Claire's case. I think that blood patches are extremely frequent, but they can be iatrogenic, of course, and they can cause intracranial hypertension. They can cause Thurston syndrome by themselves without necessarily having papilledema. And intracranial hypertension, it's one of the major complications. Thank you very much.
Excellent case, Dan. Very nice case. I just wanted you described two situations. One is John Chen's paper where you can have without papilledema, Thurston syndrome with the blood patch, and the other one where you can have it with papilledema. So what's the timeline of this? Like how soon the patient presented with Thurston's? In both the situations, when it's a papilledema, how long does it take for the patient to develop Thurston's due to raised ICT, that is with papilledema, and compared to where where it's without papilledema, just the blood is all over?
Right. I think that the question is complicated because the rebound intracranial hypertension after intracranial hypotension can cause papilledema that can go unnoticed because the patients do not necessarily have new symptoms or undergoing a new ophthalmic examination. But Thurston's after a blood patch is in what I read, it's literally the next day. Papilledema, I guess it could take some time to evolve. But what I learned from this case is that injecting a very small amount, even 20, 40 milliliters in the epidural space, not even in the subarachnoid space, can increase the intracranial pressure to 65, 85, depending where it is measured. So I would say Thurston's, it's quite rapidly. Papilledema, I'm not sure, probably will take a bit longer. In this case, they were absolutely simultaneous.
Dr. Miller and Dr. Plant have comments, please. Dr. Miller.
Yeah, I just wanted to say that I think the critical thing here is the abruptness of the rise in pressure, and from the venous compartment point of view, it doesn't have to reach a high level if it's starting from a low level. It's the abruptness in change, and I think I don't know what you think, Neil, that we always argue about how soon papilledema can develop. If you think of disc swelling in other situations like vein occlusion and so on, disc swelling can develop very quickly in other situations as well. So I think it can in papilledema if the picture is right. But
in trauma, head trauma, papilledema can occur within a couple of hours. So I agree.
And so you have to think of the dynamic aspect of this, not absolute values. The other thing that people don't realize is that the epidural space is not a space. It is not a space. It is a potential space. So it's possible to inject into the epidural space, but it does not exist anatomically. So you're also actually, if you put a lot of blood in here, you're also actually producing quite a compartment syndrome in the spinal canal. It's very interesting to think about how the blood goes from there on. Whether how far it can travel, or does it remain relatively localized? But it is only a potential space, so I think it can remain quite localized.
Absolutely. Now, what we did not understand, I think that in our case, there was a dural breach, and obviously the fact that the CSF was hemorrhagic and also the composition, we think that the blood was directly injected into the CSF, in fact. And as you probably know, there are some rebound intracranial hypertension as a complication of intracranial hypotension, just because there is some bleeding in chronic cases. And just having blood in the CSF can cause rebound phenomena. Now, my question is, do you think there is a responsibility of blood being in the CSF space, although autologous, or is it just, as you say, Gordon, just a pressure phenomenon? I think, I don't know.
No,
This
I
is
don't
what I
think.
was going to talk about. It used to be said that this was extravasation of blood through the subarachnoid space, but I think the at least recently in the last 10, 15 years, it's a pressure phenomenon. The other thing that's evolved over time for those patients with Terson's that do have significant intravitreal hemorrhage, and some of them, I mean, you can't see the fundus at all. It used to be said that you just wait and it'll clear slowly, but I think our colleagues in retina more and more are doing early vitrectomies when there's really bad blood to prevent damage from the chronic vitreous hemorrhage.
There's a wonderful image in one of the early Walsh and Hoyts, Neil, which I'm sure you've seen, a post-mortem specimen, showing quite clearly the subarachnoid space around the optic nerve full of blood and the vitreous full of blood, and no communication between the two.
Right.
Yeah, I have that.
I think it's
I have
also
that
the
photograph in color from Dr. Walsh.
Oh, share.
All right.
Also, I think it's sometimes I mean, it's a very nice case you presented, Dr. Dan. I mean, the amount of blood that's there in the intracranial space is sometimes difficult to ascertain also, or kind of, I think, quantitate. So considering that it has trickled down the spine and has moved up, so that also could play a role in a sudden pressure increase. So both hypotension going to hypertension and the amount of pressure that has gone up. So I suppose that's another thing to look at. In terms of the headache as well, I think that also gives us the kind of change in nature and the suddenness of that also gives us a clue. So what's your thought on that, Dr. Dan?
Yeah. So what was that a question? No.
Yeah, part of it was a question, but part of it was, I mean, it was a comment, but part of it was a question. As in your thought on what do you think the volume of blood loss actually would have been in the intracranial space that was causing this to happen? It's
yeah, well, that's a good question because as
whether
I said,
the headache can give us a clue of how much the blood loss actually was, or is it a clue to how severe it is?
So I'm not sure there is evidence that there has to be intracranial blood to cause a Terson syndrome. That's the new thing. You can have
No, there doesn't.
Exactly. So you have, as I showed, a case of a patient with pseudotumor cerebri with absolutely no blood and in the subarachnoid space in the brain, and yet retinal hemorrhage. It's just a matter of pressure, as Neil said. Is the peripapillary veins that are dilated and leaking blood, I guess.
Originally, the other interesting ones are these cases of subhyaloid hemorrhage,
right?
Which they can sometimes present, quite casually after some episode of raised pressure related to a hemorrhage or something like that, and you get this wonderful appearance when the patient is upright. They do their own red cell settling thing, so you get a fluid level there. They can occur after head injuries, really quite benign things. I'm not sure that they are related to raised pressure. What do you think, Neil?
Dr. Carey has written in his chat that could it be related to some kind of vasospasm because of the blood in the, exposure to blood?
I can't think. I can't think how that could. That tends to be arterial.
Yeah, reaching the retina will be, I don't know, the brain probably. It's actually boiling down to raised pressure.
It's so typical of what happens with an abrupt rise in intracranial pressure in a number of different circumstances, some of which involve blood inside the head, but many don't.
Great case, Dan. So with that, we'll move to the next case. And
thank you very much.
Yeah. Dr.
Thank you.
Padmaja has requested to present first. So actually, Dr. Plant was to present next, but I've been requested to invite Dr. Padmaja Sudhakar. Just give me a moment. So it's my pleasure to invite Dr. Padmaja Sudhakar, who is an associate professor of ophthalmology and neurology at University of Kentucky, United States. She is also the medical director of neurosciences, Chandler Hospital at University of Kentucky. She is in the general neurology division. She is the director of the division. She is the clinical competency chair for the neurology residency program at University of Kentucky and also the grand rounds director for the Department of Neurology. She is Academy of Medical She is the recipient of Academy of Medical Educators Award for Excellence in Teaching, Mentoring, Innovation, and Leadership from University of Kentucky. She is also a recipient of prestigious A.B. Baker Award for Teaching from American Academy of Neurology. Welcome, Dr. Sudhakar. So over to you.
Okay, should I share my slides?
Yes, please.
Can you see my slides?
Yeah, we can see. Can you make it full screen?
Yes. Is it full screen now?
Yes, it's full screen.
Okay, all right. Thank you so much for that nice introduction, Dr. Basi. So I'm going to present this case, and I want to take the opportunity to thank Dr. Satyakarna and team for inviting me, and also the co-authors of this presentation. I have nothing to disclose. So we have a 68-year-old Caucasian woman who came to neuro-ophthalmology for complaints of blurred vision. About a month ago, she was in the ICU for seizures, and when she woke up from there, she reported mild headache and diplopia, but this had subsequently improved. Her past medical history is quite significant in that she has metastatic renal cell cancer, which had metastasized to the adrenal gland, lung, and liver. She had undergone a partial left nephrectomy in 2017, a total left nephrectomy with left renal vein occlusion subsequently, and then a hepatectomy in 2022. There was also the history of early stage endometrial cancer, for which she had undergone a total abdominal hysterectomy and bilateral salpingo-oophorectomy. Most of her cancer treatment was in Emory. Then she moved to Kentucky and established with us. There was history of polycystic kidney disease and obstructive sleep apnea. Sorry. So there was a very strong family history of cancer. There was no history of smoking, alcohol, or illicit drug use. Now, she had done an MRI of the head when she was in Emory, and this was in February of 23. This was for cancer surveillance, and they said no intracranial metastasis, but they did comment on an enhancing cellular supracellular lesion, which was extending to the cavernous sinus on both sides, compatible with pituitary macroadenoma. It had spared the optic chiasm. And the comment was it was also present on a previously done CT head and a PET scan. So she denied any visual symptoms at that time. They had done an optometry exam around the time of this MRI in Emory and said there were no visual loss or visual field changes. They had done her pituitary hormone levels. There was elevated prolactin, which was thought to be a stalk effect, and other hormones were the pituitary hormones were unremarkable. So this is an MRI of the head pituitary protocol done in University of Kentucky in September 23. And as you can clearly see, there is a cellular supracellular lesion with enhancement going very close to the chiasm. So then in January of 24, she underwent transsphenoidal pituitary resection in Emory. And per the neurosurgeon's note, they said only a subtotal resection was possible because of extensive vascularity. And the post-op MRI still showed some residual tumor going to the cavernous sinuses. And to our surprise, the biopsy yielded a big surprise. This was no pituitary adenoma, but instead it was metastatic renal cell carcinoma. So subsequently, she underwent protein beam therapy to the tumor bed and was placed on pembrolizumab. Within a week, she develops staring spells, obtundation, fever, desaturation, and is brought into the emergency room with status epilepticus. Immediately was intubated. The status was broken with lorazepam, levetiracetam, and propofol. And at that time, she was noted to have a high blood pressure. Other vitals were fairly okay. She went on a continuous EEG. The status was definitely broken. There were only generalized periodic discharges with triphasic waves and a slow background. The neurological exam was largely non-focal, but of course it was a sedated exam. They did an immediate CT head, and there were only post-surgical changes with fullness in the sella from the residual tumor. The CTA head and neck showed no vascular occlusion, but there was involvement, at least of the left cavernous sinus from the residual pituitary lesion. Spinal tap was also done, which showed high protein, but no infection, and the cytology was negative. So this is the MRI from September of 23 when the pituitary tumor was being monitored, and you can see bilateral periventricular lesions. And this is the MRI in April when she's admitted with status epilepticus, and you can clearly see that there is vasogenic edema in the bilateral occipital region. So this was diagnosed as a case of stress leading to acute encephalopathy and seizures, and was attributed to the pembrolizumab. So oncology was consulted, and they said this is immune therapy induced encephalitis. They stopped the pembrolizumab. Then she was given methylprednisolone 1 gram daily for 3 days, went on an oral steroid taper for 6 weeks. She quickly became alert, was extubated, and went to rehab. She came within few weeks of hospital discharge, walking to the neuro-ophthalmology clinic. It was a relatively benign exam. She had mild bilateral ptosis with nuclear sclerosis for her age, and that possibly caused the bilateral visual field effects, as you can see more in the superior peripheral. You can see more superior peripheral depression, and definitely no retinal nerve fiber layer loss or ganglion cell loss on the OCT. And this is a follow-up MRI, and you can see some residual changes from the tumor in the pituitary, but definitely the optic chiasm was spared. And the MRI brain definitely shows improvement of the vasogenic edema in the bilateral occipital region. So the final diagnosis is that we had 2 uninvited guests, and we're not like India. We are not prepared in the United States to take uninvited guests. So the first uninvited guest was metastasis from the renal cell cancer to the pituitary gland, and the second was pembrolizumab causing present encephalopathy. So the subsequent course, she remains stable. There are some pulmonary nodules. There is a right adrenal gland nodule, which looks stable. She's planned on a targeted chemotherapy. She's being tapered off a hydrocortisone, and she's being continued on the anti-seizure medicine. So we will be talking about a couple of things today. One is metastatic lesions to pituitary. These are quite uncommon, described only in 1% of pituitary resections. And in that group, 2/3 come from the breast and lung, but apparently any malignancy can go to the pituitary gland. Pituitary metastasis from a renal cell carcinoma is exceedingly rare. The incidence is only 2.6%, and symptomatic pituitary metastasis is very, very rare. So it's said, and like Dr. Naronha can help me, Pituitary metastasis cannot be readily distinguished from a pituitary adenoma or other lesions, but there are some clues where if you have a thickening of the pituitary stalk, or there is a erosion of bony sella, or there is like destruction of the clivus, loss of normal signal high intensity of the posterior pituitary lobe, presence of flow voids, cavernous sinus involvement, or multiple lesions in the pituitary, maybe it's a clue to think about pituitary metastasis, but these very well can have a suprasellar extension with enhancement. And they say even an FDG PET, while showing sellar tumor hypermetabolism, cannot distinguish between a malignant and benign lesion based on the uptake. So talking about pituitary metastasis, particularly from renal cell carcinoma, these patients are in the 4th to 6th decade. In a meta-analysis of 41 patients, they saw a higher male preponderance, and 50% of those patients already had a known diagnosis of renal cell cancer, and 30% had previous history of metastasis. Pituitary metastasis was the initial presenting symptom of renal cell carcinoma in just about 24%. And they say that median time from the renal cell cancer diagnosis to pituitary metastasis is about a year. And they have even described cases where the pituitary, like the renal cell cancer, metastasized to a pituitary adenoma. Majority of these patients are asymptomatic. Endocrine abnormality is the most common presenting symptom, where they have hypopituitarism or panhypopituitarism. More frequently, the anterior pituitary is involved, but they can also have visual field defects, visual loss, headache, and cranial neuropathies like your third nerve palsy. There are no clear guidelines for treating pituitary metastasis from a renal cell cancer. Gross total resection is probably the best, as it can reduce the tumor burden, establish a definitive diagnosis, relieve your chiasmal compression, and improve vision loss. Transsphenoidal endoscopic surgery is the best available option, but if the tumor is too large, then we may have to go for a craniotomy. And achieving gross total resection is hard because it's locally invasive, it's highly vascular, and very often spreads to the cavernous sinus. Many cases get local radiotherapy, and some chemotherapeutic agents may be useful. So generally, pituitary metastasis carries a poor prognosis, but in comparison with pulmonary metastasis, renal cell cancer metastasis to the pituitary has a slightly better prognosis. Next, I'll quickly talk about PRESS. We all know this entity. It's characterized by clinical and radiologic signs of vasogenic edema, thought to be reversible. It has an acute or subacute onset and is usually progressive. Patients are obtunded. They may have headache, visual alteration, cortical blindness, and present with seizures. Usually, it's associated with acute hypertension, which is believed to play a role in pathogenesis, but it has been associated with other etiologies like autoimmunity, sepsis, eclampsia, and with various cytotoxic agents, targeted agents, biologics, the immunomodulatory agents, and in that class, we must include our chemotherapeutic agents. The prognosis mainly depends on the etiology of PRESS. All these agents have been associated with PRESS, and now we have started using a lot of the immune checkpoint inhibitors. So pembrolizumab, a commonly used immune checkpoint inhibitor, is a humanized antibody that targets programmed cell death protein 1. When that programmed cell death protein is inhibited, there is a reactivation of T cells, which targets the cancer cells and promotes an increased autoimmune response. So these immune checkpoint inhibitors have been associated with a number of neurological adverse events, mainly neuromuscular symptoms, but PRESS has been described as a very serious adverse event with some immune checkpoint inhibitors. Now, there are two hypotheses for PRES. The first is the blood pressure rising above the limits of cerebral autoregulation, leading to cerebral hyperperfusion, breakdown of blood-brain barrier, extravasation of plasma and macromolecules, causing vasogenic edema. The hyperperfusion theory is supported by high blood pressure noted in the majority of PRES, and the posterior cerebral hemispheres are vulnerable because of lower sympathetic innervation in this region. 30% PRES comes with only slightly elevated blood pressure or normal blood pressure. So the second theory proposes that PRES may be triggered by endothelial dysfunction caused by circulating endogenous or exogenous toxins. And a variant of this toxic theory is the toxic immunogenic theory, where the trigger factor is the excess production of pro-inflammatory cytokines, causing endothelial activation, endothelial damage, breakdown of vascular integrity, release of vasoactive substances, and edema. This is probably what happens in immune checkpoint inhibitors. Interestingly, PRES onset can occur after a long interval after the administration of a chemo drug, but it has been described in monotherapy with the immune checkpoint inhibitors and can quickly occur in weeks following even a single dose, just like what happened in our patient. So in conclusion, there's no definite radiological and clinical manifestation which can clearly help us make a diagnosis of pituitary metastasis. If you have someone with a cellular tumor who has a known metastatic cancer, please think about pituitary metastasis. And PRES is a rare neurological adverse event of the immune checkpoint inhibitors. Thank you.
Great case, Padmaja. Patient with a very turbulent course. I just want to know what was the indication for surgery for pituitary adenoma? I mean, like suspected pituitary adenoma. You did mention patient presented a couple of times with a little blurring of vision, but all through the, I think, optic nerve function tests were quite okay. Or there was some hormonal dysfunction, or what was the indication for surgery in this patient?
I think it was going very close to the chiasm, and they were trying to preserve her vision. So we don't have all the scans, but definitely the one which was done in our hospital when she established with us showed that it was going very close. And I think in order to preserve the visual functions, they proceeded with surgery.
You did mention, yes, I think Dr. Plant wants to make a comment.
Well, I just wanted
Veena,
to...
you were
Yeah. Just wanted to, in a patient with a known renal cell carcinoma who already has metastatic disease elsewhere, I would definitely consider the pituitary lesion as being metastatic first rather than being an adenoma. Of course, the patient had a prior PET, which you said showed the lesion in, I think, July 2022. So it would be worth seeing the change in size. There are certain pointers. If you look at the images carefully, of course, there is no T2, but RCC mets are vascular. So generally, you'll see some flowoids in that. They're usually expansile and they destroy the bone very early, which was not there in this case. The infundibulum being central and just having a diffuse enlargement of the pituitary probably were pointers that, it's not just an adenoma. That's my take. And I don't think there was initial cavernous sinus involvement from the initial images. Of course, PRES was pretty straightforward. I don't think there's any diagnostic dilemma there.
PET scan would have picked activity there in the pituitary, you said?
Yeah, but it's not specific, no? Your SUV uptake will not tell you very clearly whether it is malignant or not.
Metabolic activity.
Yeah.
Adenoma would also show a similar activity.
Not that much, I think, compared to what RCC would show. But then it was not a very large lesion for the PET also to be, to show the SUV very clearly there.
Dr. Plant, you have a comment?
Well, yes, it was mentioned. I was going to say that my experience of pituitary metastases, which are quite rare in clinically, although they may be more common at autopsy and so on, but is that they usually have panhypopituitarism, which is very unusual with adenomas, of course, but also occurs with pituitary hypophysitis. So for both hypophysitis and metastases, it's more common to get a pan-hypopituitary picture of also involving both the anterior and posterior pituitary. So I think that's a very good clue.
My patient did not have pan-hypopituitarism, unfortunately.
Well, it doesn't. Yeah, none of these things are 100%, but if you find that, then that's a very strong indicator that it's not an adenoma, is my point.
Excellent point. Any other comments from the other panelists?
Anyway, I think Dr. Sudhakar, your two uninvited guests were not welcomed anywhere, I think, across the globe, be it India or elsewhere.
Yeah.
I'd like to say one thing about press, if I may, because there's another syndrome which is seen in similar situations and caused by similar drugs and so on, which is a bilateral ischemic-looking anterior optic neuropathy. And I think this is a similar mechanism to press. Sometimes it occurs on its own, sometimes it occurs with cerebral involvement. And we used to see it quite a bit with cyclosporin, for example. I think there's a similar mechanism going on in the optic nerves.
Actually, you did the OCT for the patient. You did share. Did you share something about the GCC? If it's an ischemic damage, you'll have some amount of GCC change. I think I'll expect that on OCT.
No, well, when this occurs, the discs are obviously swollen.
No, I'm not talking about the disc involvement. I'm talking about press. In her case, occipital involvement was there, right? The patient presented with blurring of vision.
Yeah. So when she came, like her OCT was normal, both the RNFL and the
GCC was normal.
Yes.
So a follow-up scan. I have followed up a patient of press, and the GCC did show changes over a period of time.
Oh, well, that's transsynaptic, retrograde transsynaptic degeneration.
It did.
True. Yeah. But yeah, she hasn't come back yet because, like this is all like less than 2-3 months now from the discharge. But like she came to my clinic in like 2 weeks after the ICU discharge and I didn't expect to see such a good exam, and she was doing fine.
It takes, the transsynaptic degeneration takes a little time to occur. So if you're absolutely certain that the optic nerves are normal acutely, but you get some visual field loss related to the press, then just as with an occipital stroke, over a little bit of time, you may see some ganglion cell loss.
Are you guys seeing a lot of problems with the immune checkpoint inhibitors? Because it's just widely used.
Whom are you asking, Patty?
All of you. Like you will be getting referrals from all these. Everybody has cancer these days. Everybody gets the pembrolizumab.
No, truly speaking, I haven't seen. Anybody else?
Yeah, we've seen some optic neuritis or optic neuropathy from these inhibitors, and even some strabismus, acute ocular motor nerve palsies.
Myasthenic syndromes can be
For
very
sure.
difficult to treat as well.
Great case.
You can't go messing with the immune system without causing trouble.
So with that, we'll move to the last case of the second session. And to present the case, it's my honor to invite Dr. Gordon Plant. I think I meddled with the, yeah. So it's my honor to invite Dr. Gordon Plant. Dr. Plant is currently Honorary Associate Professor at University College London, United Kingdom. But we all know that he has been a consultant neurologist, neuro-ophthalmologist to the National Hospital for Neurology and Neurosurgery, St. Thomas Hospital and Moorfields Eye Hospital from 1991 to 2020. And he has worked as a full-time NHS consultant, and he has published over 300 articles. He has an age index of over 70, and he has worked as a training program director. He initiated the first medical ophthalmology rotation in London. Sir, please present your case. We're looking forward to that.
Yeah, can you see my screen?
Oh, I
Yes,
didn't share.
yes, we can see. We can see your screen.
Yeah, I'm having a bit of trouble because my very old computer, if it's been on too long, the screen starts to flicker. And I'm just looking to see whether I can share
So
the
it's on the
presentation.
right side down. You'll have to make it full screen.
Yeah, that's what I'm trying to do. Yeah. Is that all right now?
Yes, yes, perfect.
I assume it's not flickering for you guys.
It's not.
All right, so here we are. Now, as you know, I've been retired for some time now, so I'm very grateful for the team from St. Thomas's for allowing me to present this case. A young Asian boy who was, well, he's 22, perhaps not young to all of you, but he's a really, really keen footballer. That's soccer for you guys over on the other side of the pond. And he were presented to the accident emergency with headaches, 2-day history of headaches. And there was a history of he's hit his head while playing football, not just with the ball, but he otherwise seemed quite well. And he had a CT head scan and was discharged. However, he came back a little while later. The headaches weren't getting better, and he developed some abdominal pain, and in fact had constipation and urinary retention. He was catheterized and he was sent home. However, he came back yet again. He still got headaches, and now he's confused and he's got fever. So he was finally admitted with a possible diagnosis of meningitis, and treatment was started with antivirals. However, things didn't go well. He started to have seizures and was intubated, and they finally did a lumbar puncture and found that he had a CSF lymphocytosis with a raised protein. Question of TB came up. In fact, the glucose was normal at that time in the CSF, but he was started on anti-TB treatment and dexamethasone. Then he went on to have an MRI. And this is the axial T2. Can you see my little pointer?
Yes, yeah. We can see the pointer.
The pointer. Oh yeah, okay. And basically, in the white matter, it looks a bit kind of streaky. And the abnormality is a bit more obvious here, where you look at the diffusion weighted imaging, where you've got high signal here in the cerebral hemisphere's white matter, quite bilateral and symmetrical. And also lower down. And there's a general kind of streaky appearance to this white matter change, linear. And this is, of course, following the anatomy of vessels, but also of a certain type of neuron that's in the brain. A little bit of leptomeningeal enhancement here, not much to see with contrast. And in fact, his optic nerves showed high signal at this stage. So these are probably stir or probably stir. So the optic nerves, as you know, should give the same signal as cerebral white matter. So clearly we have high signal and some little bit of enhancement in the optic nerves bilaterally. There were also changes in the spinal cord, and we're beginning to understand why he was in urinary retention. So they carried on looking for an infective cause for this. As you can see, everything you can possibly think of and more was negative. So the question arose as to whether this was autoimmune. And having ruled out infection as much as they could, he was very reasonably put on steroids and had plasma exchange and IVIG. So triple approach there. And lo and behold, he began to improve. Now, when all this was over and he was getting better, people suddenly realized that he was blind. His fundus looked normal, but he had no pupil reaction to light. And in fact, his CSF was positive for antibodies to GFAP. Other NMO and MOG were negative. So the diagnosis was made of an autoimmune GFAP astrocytopathy. And these imaging appearances are quite characteristic for this. So in recent years, this has become familiar in neurology, but I think it's less familiar in ophthalmology, so well worth just reviewing a little bit. So he was getting better after this. His MRI scan was getting better. And in fact, his vision recovered to 6.6 bilaterally with good color vision, but his optic nerves remained pale. And look at the changes here on the OCT. So quite a lot of damage done here. And I presume it's something to do with his young age that he's preserved vision so well. And he started mycophenolate mofetil. And there you can see the thinning of the ganglion cell layer as well. They managed to get a right eye field, and that wasn't too bad. There's definite nasal constriction. I would anticipate the left eye, if he'd been able to tolerate the Goldman, was something similar. Sorry, something not showing up there. And there's a Humphrey. So binasal loss predominantly, disc-related really. And I saw him actually after all this had happened. We presented him at the grand round, and I asked him whether he'd gone back to playing football, which of course he had. And he now has bilateral Uthoff symptom. And I've come across a few other footballers with Uthoffs, and it's very disabling because, I mean, if you're a regular athlete, you can just stop what you're doing and then wait for your vision to come back and then go at it again. But it's very difficult to ask the other, how many is it now? The other 21 people on the pitch to all stop for a quarter of an hour while your vision recovers and then carry on. So this is very disabling for the poor chap. But I think it's interesting because we know that UTHOF can only occur where there are surviving axons. If you've lost axons, then you can't have this effect. It's probably related to demyelination, because we know that the difference in the way that the fiber conducts when it's demyelinated makes it very sensitive to temperature. And my own view is that if UTHOFS goes away, that's evidence for remyelination. It's something that Claire and I looked at a little while ago, thinking that recovery from UTHOFS could be an index of remyelination. So it's quite interesting to monitor this and see whether it does go away or not. And I'm not sure that there's any other good evidence whether this particular type of encephalopathy and spinal cord damage and so on does leave a residue of demyelination. This is why we talk about STARS, because this is directed against the astrocytes, which are, of course, also in the retina, and they're very important in the developing nervous system. For example, if you don't have astrocytes in the retina in animal studies, then you don't get any vascularization of the retina. I think it's important to realize that patients who have this type of illness could have optic nerve involvement, which I don't think the neurologists are aware of. And also there are some cases now reported of isolated optic neuritis, which seems to be related to this antibody. So it's down there at the bottom of the list, but something to think of if all else is negative. Okay, so I think I'll stop there.
Thank you. Thank you, Dr. Plant. You don't want to complete this slides? It's over?
Well, I've said it all, really.
Okay, fine. So we'll go to the discussion. A very, very interesting case. Again, it's very similar to Luciano's case, Dr. Simau's case, where an incident has kind of triggered autoimmune reaction. In his case, it was dengue fever, and here I think it's the injury, head injury. So my question to you, Dr. Plant, is that what do you think is the reason that in his case there was absolutely no recovery, and in your case this boy has recovered almost 6/6 vision? You did say that this is something like typical demyelination in MS or any other demyelinating illness, where it's all about the damage is limited only to the myelin sheath, and he has certain symptoms due to that, but eventually over a period of time in such situation patient recovers vision. Whereas in Dr. Simau's case, you think that could have been because of demyelination? My question to you, in fact, is do you see such severe vision loss in multiple simple demyelinating illnesses of the optic nerve?
Well, in straightforward MS, yes, you can acutely. Occasionally, patients can present NPL, but of course, the rule is that they get a good recovery, although they may be left with symptoms of demyelination. The whole point about demyelination is that these are surviving axons which are functioning, except in these unusual situations of raised temperature and so on. I'm not sure in this case that the head injury was actually relevant here, except that it threw people off the track to begin with. I'm not sure that it is the cause, and there's a huge amount of has been said about the relationship between injury and MS relapses in particular, because of the medico-legal aspects. But this did go to the High Court here a few years ago because there were one or two neurologists who were very keen on this idea. Actually, Alistair Compton eventually he just stood there and said no, he didn't believe this. And of course, there are people having MS relapses and people having injuries all the time, and occasionally the injury will happen before the MS relapse. If you have the MS relapse and then the injury, no one's interested. It's only when it happens the other way around. So now I'm not sure here that the trauma was relevant. You know, he's a football. He's getting trauma of some sort probably every Saturday.
So it's just a simple case of GFAP astrocytopathy.
Yeah, I think so. I mean, we don't know what triggers these things. We've talked about sometimes the trigger being post-infectious, certainly, or post some sort of immune stimulus, but I'm not sure about simple injuries.
So my next question is, here the MRI features, especially those radial lesions on the MRI, they were very, very typical, at least like how the books describe GFAP astrocytopathy with bilateral optic nerve involvement. So why was the initial diagnosis of infective pathologies and tuberculosis treatment tried?
Well, you'd have to ask the physicians who were looking after him. I suppose. I think the question here is the error of omissions. Really, I think if you look at someone in that situation, the worst thing you could do is miss an infection, probably. And if you've got an infection and you give people corticosteroids, you can make things worse. So I think it was very reasonable to rule out an infective cause for the encephalitis, although unfortunately the radiologist didn't pick up on this very characteristic. And it's all to do with the fact that the astrocytes, they go throughout the white matter from the cortex, and the other thing they're involved with is the generation of new cortical gray matter neurons, which originate in the periventricular region and sort of track up these astrocytes. So, and it's also they follow the vessels and also follows the vascular pattern. So this has come to be recognized as very characteristic of this particular type of encephalitis.
So what is this, I mean, like how it differs, the phenotype of GFAP astrocytopathy from other demyelinating diseases that we know of? What difference there? First of all, my question to the panel and all the speakers also, that do these patients, since there is quite a significant CNS involvement, do these patients present first to the ophthalmologist or the neurologist?
Oh, no, sorry, I didn't make clear. I should have done. Actually, optic nerve involvement in this seems to be very rare. It seems to be very rare. Maybe because it's missed. But certainly someone like this who was totally blind for a little while, that wouldn't be missed. It seems to be very rare in this condition. So it's more the lesson for ophthalmology is more that if there is a case like this around, someone needs to check that the optic nerves are not affected, because the other people might not know. And then also these seemingly very unusual cases of isolated optic neuritis where this antibody is positive. So they're really the two messages. It's not at all common to have optic nerve involvement in this.
So in that case, how do you follow up these patients? What is neuro-ophthalmologist's role? I mean, like, do they relapse? Are they put on immunosuppression?
Yes, he's going on longer term immunosuppression. Whether he actually needs it or not, I don't know. I don't know what the outlook is, whether this can be monophasic. perhaps someone else knows. Neil, you've got your hand up.
That your footballer has the Udhoff symptom when he plays. There are rare cases of failure to improve in patients who have an Udhoff symptom. So I would be very concerned about that. He obviously, as you point out, has significant damage already. I would still be worried that he might have an unresolving Udhoff symptom. Same thing was true in the old days when they used to do the hot bath test for patients with possible myasthenia, and they would have permanent damage. So you do have to worry. Not everybody improves when they cool down after an Udhoff.
Well, yeah, that's very interesting. I've never seen that. Of course, generally, when they start to lose vision, they will stop doing whatever they're doing. Of course, if some idiot doctor has put them in a hot bath, that's really bad news. But generally, they just stop what they're doing and wait for their vision to come back. I haven't seen I don't recall a case, certainly not in MS, of failure of vision to recover. That's really interesting. I mean, I've never told patients to avoid doing things that that might induce loss of vision, because
Do you ever tell them to have some ice cubes or something with them? But it's been shown that if you put an ice cube in your mouth, the symptom goes away a lot faster.
Oh yes, absolutely. It's absolutely. It's a purely temperature dependent, and you're talking about putting up your own core temperature, which is pretty well regulated physiologically, isn't it? So no, it'll come down again if you stop exercising, and an ice cube would help. The other interesting thing is that these patients who get loss of vision, and this is all after MS, of course, but apparently in bright light, although I think it's more to do with contrast, because just a change in the mean light level doesn't affect the firing of neurons very much. It's more contrast. And of course, the brighter the illumination, the higher the contrast will be of whatever it is you're looking at. And I've known patients with MS who get this, for example, in supermarkets, because we don't often have a sunny day here. Rashmi, you had something?
Yeah, Doctor. I just wanted to ask a question, that these antibodies you detect in serum or in the cerebrospinal fluid? CSF or blood?
I think this was both.
Both.
Yeah, I'm pretty sure this was both. I'd have to check for what it's like across the board. But generally, I think the serum results are more reliable than CSF results. So I think, yes, I think potentially both, but more reliable in serum.
So I was talking about the Chinese paper, Dr. Plant. So in that it was given that a patient presenting with optic neuritis have more probability of having the antibodies in the serum, and those presenting with encephalitis like picture in the serum. That's what it's saying.
Okay, yeah. Well, it's a fascinating condition.
So as you were presenting, and as I heard Luciano's case also, I was just wondering, I am hypothesizing. I don't know whether Satya will allow me or give me time to discuss this. Just a quick comment about it, that in the first case, that Luciano's case, probably that auto antibodies were against the small blood vessels. It was a small vessel vasculitis, which caused the optic nerve damage. That's why it was such a drastic vision loss, which never recovered. And whatever demyelinating other diseases are there, like GFAP, astrocytopathy, whatever be the trigger, they are antibodies against the myelin sheath. Any comments about that?
Well, not necessarily, because the myelin damage may be a secondary phenomenon without. I mean, people look for antibodies to myelin sheath in MS. No one ever found any. So I think that the damage here is probably to the astrocytes, which of course are supporting so much that's going on with the neurons. So I think that's where the damage is, rather than directly. But it was interesting here. I think that there is clear evidence of demyelination from the UTOFs, and I'm not sure. I haven't looked around to see whether that's been reported in brain biopsies or anything like that. If not, then that's a novel observation. The VEPs, of course, will help confirm it. He should have a delay, and also over time he may get remyelination and the symptom may go away.
Excellent points. Thank you. With that, we come to the end of the second session. Over to you, Dr. Satya. I thank all the panelists and the speakers.
Thank you, Shikha. And we move on to the third session for the day. And I would like to introduce the moderator for this session, which is Dr. Mahesh, who is the head of Department of Neuro-Ophthalmology at Arvind Eye Hospital, Madurai, India. He was trained under Professor Nachiyar, a pioneer of neuro-ophthalmology in India, and he has been in the neuro-ophthalmology department of Arvind Eye Hospital for the last 20 years. He has edited a neuro-ophthalmology textbook for postgraduate students, and he is a co-author of an Atlas of Imaging in Neuro-Ophthalmology and has several publications in national and international journals. He is a popular invited speaker in state, national, and international meetings. Over to you, Mahesh. Mahesh, are you there?
Yeah, thank you for the introduction. Sorry, I got disconnected. Okay. I got disconnected, and first, thanks to Dr. Satya for having me, invited me here as a moderator, and I'll start the introduction. So Satya, can you see my slides?
Yes, yes.
Okay. So I'll be introducing the panelists for this session. And first, I would like to introduce Dr. Neena, who is a senior consultant and head of the Department of Pediatric Ophthalmology, Strabismus, and Neuro-Ophthalmology at the Giridhar Eye Institute at Kochi, India. She is a fellowship trained in Pediatric Ophthalmology and Strabismus in Shankar Nethralaya, Chennai, and her special areas of interest are pediatric cortical visual impairment, myopia control, complex strabismus, and acquired comitant esotropias. Next, I would like to introduce the panelist, Dr. Ambika S., who is a senior consultant in the Department of Neuro-Ophthalmology and who is also the director of the Department of Neuro-Ophthalmology Service at Shankar Nethralaya, Chennai. And she has received the Athilwale Award for her work in neuro-ophthalmology at the All India Ophthalmic Society. She has participated as an invited speaker in various national, international neurology and neurosurgical society conferences. Apart from ophthalmic conferences, she has authored many books like the Atlas of Neuro-Ophthalmology, which was the first Indian atlas in this specialty, and an Atlas of Imaging in Ophthalmology, and has written chapters in many ophthalmology and neurology books. Next is Dr. Rashmin Gandhi, who is the consultant and director of the Neuro-Ophthalmology Department of the Center for Sight at Hyderabad, India. And he is also the director of Axon MedTech Private Limited and managing director of Foresight Worldwide. And he's an adjunct professor in the University of Hyderabad, India. His special areas of interest include developing new technologies in ophthalmology, education, and community outreach programs, He's a research scholar at the International Institute of Information Technology, Hyderabad, and is an adjunct faculty at the IIT Madras and clinical director of IIT Shankar Nethralaya team, which developed the mobile eye surgical units. The next is Dr. Swati Fulgale, who is an additional professor of strabismus and neuro-ophthalmology at the Dr. Rajendra Prasad Center for Ophthalmic Sciences of the well-known All India Institute of Medical Science, New Delhi, India. Her areas of interest include strabismus and neuro-ophthalmology, and she has over 80 peer-reviewed publications and 25 chapters in various textbooks. Next is Dr. Durga Priyadarshini, who is a senior consultant in the Department of Neuro-Ophthalmology of Shankar Nethralaya, Chennai, India, and she has presented many scientific papers, posters, and conducted instruction courses at national conferences. And she has got publications in optic neuritis and actively been part of an organizing team of neuro-ophthalmology conferences. So that's about panelists. And the first presenter, I would like to introduce Dr. Alison Liu, who is an associate professor of neuro-ophthalmology in the Department of Ophthalmology, Neurology and Neurosurgery at the University of California, Davis, USA. And she has completed residencies in neurology and child neurology at Linda University and neuro-ophthalmology fellowship at Stanford University. And she has a special experience in treating neuro-ophthalmic conditions in both adults and children. And she has developed a new teaching curriculum at the Neuro-Ophthalmology Virtual Education Library novel website and is a dedicated clinical scientist. So I would like to welcome Dr. Alison to present her case.
Thank you, Dr. Kumar, for the introduction. My presentation, share my screen.
Yes.
Okay, you can share. You can see the screen. Okay.
Yes.
Yes, we can.
Great. So this presentation is actually published in the Journal of Neuro-Ophthalmology by one of our residents, Dr. Huang. So the slides are available through the JNO website. We're going to talk about a young girl with subacute vision loss. So this girl, when she was presented to us, she was 8 years old. Mother said that about a year ago, when they were back in Ukraine, she suffered from subacute vision loss of both eyes. She was not able to see very well, but mom did not know exactly how the visual acuity was. The mom did bring her to a hospital, and the doctor said that glasses wouldn't help, but maybe we should try some steroids. So she was given both IV and oral steroids and gained some weight, but the vision did not improve very much. So this is the OCT that the mom hand carried to us when they came to the United States. We can see that the RNFL of both eyes were thick. So suspected bilateral optic disc edema at that time. Further history of this child, she was born full term, no perinatal complications, and the mom said the pregnancy was fine. She did not remember anything different. She has 4 children, so she told us that the milestone was just very much similar than the other children. Before the child was entered the 1st grade, she has had an eye exam by the local eye doctors. The vision was 20/20. There was no other history that was distinct. So we also asked them if there's any family members with similar conditions, and mom declined. We also asked if the mom and dad are possibly related or from neighboring town. The mom actually felt very amused about this question. She said absolutely not. The kid has a normal diet. There's no malnutrition per the mama's report. This is her first exam with us, which was about a year since her vision loss. Visual acuity was count fingers in 2150. IOP was good. Confrontation visual field was full, and she was very nervous, and there was a language barrier at that time. So it did not push her to do a visual field, although she was 8 years old. Extraocular movement was fine. She did not have any misalignment either. Ishihara placed the right eye was 1 out of 14, left eye was 14 out of 14. Anterior segment was unremarkable. The fundus exam showed bilateral optic pallor, so I have photos in a little bit. Neurological exam was normal. So this is the first set of optos that we had in the clinic. We can see that although these are optos images, we can see the bilateral optic pallor. And we did obtain an OCT. She had bilateral optic atrophy. The suspected bilateral optic disc edema had resolved. And also there was ganglion cell layer loss. So the differential diagnosis was broad at that time. First of all, we agreed with the local ophthalmologist. It can be demyelinating disease, including MS and NMO and MOG. It could be a structural abnormality, maybe it's a KRE, maybe craniosynostosis, but mom declined all of these. And it could also be a sequelae of elevated intracranial pressure. She was a little overweight. But she did not have any headaches, any signs of increased intracranial pressure. Of course, we have to think about hydrocephalus tumor and cerebral venous thrombosis. Although she just declined any kind of a double vision, transient visual obscuration, and any headaches, any tinnitus. So we also thought about infectious, infiltrative, and neoplastic, toxic, metabolic, and nutritional. The workups, of course, we started with an MRI to look at the structure. There was mild optic atrophy bilaterally in the anterior portion of the optic nerve. And the brain was clean. There was no demyelinating lesions or white matter lesions. Axial T1 plus GAD with fat sat. We looked at the optic nerves. There was no enhancement. And also this is the T2 flare just to show the normal structure. And then the T1 sagittal showing normal midline structures. So these are the labs that were negative. We looked at pretty much the common treatable causes of optic neuropathies, negative, and we also sent a CDS1 panel, including the NMO and MOG antibodies to Mayo Clinic that was negative. So when we revisited the differential diagnoses, she had an unremarkable MRI, so probably not elevated ICP, structural is fine, no tumors, no infiltrative lesions. Demyelinating disease, we have negative antibodies. Also, her clinical course was not suspicious for an infectious disease or inflammatory diseases. There was no risk factor for any kind of a toxic exposure, metabolic, or nutritional causes. So at that time, we thought, well, this is a young girl, and she did have bilateral optic disc pallor. We tried to do genetic testing. And first of all, we submitted a request for just a basic optic neuropathy panel was denied. And we submitted a mitochondrial panel that was also denied. So the third time, we just submitted a whole genome sequencing. Surprisingly, that was authorized. So this is the genetic testing result. This is actually a whole exome sequencing instead of a whole genome sequencing. So there was a positive result showing a homozygous pathogenic variant in the DNA JC30 gene. So we were wondering what that was. Usually we thought that mitochondrial disease was, Leber's was mitochondrial, and then the report actually, actually said that this is suspicious for autosomal recessive Leber's hereditary optic neuropathy. So our question was, Well, that's usually what we see is maybe a teenager or 30-something years old male that's presenting with this condition. But this is a young girl. And what's the difference between autosomal recessive and mitochondrial Lebers? Also, what do we tell the family and how do we treat her? So there are actually two distinct inheritance patterns of Leber's hereditary optic neuropathy. So commonly, it is recognized as the mitochondrial genetic disease for Leber's, and there is a predilection for males. So basically, the three common types, 3460, 11778, and 14484 were all maternally inherited mitochondrial mutations. So for this type of autosomal recessive Leber's, particularly in our case, it was caused by a homozygous DNA JC30 mutation, but other genes have also been identified, including NDUFS2, NDUFA12, and MCAT genes. So usually there's a family history, but we did notice that there could be incomplete penetrance. And in the interest of time, I'm not going to go into details about this mechanism, but with the DNA JC30 mutation, the complex 1 could not be repaired by the PXP component. So there was, when there is any oxidative damage to the complex 1, then one of the subunits was not able to degrade, so that it causes more lower turnover, so more damage to the module. And the clinical features of autosomal recessive and versus mitochondrial Leber's hereditary optic neuropathy is that, first of all, the prevalence of the MT LHON has a prevalence of 1 in 25,000, while the other one, the autosomal recessive form, is more rare, affecting 1 per million individual. So the presentation is actually similar. Both will present with subacute and concurrent or sequential vision loss in a young individual. And also both conditions will cause degeneration of the retinal ganglion cell layers. So we wanted to make a note about the DNA JC30 mutations. There may be an overlap with Lee syndrome. In these cases, when we perform an MRI, we'll see symmetric T2 hyperintense necrotic lesions in the basal ganglia or the brainstem. The pseudoedema is it's a well-known phenomenon in LHON. Usually, when we look at the optic nerves, it will look like there's polar disc margins. Looks like there's edema of the retinal nerve fiber layers. However, FA will show no leakage, and with disease progression, both the edema and the vessel telangiectasia will disappear. So this is again showing the features of the pseudodysedema. Important notes, the age of onset of autosomal recessive LHON is usually younger, just like in our patient. So the treatment, we know that at this time, the only thing we have is idabenam. Fortunately, in these cases, the clinically relevant recovery rate is a little higher than the traditional mitochondrial LHON. So this is just one study. It showed that the visual involvement with idabenam in the DNA JC30 mutations is about 81%, while the mitochondrial LHON is half of that. So based on these small cohort studies, we started this patient on idapnan 300 milligrams daily. She was 35 kilograms at the diagnosis. Technically, she could take 1.5 pills. So we did not want to cut the capsule, so we just gave her 300 to see. And also, this is out of the pocket. So for a newly immigrated family, it was difficult financially. So we also that's the other consideration why we started only 300 milligrams every day. About 6 months later, she came back for follow-up. Now her best corrected visual acuity has improved from count fingers and 2150 to 2040 and 2050. Ishihara plate did not really improve. Her color vision is still impaired. This is the first time we were able to grab a visual field. We can see the sequocentral pattern of visual field loss. She had stable bilateral optic atrophy. The RNFL and the ganglion cell layers remained the same. So in summary, there are two different inheritance of Leber's. One is the traditional mitochondrial, the other one's autosomal recessive. So our team actually has learned from this case a lot. We know that the autosomal recessive type tend to occur in younger patients, but the presentation is similar to the mitochondrial type. And we also know that when we started idapnan, although it was a small dose, and she responded well to it, so the family is happy about it. So these are my references, and thank you for your attention.
Thank you, Dr. Allison. It's an excellent case and a lot of points to learn from this case. So panelists, any thoughts? Dr. Nina, would you like to add something, panelists?
Yeah, very good case. I learned a lot of things from your presentation because in this part of the world where I work, genetic testing is not very common. We've just started doing genetic testing, and I was not aware of this mutation, being a cause. So it was a very good learning experience for me. So I just wanted to know, was parental testing done for the done in this case?
Was genetic testing?
Parental testing? Parents were tested?
Oh, the parental testing, no, because it was out of pocket. It was $250 per parent, so they declined.
Okay, and the fact that she's coming from Ukraine, which is because there are a lot of studies which says that there is a definite, ethnic prevalence for this mutation from Eastern Europe, right? From Russia, Ukraine, and Eastern Europe. So does that give a clue to the, the fact that you were looking at this new mutation? Or it was just accidental that you just got the thing on genetic testing?
I was thinking that this is autosomal dominant optic neuropathy because there was no family history. And then the mother clearly declined consanguinity, and she actually laughed at me asking that question. So I just said, whatever genetic testing I can get, I will grab it. So at the end, the only thing that was approved was the whole genome sequencing. I didn't think of the family heritage at that time, so I wasn't thinking about this particular type.
Yeah, you're right. I think autosomal dominant would have been, what you would have thought first. What about other syndromes? Like, of course, you would have done a complete systemic evaluation. But sometimes we do see some syndromic associations. So none of that was there, I guess, here. So everything else was ruled out. What about autoimmune optic neuropathy? Would that be a possibility? Would you consider?
We checked the basic labs. Basically, what we did was lupus and Sjogren's. And we checked ANCA as well because she was young and she was very afraid, and there was a language barrier. So I just thought I would minimize things as much as possible through the blood draw. Apparently, there are so many different autoimmune neuropathies that we could check, but she has no autoimmune symptoms at all. So I just selectively checked for a few.
Yeah, the fact that there was definitely retinal, RNFL thickening on the first scan, that did give some clue. But yes, but this is surely a a blind shot, but I think it did good in the end that you got the genetic testing, and I'm happy that she's doing good with Idibanon. In India, we don't get the same dose of Idibanon. We get about 45 milligram tablets, and it's very difficult to ask the patient to swallow, so many tablets together to achieve the adult dose. So I think I learned a lot from your case, and I think we should start doing genetic testing in cases where you're not getting anything positive, so it might give some clue. Another thing I wanted to add is we see a lot of ethambutol-induced optic neuropathy in this part of the world, and we also find that this Leber's kind of mitochondrial mutations make them more susceptible to the optic nerve damage. So if this patient was an adult or a young male or somebody with, who was, another thing you should look at is the, abuse of drugs, alcohol, tobacco, and also any history of tuberculosis treatment, because I think you've done all that work. I'm just adding into that.
Yeah, we have lots of alcoholic issues in this part of the world too, that causes nutritional deficiency, and we do see an uptrend of ethambutol toxicity as well. I agree. I've seen a couple of cases with mitochondrial mutation. They have a first hit, then we give ethambutol. They really lose vision quickly.
Yes.
I think we have.
I understand. Can I make a point? As I understand, I just summarized that this autosomal recessive variant has a better prognosis and a better clinical recovery rate than the other mitochondrial variant, right?
Yes.
And Idibanon should be tried definitely, and it does make a difference because the clinical recovery rate, which you mentioned, is quite good. And it has almost equal male to female ratio. So I think even girls should be definitely considered for testing, right? So it is now understood that it can affect females also, Leber's hereditary optic neuropathy, and we shouldn't be biased in the testing if a female child presents to us with bilateral optic neuropathy. I think we should definitely think about the possibility of Leber's.
Yes, thank you.
Thank you.
Thank you, Dr. Nina, and thank you, Dr. Allison. And we have had good discussions in the chat box, and there are a lot of good questions and answers too. So, one of the questions is, what is the recovery rate in these autosomal recessive variants? How is the prognosis in these autosomal recessive variants in general?
We don't know. The study is so scattered. This mutation is so rare. At least we looked. We have not come across with any good answers.
Thank you, Dr. Allison. Thank you. So we had a good discussion on this. So with that, we go to the next case, and I would like to, and I'll be happy to introduce next, I would like to invite Dr. Lulu Burstein, and I just want to introduce her. Dr. Lulu Burstein is an associate professor at Western University, and she's a comprehensive and neuro-ophthalmologist at the Western University in London, Canada, and done a neuro-ophthalmology fellowship at the University of Michigan in Ann Arbor in 2015, and teaches medical students and residents in ophthalmology and neurology, and has won both surgical and clinical teaching awards, and has 45 peer-reviewed publications. So I'm very happy to welcome Dr. Lulu to do the presentation.
Okay, thank you so much for inviting me back. Is my screen visible? Looks good?
Yes, it's visible and audible.
Okay, so I'm presenting a case that I've called a vascular oddity. So this is a 32-year-old previously healthy woman. She's currently 29 weeks pregnant, and she presents with new onset severe headache, vomiting, and progressive lethargy and cognitive impairment. She's unable to dress herself, she's very confused, so she's admitted to hospital for a complete workup. She has very, very extensive blood work, and the only thing that comes back abnormal is she's got slightly low vitamin B12 at 141, with a lower limit of normal is 145. She has a lumbar puncture that shows elevated protein, elevated IgG, elevated albumin, and a few nucleated cells that are predominantly lymphocytes. She has an MRI. These are just some selected FLAIR images, and you can see that she has some spoke-like lesions in the corpus callosum. She also has some hyperintense lesions throughout the basal ganglia, and also some lesions elsewhere. So she started on vitamin B12 and thiamine, even though that seems unlikely to be the cause of her presentation. But 2 weeks later, she develops bilateral sensory neural hearing loss. So she's sent for an ophthalmology exam, even though she has no visual symptoms at the time. Visual acuity is normal, fundus exam is normal. She does not get an IVFA at that time because of the pregnancy. So because of the encephalopathy and the hearing loss, and because of those typical MRI findings, she's given this presumptive diagnosis of Susac syndrome, even without any ocular abnormalities. She's treated with IV steroids and IVIG, followed by a prednisone taper. She's induced at 37 weeks because of intrauterine growth restriction. Once she's delivered, she now is sent back to ophthalmology for a repeat eye exam. She remains asymptomatic. Visual acuity is 20/20 in both eyes. The fundus examination looks grossly unremarkable, but if you have a very close look here, unfortunately on the Optos images it is obscured by eyelashes. I'll blow it up for you here. If you squint, you can see that there is this area of very faint retinal hemorrhages. So she has an IVFA, and we can see the left eye looks pretty unremarkable. In the right eye, there's some temporal vascular abnormalities, but we see this a lot on the Optos imaging. Don't really know what to make of it. There's nothing clear out here, but in the area where she had those retinal hemorrhages, you can see that there is some vascular wall staining, but if you follow that vessel along, this is a vein. This is not an artery like what we would expect in Susac syndrome. There, I'll just blow that up for you. So again, you can see this vessel wall hyperfluorescence with maybe a tiny bit of leakage around it. But again, this is a vein. So 6 months postpartum, she's now on a prednisone taper. She's feeling better. Her cognition is improved. Her hearing is improved. She still has no visual symptoms. She's had a repeat MRI, which shows some interval improvement. She's got some repeat fundus images here. You can no longer really make out those retinal hemorrhages. That area does seem to have resolved. So this is like a dynamic lesion. But when we get the IVFA here, you can see she now has a new, very typical looking BRAO. So I'll blow that up again. You can see here there's a lack of flow through the vessel here, and adjacent to there you see this vessel wall hyperfluorescence, and this is now in an artery. The vein that was abnormal previously looks a little bit less abnormal. So this goes along with Susac's. Now we're feeling a lot better about the diagnosis. So she comes back for her 1-year follow-up. This just happened actually this week. She's seeing her rheumatologist. She's currently being treated with prednisone, mycophenolate, and IVIG. And when she's seeing her rheumatologist, she complains of a recent onset visual disturbance in the right eye. She's referred for an urgent ophthalmology exam again. So this time now, we can see this area of retinal whitening here in the right eye, and corresponding to that same area on the IVFA, you can see a complete lack of perfusion of that area in the retina. And then if you look up here in the supranasal quadrant, you can also see that she's got a second BRAO that is asymptomatic. So in summary, this is a 32-year-old previously healthy woman diagnosed with Susac syndrome in her 29th week of pregnancy. She presented with fairly typical encephalopathy and neurosensory hearing loss. She had, again, a very typical MRI demonstrating these multifocal FLAIR hyperintense lesions, both in the basal ganglia and the corpus callosum. She's treated with IVIG and corticosteroids during and after pregnancy, and postpartum, her IVFA revealed this localized retinal venous occlusion, but no arterial occlusions. It wasn't until later in the disease course that she developed first an asymptomatic and then later a symptomatic retinal arterial occlusion despite ongoing treatment. So Susac syndrome, this is a microangiopathy of the brain, retina, cochlea. It's also sometimes known as secret syndrome, which stands for small infarctions of the cochlear, retinal, and encephalic tissue. The classic clinical triad is encephalopathy, retinal artery occlusion, sensory neural hearing loss, but only a third of patients actually present with the complete triad at the time of diagnosis. The three different components may be delayed by several months or may not necessarily always occur in the same patient. The pathophysiology is a bit controversial, not entirely clear yet. It appears to be an autoimmune endotheliopathy that results in this endothelial cell necrosis and subsequent microvascular occlusion. So anti-endothelial cell antibodies are found in only around a quarter of patients, but not in the rest. And it's really unclear why these endothelial cell antibodies would affect certain areas, the brain, the retina, and the cochlea, and not others. There have been a few autopsy studies. So in this one brain biopsy, researchers found perivascular inflammation in the leptomeningeal and parenchymal arteries and hypertrophy of the endothelial cells. And most of the infiltrates were found to be CD8 positive, and we do know that there is increased CD8 positive T cell population both in the CSF and the blood. So that may give you a little clue into the pathogenesis. So this is a rare disease with an unknown prevalence, female predominance, tends to occur in young adults, and it may present during pregnancy or postpartum. Common symptoms at presentation: headache in about 80%, cognitive impairment 48 to 64%, visual disturbance in about half, hearing loss or vestibular dysfunction in about half, and rarely some skin changes like libido reticularis. So patients really should have ancillary testing when you're suspecting this diagnosis. So the MRI can show these fairly typical white matter lesions. So you can see snowballs like this in the corpus callosum, or more spoke-like lesions in the corpus callosum acutely, and then later on in the disease course they may have these little black holes in the corpus callosum. Lumbar puncture will show elevated protein and may have a mild lymphocytic pleocytosis. Patients should also have formal audiometry, which shows bilateral low to middle frequency hearing loss. So we're more interested obviously in the visual symptoms. These can be unilateral or bilateral, are painless. Patients may describe photopsias or scotomas. The characteristic lesion is that of a branch retinal artery occlusion without intraocular inflammation. It's not typically known to cause a retinal vein occlusion or phlebitis. The very pathognomonic finding is that of a gas plaque, so shown in this image here. So these are lipid deposits in the arterial walls, and they tend to occur in more straight vascular segments rather than at bifurcations like we would expect from a cholesterol embolus. Less frequently, you can see focal retinal whitening, arterial or narrowing. You can see cotton wool spots like seen in this image here. The optic disc may be involved with some hyperemia or pallor. You may be able to actually see peripheral capillary closure. So retinal imaging, most typically in IVFA, and if you do this throughout the disease course, patients in 99% of cases will demonstrate at some point in time a BRAO. You're looking for arterial wall hyperfluorescence, such as that seen here and here, and it does not need to be adjacent to the BRAO. They can be quite remote and in totally different parts of the retina. If you're lucky enough to have access to ICG, you can actually see that there's involvement of the choroidal circulation as well. OCT is not so useful here. In the acute setting, you may see some RNFL thickening along the occluded vessels, and then in the chronic phase, you may see focal retinal thinning, but none of these are very specific to Susacs. So venous involvement is not thought to be typical of this disease. There's one case report from 2014 where the authors used ultra-wide field fluorescein angiography like we did, and they found not just the more typical appearing BRAOs and vessel wall hyperfluorescence, but they also found areas of phlebitis. So you can see highlighted here, this is a venous segment with that wall hyperfluorescence, and same thing in the other eye. There's also a case from 2011 where a patient died shortly after their diagnosis of Susac syndrome, and they did a full retinal examination. And what they found was that looking at the gross specimen, there wasn't any obvious visible involvement of the veins like there was of the arteries. But when they did pathology segments, you can see here in the B, C, and D row, these are arteries. And then there's this thickening of these dead endothelial cells, which is causing some occlusion of the vessel. But when you look at some veins in the EFG section, again, there's this very dramatic thickening, this hypertrophy of these necrosed endothelial cells with almost complete occlusion of the veins. So this was pretty good evidence that the veins are indeed involved, even if you can't see it clinically. When you look at them pathologically, they are compressed and they are involved. So they commented that there was occlusion in vessels of all calibers at all levels of the vascular hierarchy. So there were optic nerve, like peripapillary vessels involved, arterioles, venules, capillaries, they were all involved in some way. So treatment for Susac syndrome, the goal is this rapid, complete disease suppression with the hope of optimizing outcomes, but unfortunately there's really no randomized controlled trials to guide us. Typical treatment is with IV corticosteroids and IVIG. Really not well studied is use of immune suppressive medications like cyclophosphamide, mycophenolate, or rituximab. It's not really clear what the role of Plex is here, but that's actually what we tried on our patient to see if we can recover some of her vision. So key points, Susac syndrome has the potential to affect not just arterial, but also the venous retinal circulation. These findings may only be visible on ultra-wide field IVFA. So you would not see them if you're doing the 7-field montage on your traditional IVFA. You may not see any of this on fundoscopy. So if you have access to an ultra-wide field IVFA, then that really should be taken on all patients with Susac syndrome at multiple time points throughout the course of their disease. And this particular pattern of vascular involvement may provide some further insight into the pathogenesis of the disease, which we currently don't understand very well. And hopefully that will lead to better treatments. Here are my references, and happy to take any questions.
Thank you, Dr. Burston. And I just had one doubt that if a patient comes subacute vision loss with this compression, agreed, the retinal findings are more towards Susac and came with a classical triad. Are there any differentials what we would consider like a Cogan's or an ADEM?
I mean, it depends on what you see. So, I mean, the findings that we had in our patient, not at the beginning, but throughout the rest of her disease course, were so typical. I mean, you don't really see that segmental hyperfluorescence and those are occlusions along the straight segments really in any other disease. It is so pathognomonic for Susac's. So I will admit that my differential diagnosis was very short for this particular case.
Was tuberculosis any time in the differential having an Indian patient?
Yeah, so she did get tested for TB at the time of her initial presentation, and it was negative. So yeah, we'd absolutely thought of that, but.
Are there any imaging clues on the MRI which we can say that it is more towards this type of lesions which are attributing to a vasculitic etiology?
I don't think there. So the pattern of hyperintensity on the MRI with those spoke-like or snowballs in the corpus callosum, again, are extremely typical, but not everyone will have them. And the rest of the lesions really are not that typical to say, yes, this must be an endotheliopathy. It's only on the brain biopsy that you can really differentiate this one fluffy white matter lesion from a different fluffy white matter lesion. But the few studies that have had brain biopsies have shown very typical endotheliopathy. But I don't think you can distinguish that on an MRI.
And she had any specific antibodies positivity?
We don't have access to anti-endothelial antibodies at our institution. Does anyone? Do you guys have this? Is this available?
We refer to the rheumatology wing, and probably they may have the access, I guess.
Okay. I mean, again, I'm not sure it's that helpful because if you've got a negative result, I mean, 75% of
It
patients with
doesn't
Susac
change.
are going to have negative antibody.
So how frequently you get this ultra wide field angio photography and all these for your patients in your follow-up?
I get it every time. And so I'll see patients about once every 6 months or so, and I will get it every single time. And we just got a new device, the Silverstone, which seems to actually give slightly better images than the Optos. They're really beautiful, and there's a much less problem with the eyelash artifact. So that is one of the big bugaboos with the Optos is there's eyelashes everywhere. But the Silverstone has been really good, and so I'm extremely pleased with the images. So my plan is to keep collecting these because I think we find a lot more than we're looking for here.
Thank you. That's a great
Oh,
case.
Thanks.
Are there any other questions?
Any other question? Yeah. So there has been some questions in the chat box, immunoglobulins, but I guess you've answered that in your presentation. In the use of immunoglobulins, you've answered that, and I think yeah. So if that all, thank you very much, Dr. Burstein, and thank you, Dr. Ambika, for those questions. And Dr. Satya wants to share a slide. Dr. Satya, please go on.
Yeah, thank you. Am I audible?
Yes, you are.
Okay, so just wanted to share this slide about are you able to see the slide?
Yes, Satya.
So the 6th annual conference of the INOS is in Chennai next month, and we have very esteemed speakers at the conference, 2-day conference in Chennai, hosted by Ambika and her team. Thank you. And over to you, Mahesh.
Thank you, Satya. Next, I would like to introduce
Dr. Mahesh, can you stop and then reshare?
Oh, okay, I'll do that. Something happened. I don't know what happened. Is my slide visible?
And just reshare, please, again.
Okay. Share and is it visible now?
Yes.
Yes, doctor.
Yeah.
It's visible.
Yeah. So sorry for that. And next, I'm happy to introduce Dr. Andrew Carey, who is a Dr. Neil Miller, Rising Professor of Ophthalmology and Associate Professor of Clinical Ophthalmology and Neurology at the Johns Hopkins University Wilmer Eye Institute in Baltimore. He specializes in neuro-ophthalmology, medical retina, and genetic eye disease. He has special interest in unexplained vision loss at the intersection of the optic nerve and retina, and using ocular imaging to improve the diagnosis of vision loss. Dr. Carey, welcome, and kindly present your case.
Thank you all so much for inviting me. This is such an incredible conference every year, and it's an honor to be able to present. So I'm going to present a case of marked vision loss. And my co-author, Dr. Kelly Seidler, is one of our fantastic neuro-optometrists who helped in the workup and evaluation of this patient. I don't have any relevant financial disclosures, but to this case. So we begin the case with a 70-year-old Caucasian gentleman who came in with left eye sudden decrease in vision. He described it as a ring of watery motion-like vision, like looking through water in his paracentral vision. And he also described it kind of as like noise that started to impact the edge of a word he's focusing on, associated with severe nyctalopia. The symptoms have been progressive, and he says there's no associated photopsias. He first showed up about 3 days into vision symptoms and saw one of our comprehensive optometrists. No history of any trauma, laser surgeries, or other ocular procedures. He does have a choroidal nevus in the right eye. He's not using any eye medications. Only relevant systemic medication is aspirin 81 milligrams daily with no family ocular history. Medical history, he has high cholesterol, a meningioma, Crohn's disease, a cutaneous melanoma 8 years prior on the left heel that was resected, pneumonia in his 20s, and Lyme disease 20 years prior to presentation. And he does have factor V Leiden mutation as well as macrocytosis. He is a former smoker, a fairly high alcohol intake, and some recreational marijuana use. He does have dogs, and he's a retired computer tomography scan engineer. On his initial exam with optometry, he was 20/20 in both eyes. Optic discs were normal, and he was noted to have a large superior temporal choroidal nevus with drusen. And the plan was to have him come back for visual fields to better evaluate his vision symptoms. And this was his visual fields at that visit. You know, there's these scattered clusters in the right eye. This was a CETA faster protocol with mild fixation losses. The false negatives were off. And, you know, first time I looked at this visual field for the right eye, you know, I said, is this a retinal problem? Is this artifact from, you know, first field taking? And when you look at the pattern deviation, though, you said, oh, maybe that's a superior gerum scotoma and an infranasal step. And the left eye has this superior arcuate and an infranasal step. And so he was referred to see neuro-ophthalmology and came in to see one of our neuro-optometrists, Dr. Seidler. And at that time, he was 20/20 in both eyes, found to have a very dense RAPD in the left eye. Color vision was full, and his optic discs were still normal in both eyes. And this is the repeat visual field only 6 days after the original one. The right eye looks fairly similar, a little bit better reliability characteristics. And the left eye is markedly worse, with it now has a, you know, his depressed fovea and a near total scotoma. And so at this point, there was concern that there might be optic neuritis, and he was referred to the emergency room for urgent neuroimaging, although a little bit atypical for 70-year-old and normal color vision, so thought maybe this could be a compressive lesion or something else. The MRI was negative for enhancement, but he was treated with IV steroids anyways because of the rapid change in vision, and was afterwards came back to neuro-ophthalmology. Symptoms unchanged and examination was unchanged. And this is the visual field. The right eye looks fairly stable. The left eye may be worse, with his visual field index progressively decreasing, originally at 80%, now down to 26% prior to steroids, and after steroids down to 9%. At this point, he was referred to me. And the first time I met him, he said, my cutaneous oncologist said to tell you that I have a history of melanoma and wants to know if you think my vision problem is related to this melanoma. He's still 20/20 in both eyes with normal color vision and normal optic discs. And we did a size 5 stimulus visual field at that visit because of the dense scotoma in the left eye. And interestingly, it looks pretty close to normal in both eyes, except that the left eye has a suppressed fovea sensitivity down to 24 decibels. 4 days after the stimulus size 5, he came back and we did a size 3 because we said the size 5 is too normal. I can't use that to monitor his vision. And the left eye still has this total scotoma with a visual field index of 11%. The right eye is even worse than before and now has this very dense double arcuate scotoma. And this is a pretty big contrast between the size 5 and the size 3, and not something we commonly see in optic neuropathies to see such a discordance. This is his OCT of his macula. And on the volume scan, essentially, it looks pretty good in both eyes, but we can see there's these areas of thinning in the perifoveal region and perimacula. And on the cross-sectional imaging, not too different than what you might have seen in Lulu's recent case, is there's these focal areas of inner retinal thinning involving the inner nuclear layer that correspond to these areas of thinning in the retina on the volume map. And they're present in both eyes. And over the course of time, it's been progressively thinning for over 5 months with the total macular volume getting thinner. And so I said, is this a strange case of Susac's? Although the visual field is way worse than I would have expected based on the OCT. And so we did a fluorescein angiogram, and this was negative for vasculitis and negative for any acute occlusions. And so at this point, I am starting to say, what is going on with this patient?
Yeah, thank you, Drew. I think we'll pause and we'll just recollect as to saying there are so many, this patient, unfortunate patient has decided to have so many of these risk factors. I mean, first of all, he has Crohn's disease, which in itself can cause optic nerve issue, or the treatment can cause optic nerve issue. As you said, history of malignancy, melanoma. Now, melanoma, generally speaking, any cancer in the body can have infiltration of the optic nerve, like leukemia, or treatment causing an optic nerve disease, or autoimmune problem of the retina. So it'll be interesting to see how you worked up this patient.
So, as I said, the concerns that the discordance between the size 5 and the size 3 visual field, not typical for optic nerve disease or cerebral disease, and these findings on the OCT, along with the history of, made me think, could this be a retinal problem? And so we proceeded to get a full field ERG. And the most abnormal result on this is the marked reduction in the scotopic rod pathway responses, which is the dim flash. And this is a combined response of photoreceptors and bipolar cells. There's really no detectable A wave in a normal patient on the scotopic rod response. And so we're only looking at the B wave in that. And this is over here in the section of the diagram. He also had a marked reduction in dark adapted maximal combined B wave, which represents bipolar cells, as well as a marked reduction of the dark adapted B to A wave ratio, indicating that the patient has an electronegative response. His B to A wave ratio was 0.4, normal is 1.3 and above. There was mild reduction in the dark adapted maximal combined A wave response, which represents rod and cone photoreceptors, and mildly reduced light adapted cone wave responses. And so when you look at an ERG and you say everything's abnormal, I like to say, well, what's most abnormal? And that can really help to direct you down your pathway. And so the things that are most abnormal are the scotopic responses, and specifically it appears that it's mostly the B wave representing bipolar cells. And this, of course, is something that you would typically see in a patient with melanoma-associated retinopathy. And so I called his cutaneous oncologist and I said, I think it's melanoma-associated retinopathy. I'm concerned about a metastatic recurrence. And the cutaneous oncologist goes, I don't really think it's a recurrence. That melanoma was 8 years ago and it was not particularly high risk. Did not have a very significant Breslow depth. And I said, well, I'm pretty sure it is. And so what can I do to prove this to you? So we sent off the melanoma-associated retinopathy antibody panel to the KCI Institute at the Oregon Health Sciences University. It came back with positive arrestin, aldolase, and enolase antibodies. As has previously been described by a number of colleagues, though, these antibodies are not specific, and you may see these in patients who are normal, patients with other causes of retinopathy, like diabetic retinopathy, hereditary diseases, uveitis. The most specific of these antibodies for melanoma-associated retinopathy is the TRPM1 antibody, which was negative in this patient, but while it is fairly specific, it is very low sensitivity, only occurring in 5% or less of patients with melanoma-associated retinopathy. What was very helpful was the immunohistochemical staining, where they take the patient's serum and they apply it to a histologic section of retina. And what that was positive, showing moderate staining of the bipolar cells, which does help to correlate to the ERG and saying that these antibodies are attacking bipolar cells. And so we proceeded with a CT PET scan. And since his last one, there was a new finding in the proximal left external lymph node with increased metabolic activity, which is concerning for disease. And of course, this is in the lymphatic distribution of his previous left heel cutaneous melanoma. And so the patient went to surgery and had this lymph node resected, and it did in fact show metastatic melanoma in one of the 2 lymph nodes that were resected, a nodal deposit measuring 1.8 centimeters, and then there was extranodal extension. We had our fingers crossed, hoping that perhaps the patient's vision would improve after removal of the melanoma, which is, of course, the stimulus for the autoimmune condition. Unfortunately, he did not improve. Still 20/20, still has normal color vision, but his visual fields are actually the worst they've ever been. And so at this point, I called his ocular oncologist and I said, you know, he's not any better. Can we proceed to the next level of treatment? And so we set the patient up for plasma exchange therapy or plasmapheresis. And about 4 weeks after treatment, there was really no improvement yet in his field. But when he returned, 4 months after Plex, we can see there is this marked improvement in his visual fields. The patient says, I can see much better at night. I can see stars in the sky again, and I can see the rooftops on the houses across the street at nighttime, which I could not see before. And at 19 months into his disease course, 7 months after Plex, there is continued improvement in his visual field. And the patient is pretty ecstatic about this improvement. So some teaching points about melanoma-associated retinopathy. The clinical presentations and fundus findings can be highly variable. Visual acuity can range from 20/20, as it was in my patient's case, all the way to light perception. Visual fields can be highly variable. They may be normal, they may have a central scotoma, and they may have peripheral visual field constriction. The full field ERG is really probably our best ancillary test for evaluating these patients from a visual standpoint, and it classically shows the B wave depression. It may also show photoreceptor abnormalities as well. And as we had mentioned, the anti-retinal antibodies, they really lack specificity, but the immunohistochemistry classically shows staining of the bipolar cells, which really helps you to differentiate this condition from autoimmune retinopathies impacting photoreceptors. There are highly variable responses to treatment. Some patients may have improvement with tumor resection alone. We really want to be aware of autoimmune exacerbations with immune checkpoint inhibitors, as discussed in an earlier case in a patient who had pembrolizumab-associated PRES. You may develop other autoimmune conditions, and uveitic responses have been reported, including those mimicking Voigt-Koyanagi-Harada syndrome. Steroids are rarely helpful in melanoma-associated retinopathy, as well as other autoimmune retinopathies. Plasmapheresis versus IVIG likely have the best outcomes, but this is a very rare condition, and we don't have strong data from large groups of patients for this. And we think that you are more likely to have a better visual response and better visual recovery if your retinal anatomy is relatively normal, as opposed to significantly thin retina with structural changes in and significant loss in bipolar cells or outer nuclear layer and photoreceptor layers. This case was highly asymmetric. I think a lot of us are used to seeing rapid progression in cancer-associated retinopathies and bilateral involvement. But asymmetry is not uncommon in autoimmune and paraneoplastic retinopathies, and that is a very distinguishing feature that would separate it from retinal dystrophy, if you do see that. The acute onset and rapid progression is likely indicative that this is paraneoplastic rather than an autoimmune non-paraneoplastic etiology. There was a high discordance in that size 5 stimulus versus our size 3 stimulus visual field, which really suggests a retinal etiology rather than neurologic etiology. And the paracentral acute middle maculopathy lesions have not previously been reported in MAR, and it is unclear if this is a true correlation, even though that does represent bipolar cell damage, or it is a confounder. And it's something to keep an eye out. If you see that, that may tip you to think that this is MAR or at least a retinal etiology impacting or attributed to the visual impairment. And that's my case.
Thank you, Dr. Carey. An excellent case, and congratulations on the successful recovery of the vision for this patient. That's really good to hear. Rashmin, any comments?
No, fascinating. I mean, the way you persisted, and I think this case demonstrated how do you really differentiate in these kind of conditions, problem of retina versus optic nerve, because RAPD in the left eye on during one of those visits was a confounding factor. But then the visual fields, the electrodiagnostic tests, I think, helped us to make sure that this was a retinal problem. Would pattern ERG be of any specific value in these cases, apart from full field ERG?
That's a great question. I think, pattern ERG has been around for a long time, but the scientific publications behind it are not quite as robust. And certainly so pattern ERG, we think is really helpful for looking at ganglion cell function and is probably more reliable than visually evoked potential. So it may be helpful. I think if you have access to it, that can be good. But it's certainly less widely available. And so that may be harder to get. Multifocal ERG, which also is less available, only evaluates cone pathways. So patients who have particularly rod dysfunction with peripheral visual field loss, that may look normal and not as helpful. And it doesn't allow for quite the same type of distinguishing photoreceptor versus interretinal disease that you can do with full field ERG. So I think the full field is really helpful.
Thank you.
So any other comments, questions from any other panelists or anyone? Okay. So excellent case, Dr. Carey. Thank you very much for presenting this case. And with that, we go to the next presentation. I'm happy to invite Dr. Prem Subramaniam, who really needs no introduction. He's a Clifford Janus Merrill Endowed Chair in Ophthalmology and is Professor of Ophthalmology, Neurology and Neurosurgery, and Vice Chair for the Academic Affairs at the University of Colorado Eye Center School of Medicine in the USA. He is a founding member of the Marcus Institute for Brain Health, which serves to improve the functioning of patients with traumatic brain injury through intensive outpatient rehabilitation. He is an active orbitocranial surgeon with a specific interest in tumors of the skull base and small incision approaches. With this small abbreviated introduction, I request Dr. Prem to do his presentation.
Okay, thank you so much. And it's my pleasure really to present this case, which I've entitled Vision Loss, Simple Answers. And so I have no relevant financial disclosures here. And so this was an 80-year-old man, and he presented with 2 years of decreased vision in his left eye. His past medical history was rather typical for someone of this age, with hypertension controlled with one medication. He had a recent prostate cancer history diagnosis. In fact, 2 weeks prior to his presentation to us, and I should say that his initial presentation was to one of my colleagues, Dr. Jeff Bennett, not to me. He came under my care later. But hyperlipidemia, which is, well, he's on a statin. He had a history of a TIA for which he was on clopidogrel, and that had been remote. And he has a history of obstructive sleep apnea for which he states compliance with CPAP. So really, he had been in his usual state of health when he developed this decreased vision. Now, initially, before he was referred to us, so at the onset of his blurred vision that he noticed in his left eye 2 years prior, he'd actually had blurred vision in both eyes. And he went to see a comprehensive ophthalmologist after seeing an optometrist. They, of course, saw that he had cataract and did cataract surgery on him. His cataract surgery went well, no complications, but he had no improvement in the vision in his left eye. So in the referral pattern that is standard under these circumstances. He was sent to the retinal specialist who did a fluorescein angiogram as well as other testing and said the retina is not the problem. So at that point, the patient was told, oh, you know, sometimes people don't improve after cataract surgery. Go home and be happy that your right eye is seeing well. Well, he wasn't quite satisfied with that. And so as a result, he then decided to go ahead and seek another opinion regarding his vision loss. And at that second opinion, he was noted to have a pale left optic disc. I don't know if that had been noted before. We have no records from prior to that. His OCT was done at that point, again, for the first time, of the retinal nerve fiber layer, which showed a thickness of 66 microns, whereas in the other eye it was 93 microns. And he was given a diagnosis by this other eye care provider of prior NAION versus BRVO. And nothing further was done until actually he went back to see his primary care doctor. His primary care doctor, in again, 2 years after the cataract surgery, decided, let's get an MRI scan. And the MRI scan, as I'll show you, led to his referral to Jeff. And so he had this MRI, and at that point was sent for neuro-ophthalmic consultation, where it was noted that he had normal acuity in his right eye, reduced in the left, and RAPD in the left eye, maybe some generalized constriction on confrontation in the left eye. The anterior segment was normal, nice cataract surgeries, and he had temporal pallor of his left optic disc. The right was normal. And so two representative images, I'll show you a couple more, of an MRI of the brain. MRI of the orbits was not done at this point in time, but here we see a lesion that is suspicious for some type of enhancing lesion, of course, in the area of the proximal optic nerve near the chiasm, and just a bit more inferior to that, we have this axial image as well, suggesting perhaps some enhancement along the left optic nerve intraorbitally, but primarily intracranially. And here are a couple of coronal images as well as a sagittal image shown down below. And so at this time, again, he was referred to us for further evaluation. I'll come back to what we thought this might be and maybe get any thoughts from anyone else, although I think it's pretty straightforward. And so he had a visual field test done at that time, which, despite his 20/50 vision in his left eye, showed rather diffuse peripheral loss in the left eye, and the right eye just had a little bit of what we thought was eyelid effect superiorly at that time. His OCT, unfortunately, went along with what had been done previously, where we can see that the retinal nerve fiber layer and macular ganglion cell layer in the right eye are completely normal, while in the left eye, there is a marked loss in both of those structures. So he came to us at this point, having been given this prior diagnosis of NAION versus BRVO, and of course now has this new intracranial lesion. Now, remember that 2 weeks prior to his diagnosis, or to his visit with us, he had been given a new diagnosis of prostate cancer. And while some workup was underway, there were characteristics of his prostate cancer that were considered high risk for metastasis. And so the question came up, although this is a highly characteristic appearance for a clinoidal meningioma and with some extension along the proximal optic nerve, a PET CT scan had been done just prior to his visit as well. And this did show a little more uptake within the tumor than was characteristically expected for a meningioma. So at that time, it was just, there was some debate around whether or not this actually represented a meningioma or not. And so any comments at this point from anyone? Would you consider this to be something other than meningioma? I mean, we did not. We were not highly suspicious for that. And so the patient was referred to radiation oncology, and they evaluated him. They felt that indeed, because of his vision loss, the damage that was already done to his optic nerve at that point, that he was a good candidate for fractionated stereotactic radiotherapy. Because he was 80 years old, there was no consideration given to surgical debulking of this tumor, even though it did have a little bit of bulk to it. It was felt that both in terms of the history, the slow onset of vision loss, as well as the MRI characteristics, that typical treatment for with fractionated stereotactic radiotherapy. Again, 180 centigrade fractions, 5,040 centigrade total dosage, very standard treatment that he underwent at this time. And he tolerated it with no difficulty. So he came in for a 6-month follow-up. He was seen before that, of course, but showing you here is 6 months after his radiation therapy earlier this year. His visual acuity in his right eye was stable. Left eye had perhaps improved by a line. Of course, he still had an RAPD, poor color vision, and a pale left optic disc. And if you look at his visual fields, now I've shown you on the top row, that's presentation, that's the next visual field shortly after radiation, and the bottom was the visual field at 6 months. So you can see that there has been a demonstrable improvement. I think it is more than learning effect in the left eye that over that time that suggests that even though he had significant damage to his retinal nerve fiber layer and the macular ganglion cell layer from this tumor over time, that he did have good functional recovery, and he was pretty happy with things at that point. And he was supposed to come in about another 6 months at that time as well. Not surprisingly, you're not expecting that he's going to recover either retinal nerve fiber layer or ganglion cell complex anatomy. This is a nice example, I think, of how these patients can still have some functional recovery despite seemingly poor prognostic indicators before the radiation is done. We can come back to that in the discussion if people would like. I'm not going to say more at this point. 1 year post-treatment, about a month before he was supposed to return for his follow-up with Dr. Bennett, he showed up in my clinic. Jeff was cruising the Mediterranean, of course, and he says, "I think my vision is worse." And it was 20/80 eccentrically in his left eye now. Remember, he was 20/40 before. He had an RAPD in his left eye. His anterior and posterior exam was stable. Not surprisingly, his left optic nerve still looked pale. And now, remember I showed you he had that remarkable recovery of visual field in his left eye. It's now completely gone. The right eye showing a few scattered points, I think, are just noise. We did not feel that was any evidence of disease on the right side. So now he's 1 year out from radiation. He was doing great, and he has this decreased vision. We're immediately concerned. What could this be? Could this be tumor progression? Could this be something else? Were we wrong? And was this actually prostate cancer? And that was inadequate radiotherapy to it. So we got a repeat MRI at this point, an orbital MRI. And I'm just showing you 3 representative cuts of a T1 gadolinium enhanced coronal images of an orbital MRI. And I think you can appreciate that this is the tumor. And there was a little bit of lucency within the center of that. And but there was also enhancement both posterior and anterior, proximal and distal to this tumor. And this had not been seen before, especially not the proximal signal. And so the radiologist actually read this and said, well, on T2 images, what I haven't shown you, there's not characteristic change for meningioma, and I'm seeing this lucency. Maybe this is a thrombosed aneurysm, and you all had it wrong the whole time, and this is some sort of new lesion. That didn't make a whole lot of sense to us. We were, again, looking, we're saying, is that really going to explain what is happening with this patient? We look again at these images with this enhancement right in the optic nerve adjacent to the area of the radiation therapy. And we were much more concerned that this could be radiation optic neuropathy, despite the fact that he had received very standard therapy and in a very focal area of the optic nerve. And so given that this was likely radiation optic neuropathy, I didn't plan this, but I'm flanked by 2 speakers who have written just a lovely review on this topic that was published last year in the BJO. There was also a meta-analysis or systematic review, not a meta-analysis, of radiation-induced optic neuropathy and retinopathy that was published in the same year. And I encourage you to look up both of those studies because they're great reviews in this area. I don't have time to go into it in detail, but it typically happens long after radiation therapy with a peak onset perhaps 12 to 18 months after the initial treatment, although it can be seen years later. Risk factors, which our patient really didn't have aside from age, seem to be high fractions, high total dose, repeat treatment, perhaps diabetes. And in this graph from the second paper, looking at the systematic review, you can see that most of the cases, the higher prevalence of optic neuropathy, of radiation optic neuropathy in this bubble plot is really seen, except for some outliers, in those individuals who received more than 54 gray of total radiation. So that does seem to be a major risk factor not present in our patient. So thinking this is radiation optic neuropathy, what are we going to do? Well, traditionally, the treatments have included things like corticosteroids because we are neuro-ophthalmologists and no one goes blind without a trial of them. Pentoxifylline may help. Hyperbaric oxygen has become extremely popular and is much more widely available now in anticoagulation. And the data behind all of these is pretty darn poor. However, bevacizumab has been studied recently. And again, I direct you to the review published by Drew and Neil and their co-author on this topic to really get more data on this because I don't have time to go into detail. But it is the one treatment that has been suggested and shown with some reasonable data to be potentially effective. So this patient was hospitalized and started on 7.5 milligrams per kilogram IV. Doses have ranged between 5 and 10. He tolerated it with unclear effect. It was infused again 3 weeks later. He noted some lethargy with the infusion, but no change in his vision. And when unfortunately he returned to see us, his vision had actually deteriorated in his left eye, and he really felt that he didn't think it was any different. I think that 20/80 was just a very lucky island given that terrible visual field that he had. And of course, his anatomic parameters still look bad. So he was supposed to get 2 more infusions of bevacizumab. He declined them because he wasn't doing well. He didn't feel it was helping him. Logistically, it was hard for him to get in. He was taking care of his wife who was ill. And so really the ultimate outcome was that he remains at count fingers and we'll see how he does over time. So in conclusion, I mean, going back to the very beginning, you should look for optic neuropathy before doing cataract surgery. Almost certainly this patient had evidence for optic neuropathy before his lens was removed. When he presented to us with his new vision loss just recently, the findings for radiation optic neuropathy may be subtle. That enhancement was not initially considered to be typical, and I had to argue that that was the most likely diagnosis, and that progression of meningioma or some other disease, metastatic prostate cancer, was just not particularly likely. Timely and the enhancement has improved with time, as it typically does in radiation optic neuropathy. Timely treatment is definitely appropriate, but despite best efforts, visual acuity may not always recover. And so I thank you. Unlike in Drew's case, I was unable to recover this patient's vision, but I hope this has been instructive to everyone.
Thank you, Prem, and it's an excellent case. And there is a question on by Dr. Drew that if CT had been done prior in the first instance, would it have shown was it done, and whether it showed any calcification or bony erosion to prove it's probably a meningioma?
It was done, and there was some subtle calcification within it. I did not show that to you because it was a CT brain and the quality wasn't great, but it did show that.
Okay, so that could have helped us narrow the diagnosis to meningioma. And till what duration can we expect development of a radiation optic neuropathy after the initial radiation? Is there any time limit? You said the peak instance was around 12 to 18 months or so, but is there any time limit till which we can expect that?
As an outer limit, I think I would have to look back and see what the latest case, and perhaps Drew or Neil remember from when they did their review, but I mean, I've seen it 6-7 years later. I think the risk does go down after that in terms of just the incidence, but it may be an acquisition bias because those patients don't come back to the person who originally saw them.
Okay. So
and then the shortest duration I've ever seen is 6 months.
6 months, okay. How worried should we be about the
Actually,
development
two types of radiation optic neuropathy. There's an acute change either during or very shortly after, and that usually is short-lived and you can treat with steroids and it often gets better. And then it's the type that Prem was talking about, and Drew has a lot more experience than I do in terms of using anti-VEGF agents.
Thanks, Neil.
And Drew, any comments on that?
Yeah, I think the early phase is usually inflammatory. I agree with Neil. Sometimes, the tumor will swell, and then as proton radiation is becoming more and more used, and we don't know nearly as much about its tissue interactions, it is certainly more inflammatory, and we may see more damage or more of the early stage. I agree with Prem. I think probably about 7 years for optic neuropathy. There's not too much after that. And those statements are all for patients who've had single doses of radiation. For folks who have malignancies or recurrent progressive meningiomas, they get multiple radiation. I think all the rules get thrown out the door. And of course, patients can also lose vision from retinopathy, if it's whole brain radiation and they're going to radiate all the way up to the posterior globe. And there's no rule about how late that can occur down the line.
And should we be worried about the development in the other eye also at some instance, at some point of time?
I think, yeah, I mean, I think in this case, and in most cases, when it's unilateral disease and unilateral radiation, the fellow eye will not have received a dose sufficient to cause radiation, either retinopathy or optic neuropathy. The only case, like Drew just mentioned, is if you have whole brain radiation where the retina may be exposed to that in those instances. The ones where I have seen it is sinus malignancies where they're giving 70 gray and a pretty wide field, then you may have exposure to the contralateral side as well.
So thanks very much, Prem, and for that wonderful discussion and an excellent case. So with that, we go to the next presentation, and I'm very honored and happy to introduce Professor Neil Miller, who really needs no introduction. Dr. Miller is Frank B. Walsh Professor of Neuro-Ophthalmology and Professor of Ophthalmology, Neurology, and Neurosurgery, and from the Johns Hopkins University School of Medicine, Baltimore. And he has authored over 580 articles, 97 chapters, and 15 books, including the well-known Walsh and Hoyt's Clinical Neuro-Ophthalmology, as well as the present one, which is the Essentials of Walsh and Hoyt Clinical Neuro-Ophthalmology. And he's also the author of the Neuro-Ophthalmology Survival Guide, a textbook designed for both physicians and students. He has given 65 named lectures around the world and has been involved with many clinical trials in the field of neuro-ophthalmology. So we welcome Professor Neil Miller. A great honor for you to invite, for me to invite you here. Dr. Miller.
Okay. Well, Dr. Plant and I apparently have the same philosophy regarding footballers. So we have a similar one, although mine's a little younger. And this was a 13-year-old healthy boy who noted a floater in his right eye 2 weeks after having been hit in the face, including the right eye, with a soccer ball. His past medical and surgical and social histories were negative. He was on no medications. When he was seen by an ophthalmologist on the outside, his visual acuity was normal. Color vision wasn't tested, but visual fields were full to confrontation, pupils, eye movements, slit lamp tensions, all normal. But he had significant right optic disc swelling. The left disc was normal. The retinas were felt to be normal. So he was sent to Hopkins ED for a diagnosis of either unilateral papilledema or traumatic optic neuropathy. He had a neurologic exam that was normal, MRI was normal, and there were plans made for a lumbar puncture, but ophthalmology was consulted first. The MRI was read as normal. However, you might be able to see that there is a little bit of enhancement and elevation of the optic disc on the right side, but nothing much in the orbit. The optic nerves were fairly unimpressive. Certainly no enhancement of the sheath on the right side or evidence of definite blood. When we saw him, his visual acuity was 20/20 with normal color vision, normal pupils, normal eye movements, normal slit lamp, normal tensions. His visual field showed an enlargement of the blind spot. And here are his discs. And you can see the left one is small with no cup. I'll come back to that in a little bit. And the right one is swollen, pretty impressive actually here, with some peripapillary atrophy. So the question is, what would you do next? Would you do a lumbar puncture? Would you do blood studies? And if so, which ones? Should he have an urgent optic nerve sheath fenestration for anterior traumatic optic neuropathy? We know that most indirect optic neuropathies are retrobulbar, but every so often you have an anterior one. There's disc swelling, sometimes a CRVO-like picture, and you can slit the optic nerve sheath and let out the blood, and some people get better. Is there something else that people would do? Any thoughts?
So the patient doesn't have any visual loss, right?
Correct.
So why would we intervene? We should not intervene.
I didn't say you should intervene. I'm just asking if anybody would.
Yeah.
Well, we did a test. Any thoughts about what that test might have been?
An angiography.
Ultrasound?
Nope, we did an OCT. And if you look closely, on the left side, everything looks pretty normal, but you can see these strands on either side of the optic disc. So here's the left eye, and here's the right. And here's another picture, left and right, not quite as impressive, but it's there. So what's the diagnosis?
So there's a vitreous traction on the disc, on the margin.
Yeah, vitreopapillary traction syndrome. Secondary, maybe to the trauma. I'd be interested in people's reactions to that. The patient was followed, and 2 months later, his floater had disappeared. The optic nerve disc swelling had resolved, and the OCT, it's actually, I'll show it to you because there is a little bit of traction, I think, still there, but you can see the optic disc is no longer swollen. Again, it's a small, slightly small disc and no cup. And you can see that the OCT, if you look at this middle one on the left, it does look like there's some debris still there, or a little bit of the vitreous that's sitting on the disc. But in fact, there's no more traction on the disc, and it's normal size. So I just wanted to point out very briefly that this vitreopapillary traction syndrome is significant because it can be mistaken for papilledema, papillitis, even NAION, but it's easily diagnosed with OCT. We presented, actually, reported a similar case some years ago of a patient with bilateral vitreopapillary traction syndrome that the patient had been placed on, had LPs, had been placed on Diamox, and nothing happened. And then finally we saw the patient and the OCT showed clear traction. I do think it's important, and I'd be, again, very interested because this is a controversial topic. There are some individuals who believe that at least some cases of so-called NAION are actually due to vitreopapillary traction. There was a lovely article from Duke, however, that as far as I'm concerned, answered the question. They did an SD-OCT in 80 eyes. Co-prevalence of posterior vitreous detachment was 30%, which is a similar prevalence in unaffected eye. No evidence of vitreopapillary traction on presentation or final follow-up of patients with acute NAION, and 5 eyes who'd already had posterior vitreous detachment developed NAION months after resolution of the swelling. So they concluded that VPT is not mechanistically related to the development of NAION. And if you have a pre-existing posterior vitreous detachment, it doesn't mean that you can't develop NAION. And I would refer you to Jane Chan's article last year in the JNO, where she points out, and this case is a good example, that vitreopapillary traction can cause optic disc swelling, but it's not at all typical, at least in my opinion, an AION. And I'll just stop there.
Thank you, Dr. Miller. Panelist Dr. Swati, would you like to add anything?
Yes, I actually have one or two questions for Dr. Miller. That was indeed a learning experience from your case. So when would you exactly suspect, particularly if it's a bilateral swelling, the first thought that comes to mind with a good visual function is papilledema. So when would you exactly suspect that this is because of vitreopapillary traction?
I think it's a little bit like the comments that were made about Leber optic neuropathy. You need to look at the setting in which it's the disc swelling's occurring. What are the other components, any constitutional symptoms, any other ocular symptoms, neurologic symptoms, etc. I think in this day and age, and I don't know about the rest of you, but certainly my colleagues at Wilmer tend to get OCTs on a regular basis for anybody with any type of optic nerve disease, not just disc swelling. So I think that what's happening is that we're picking these things up a lot faster. But I think it would be unusual for papilledema to occur without neurologic manifestations. Now, granted, a lot of people come in, yeah, I have headache, and then you're stuck. But I think it just should be kept in the armamentarium. I'm not convinced that I can tell for sure the difference between standard disc swelling and disc swelling caused by vitreopapillary traction. So it just needs to be on the differential. And I also think the symptoms are a bit different. Either they have none, or maybe as in this child, a floater as opposed to blurred vision or loss of vision.
Yeah, maybe. And I was just wondering, just thinking loud, that will the retinal nerve fiber layer thickening in such cases will be much more localized as compared to, a generalized disc swelling where you have optic nerve pathology per se? Will it be localized to fractional area or something? I'm not sure. I'm just thinking.
Yeah, it's probably somewhat variable in terms of where is the vitreous traction all the way around, or is it in a particular area? It's an interesting issue. I don't know.
Maybe we may look into this thing, subsequent patients whenever we see that. And even I was just going through literature, so I found that most of this, some of these patients can have intrapapillary hemorrhages also, which may contribute to disc swelling. So in that case, do we need to do anything?
I don't think it's necessary, but I agree with you that there's no reason that traction on the peripapillary area, there's no reason that couldn't tear a little blood vessel and cause some hemorrhage. It wouldn't change my concern about it.
Okay, but have you ever come across patients who have had some kind of visual disturbances because of VPT?
Yes. Years ago, we had a patient who came in who had blurred vision, and it looked like she was seen by retina as well at our institution, and it looked like what had happened was that the traction had caused a hemorrhage in one area, peripapillary hemorrhage, and that had grown to a point where it had blocked some of the field.
Right. So enlarged blind spot is what we are generally looking for in these cases.
Yes.
Okay. Thank you. Thank you, Dr. Miller.
Thank you all.
Thank you, Dr. Miller. Yes,
I'm curious to know why you chose the title goal for this case.
Well, he was a footballer.
Okay.
Okay.
Does it
So-
have something to do with the kind of focused injury that he had? It was only on the disc and nowhere else.
Fair enough.
Okay.
No. So thank you, Dr. Miller, for that case. And next, I would like to introduce finally Dr. Zoe Williams. I'm happy to introduce her. And Zoe Williams is a professor of ophthalmology, neurology, and neuro-ophthalmology, and a fellowship and director and chief of neuro-ophthalmology service, the University of Rochester Medical Center in Rochester, New York. And her areas of interest were she was the chair of the basic and clinical science course, of which we are all well aware of, the Section 5 Neuro-Ophthalmology Committee. And she serves on the American Board of Ophthalmology, Neuro-Ophthalmology Exam Development Committee for written and oral board certifications. And she's a section editor of the Neuro-Ophthalmology Virtual Education Library, which is listed in the NANO's website. And she's also the vice chair of the curriculum committee for the North American Neuro-Ophthalmological Society. Welcome, Dr. Williams, and I request you to present your case.
Thank you so much for the invitation here. Is that visible to everyone in the slideshow?
Yes.
Okay, great. So I'm going to harken back to session 1 and Luciano's case, but my case is entitled COVID Causation or Coincidence. So the case is a 67-year-old Caucasian female who had COVID 6 weeks prior and presented with painless vision loss in her left eye. She had symptomatic COVID with upper respiratory infection and headaches in early February of 2022, went on a ski trip afterwards in Colorado and Utah, and then developed mild recurrent frontal headaches, which she attributed to altitude and dehydration. One day after returning to Rochester on March 16th, she had sudden onset of painless vision loss in her left eye. And she described this as when she occluded her right eye, it looked like she was looking at a Monet painting. She denied any dimming of her vision or noticeable color vision loss, and she denied any preceding transient vision loss or diplopia. She was seen by optometry the next day and had 20/30 minus vision in both eyes. A left APD and left optic disc edema were noted, and they did an initial workup with negative inflammatory markers, a normal CBC, no anemia, no normal platelets, and a normal ANA, ANCA, and ACE. And she also had a non-contrast MRI of the brain, which was limited by motion artifact, but normal. And I did review this and have the scan here, and there is no T2 hyperintensity of the optic nerve on that left side. Maybe the nerve looks slightly larger there, but this was, as I said, read as normal. So her past medical history, she had melanoma in situ, which was excised in 2017, and depression. She was a former smoker. She drank a fair amount of alcohol. Her parents had vascular risk factors, and her sister and brother both had cancer. On review of systems, she had no jaw claudication, scalp tenderness, and explained weight loss, fevers, or myalgia. She just had the headaches and malaise that she had had after recovering from COVID. So on my exam, this is now 13 days after her vision loss. She'd had a little bit of subsequent decline in the left eye from 20/30 minus to 20/50. Her color vision was 9.5 out of 14 in the left eye. She had a left APD. Motility was full. She was orthophoric in all directions of gaze, had a normal external exam, and her slit lamp exam showed no cell, just mild cataract. The optic disc exam was normal for the right eye. The left eye, I'm sorry, in the right eye, cup to disc was 0.4. In the left eye, she had a sectoral swelling, which was predominantly nasal and inferior. It was hyperemic, and there were multiple peripapillary cotton wool spots. And there was no peripapillary hemorrhage. I'm sorry, I don't have a picture, but I will have an OCT to show you. The macula was normal with no subretinal fluid or exudate, no cotton wool spots. There was a little bit of arterial attenuation on the left side, and the periphery was normal. So just to show you the visual fields here, normal on the right. The left, I think, is open to a little bit of interpretation, but enlarged blind spot, it's predominantly inferotemporal, extending through central fixation, or you could say it's predominantly central, extending inferiorly. And then on OCT, she had a normal RNFL in the right eye. In the left eye, there was mild edema, which the OCT also showed was sectoral. And then she did have some ganglion cell thinning actually bilaterally. So just to summarize, a 67-year-old woman with mild to moderate painless vision loss that progressed mildly over 3 days, mild optic disc edema with peripapillary cotton wool spots occurring 6 weeks after COVID. There's no contralateral disc at risk. She's had a prior non-contrast MRI of the brain that shows no T2 hyperintensity of the left optic nerve, and her inflammatory markers are normal. So I may just go to this in the interest of time here, but I think the biggest things on the differential would be ischemic optic neuropathy and anterior optic neuritis. So as far as favoring AAION, she did have a slightly larger contralateral cup to disc ratio. She had recent malaise and new onset of headaches, and she has the peripapillary cotton wool spots, but inflammatory markers and platelets were normal, no preceding transient obscurations of vision. She does, as far as for NAION, have sectoral optic disc edema. Maybe you can say that's an altitudinal-ish visual field defect, but no contralateral disc at risk and no vascular risk factors that had been previously identified. And then for anterior optic neuritis, she does have slightly disproportionate color vision loss. This vision loss did occur post a viral illness, but absolutely no eye pain, no pain with eye movement, and no T2 hyperintensity of the nerve on her prior MRI. And then, of course, there's a few other things on the differential. So optic perineuritis, again, no pain, and it's not a purely peripheral vision loss. Compressive optic neuropathy, we don't see an orbital mass on her prior MRI. Infectious inflammatory infiltrative, so again, no T2 hyperintensity of the nerve and not a severe vision loss, which I know this can be somewhat variable, but generally for this and optic neuritis, 2 weeks after vision loss, you might expect it to be a little bit worse. And then neuroretinitis, there's no cell on exam, no exudate. And although, again, not 100%, the temporal disc is the least edematous on exam. So the patient told me at that initial visit that she was leaving for vacation for 3 weeks in 2 days. This was March of 22, so I knew I couldn't get an MRI in 2 days without admitting the patient. And I didn't feel like she had a reason that she had to go to the emergency department during a pandemic when her vision had not changed much over the initial 2 weeks since vision loss. So I did what we could do to rule out what we had to before she left, and I started her on prednisone 1 mg/kg, pending temporal artery biopsy, which was negative. So she received just 2 days of prednisone, 60 milligrams daily, and then discontinued. Her hemoglobin A1C was normal. Lipid profile did show elevated cholesterol and LDL. And then I ordered the MRI of the orbit with and without gadolinium, but even stat could not get that in 2 days. So that was pending. So she went away on vacation and returned 3 weeks later, which was now 5 weeks after her vision loss. And she's got her MRI pending in 4 days. And her vision's improved in the left eye. She said she had slight dimming of her vision in the left eye. There was no appreciable color vision loss, no peripheral vision loss. And the visual acuity is actually not much change. She was 20/40 -1 from the prior 20/50, but her APD is better. Her color vision's full. Her visual field, which I'll show you, is full, and there's no residual disc edema. So these are the visual fields now 5 weeks after onset of vision loss. And here's her OCT. So this shows that there is resolution of the disc edema. There is borderline thinning temporally. Actually, on this OCT, that was also shown in the right eye. That subsequently in the right eye wasn't seen again, so I'm not exactly sure what happened there. And then we do have some ganglion cell thinning shown, and it's a bit thinner than it was initially. So obviously at this point, this is not ischemic, and an atypical anterior optic neuritis is the most likely diagnosis, and MOGAD was ordered. So 4 days later, she got her MRI of the orbit, and the axial T2 does show T2 hyperintensity of the left optic nerve, and then her contrast-enhanced T1 with fat suppression shows a longitudinally extensive enhancement of the left optic nerve, and you can also see some perineural enhancement extending to the orbital fat. So very consistent with the radiologic appearance of MOGAD optic neuritis. So her MOG-IgG was positive at a 1 to 1,000 titer, and I talked to her about restarting steroids with a slow taper, but she deferred. She said, my vision's great, and she had prior side effects for the 2 days she was on high-dose prednisone, so she elected to observe and call me if she had any subsequent visual decline. And she actually didn't. So she came back 6 weeks later, now 3 months after the vision loss, and visual acuity was actually a bit better. So 20/25 in both eyes now, still full color vision. The APD was the same, and now she has temporal optic disc pallor in the left eye. At this visit, she did report some band-like truncal sensory change, and this prompted cervical and thoracic spine MRI, but actually there was no cord enhancement shown, just spondylosis with degenerative disc disease. So we continue to observe, and a little bit over 3 months later, so now 7 months after the vision loss, she came back and the OCT showed further thinning of her retinal nerve fiber layer, and the temporal disc pallor was still present, obviously, and to my mind had not progressed there to diffuse pallor, and she was stable. So MOGAD is a CNS demyelinating disease, which is usually associated with optic neuritis, transverse myelitis, or acute disseminated encephalomyelitis due to serum autoantibodies, which are directed against myelin oligodendrocyte glycoprotein. Less commonly, MOGAD will cause cerebral cortical encephalitis, brainstem presentations, or cerebellar presentations, and it can have a monophasic or relapsing course. There have been recent diagnostic criteria that have been revised, and this is as of 2023. So the diagnosis requires fulfillment of A, B, and C, so a core clinical demyelinating event, of which optic neuritis will count. Positive MOG-IgG test is defined as a titer greater or equal to 1 to 100. So our patient would fall into the clearly positive. And then in that case, no additional supporting features are required other than exclusion of better diagnoses, including multiple sclerosis. If the titer is a low positive, or if it's a positive MOG without a reported titer, or if the serum titer is negative, but the CSF titer is positive, then you need supporting clinical data, or MRI features, which for optic neuritis would be bilateral simultaneous clinical involvement, or the longitudinally extensive optic nerve involvement, so more than 50% of the length of the optic nerve, perineural optic sheath enhancement, and optic disc edema. So there was a very nice paper that came out looking at differentiation of NAION and MOGAD optic neuritis that's unilateral. So this was a multi-center case-control study. They had 64 patients presenting with unilateral MOGAD optic neuritis. They required that the initial attack had to be at age 45 or older, so that it could be age matched with the group of patients who had NAION presenting. And all of the patients in the MOGAD optic neuritis group fulfilled the 2023 updated diagnostic criteria. And they did a multivariate analysis to determine statistically significant predictors of MOGAD optic neuritis. So for this group, because they set the age higher to qualify for inclusion in the study, the median age was 56, 70% were female, and 78% were white. And so the differentiating factors that they found were that eye pain was strongly associated with MOGAD optic neuritis with an odds ratio of almost 33. And 89% of patients with MOGAD optic neuritis have pain with eye movement, usually preceding the vision loss. A crowded optic disc or an altitudinal visual field defect were both strongly associated with NAION with an odds ratio of 0.03 for both. And then interestingly, this one kind of surprised me, the peripapillary retinal nerve fiber layer thickness in unilateral MOGAD optic neuritis was actually lower than in NAION, so a median of 114 microns versus 201 microns. And if you compare to the unaffected eye, it was just an increase on average of 25 microns for the MOGAD optic neuritis versus 102 micron increase in NAION. More severe vision loss at nadir was seen with MOGAD optic neuritis, so 2200 was the median visual acuity versus 2040 for NAION, but there was better visual recovery in the MOGAD group versus NAION at 3 months. In terms of COVID-19 being a potential trigger for MOGAD-associated optic neuritis, this has been reported with quite a few cases for optic neuritis and for other presentations. And we do know that depending on what you read, between 30 and 70% of MOGAD is associated with a pre-viral or pre-infectious, at least, agent. So how does this happen in terms of COVID? So SARS coronavirus 2 can cause neurotoxic effects by binding to the ACE2 receptors that are in the blood vessels in the CNS. It can also induce cytokine release with disruption of the blood-brain barrier. it can increase blood coagulation and trigger autoimmune mediated demyelination. So the idea is that you get a dysregulated interferon response and then upregulation of pro-inflammatory cytokines, including interleukin-6. And then the host's response activates the MOG-IgG1B cells, which of course increases the titer. And then with disruption of the blood-brain barrier, those MOG antibodies enter the CNS and then cause the MOGAD. So there was a review, probably the largest amount of cases that I could see, which was 17 cases of SARS-triggered optic neuritis with or without spinal or cerebral demyelinating lesions. And in these reported cases, the majority were bilateral. There were a few unilateral cases reported in children, and all had visual improvement, often dramatic, after treatment with IV methylprednisolone, followed by oral steroids of various taper length. And the patients tested positive for the MOG antibodies anywhere from a week to 6 months after their positive COVID testing. So the questions that I had for a discussion with the panel were, if the MOGAD-associated optic neuritis is triggered by COVID or another infectious agent, how do we account for the unilateral cases? We know that optic disc edema and bilateral MOGAD optic neuritis is often described as moderate to severe, and I think that's always been my experience in these cases. But the case control study that was performed showed that first attack unilateral MOGAD optic neuritis was usually mild in terms of the disc edema. So does this suggest that there's a different pathophysiology going on in unilateral versus bilateral cases? And then finally, there have been about 8 cases that John Chen's group has reported where the patients with MOGAD optic neuritis for one reason or another were not actually treated and had excellent recovery. So in general, we do try to treat these patients rapidly with IV methylprednisolone, and there have been studies that have shown within 2 days of vision loss is ideal in terms of promoting faster visual recovery. And we know that MOGAD optic neuritis has a high rate of relapse. So why are there some patients with MOGAD optic neuritis that have excellent visual recovery without treatment or even with minimal steroid treatment, like this patient who only received 2 days of treatment and did not relapse? Thank you.
Yeah, thank you, Dr. Williams. So we'll have some question of discussion by Dr. Durga. Would you like to?
That was a great case, Dr. Zoe. Actually, I don't have answers for the questions that you've asked, and I had the same queries when you had shared the abstract. And definitely, I feel the MRI contrast has helped you in the diagnosis of this patient as an optic neuritis.
Oh, yes, definitely. I think if we could have gotten the MRI sooner, that would have sealed the diagnosis as an anterior optic neuritis. And it did have all the characteristic features with the longitudinally extensive enhancement, the more anterior enhancement. Some of these can extend to the chiasm, but that's more rare than with NMO. And then the perineural enhancement is quite characteristic for MOGAD. But I think once the patient came back and had a normal visual field, that would be very atypical for, either an NAION or an AAION to completely resolve. That I think really doesn't happen. So at that point, it was clear it wasn't ischemic and that it was just an atypical case of optic neuritis that didn't have any pain with eye movement or any pain at all. It was a little atypical as well because usually the vision would be worse by the 2-week point, and she really hadn't changed that much from onset of noticing it from 2030 to 2050 over those 2 weeks.
Yeah. And I have another question. May I know the severity of the COVID that the patient had 6 weeks ago before the vision loss? And can there be any correlation between the severity of the disease, viral illness, and which could have triggered the optic neuritis?
Yeah, so hers was very mild. And actually in those 17 reports, they were predominantly mild cases of viral infection. So she wasn't treated. She basically just had headache and upper respiratory symptoms, which resolved on their own, and then had the recurrent headache when she was skiing and some malaise. And that was a little unclear whether that was related to COVID or if it was altitudinal sickness or what it was. But yes, hers was very mild. And she had received 3 vaccinations, the Pfizer vaccine for COVID before this happened without problem as well, and then 2 vaccinations afterward without any relapse either. So There have been very rare reports of vaccination-induced MOGAD as well, but it was not a factor for her, luckily. So,
and
So we have,
another question, yeah, yes, sir.
we have a comment by Dr. Miller.
Is Durga finished? I think she had another question.
Sorry. Yeah, please go on, Dr. Durga.
Yeah, and did you have any pro-inflammatory cytokines for the patient in the workup?
no, so she ended up not getting a lumbar puncture. It was planned if the MRI wasn't revealing, but then actually the MRI was pretty characteristic, and then the MOGAD came back shortly afterwards, so the MOG testing. So she ended up not having a lumbar puncture. But from what I've read, it's actually rare to find coronavirus in the spinal fluid in these cases, but you probably can test. I don't know if this is really done, but you probably can test for some of the cytokines or interleukins in the spinal fluid, I would imagine.
Okay. Miller had some question.
Well, this is a great example of why there's so much controversy about what you do with a MOG antibody-related optic neuritis. You know, when it first came out, it was sort of like, well, you need to differentiate it from NMO, but it doesn't have the same visual prognosis. But the group from France showed that a substantial percentage of their patients, treated or untreated, had permanently worse vision. And that's led to a controversy about whether these patients should be treated with long-term immunosuppression from the beginning. I remember talking to John Chen, who I consider one of the world's experts in this field, maybe a couple of years ago, and his feeling was with the first attack of optic neuritis, you just treat acutely and nothing else. And if there's a relapse, then you go ahead and treat long-term. However, there was just an article this last month that suggested that it is much better in terms of relapses, just like NMO, to treat right away. I don't know what people are doing in these cases. Zoe, did you consider, obviously she got better pretty much on her own, but did you consider, or what are your philosophies regarding long-term management of these patients?
Yeah, I actually wasn't aware of that recent paper. So I typically, if they recover well for the first or second relapse, don't treat with anything long-term. And then I think this is based on the Mayo Clinic data. And then if there's a third occurrence, or if they didn't have good recovery, then I do send them to neurology for long-term immunosuppression. So for her, it was more a question of whether to restart steroids and just do the typical slow taper, which she didn't want to do. And I couldn't really argue by the time I had seen her back, and it was 3 weeks in and she was doing well. I think most of the studies with the high relapse rate, they occur, well, I guess there's two groups, recurring early within 6 weeks or within a little later within 3 months. But she, did beautifully with nothing. So I kind of had just told her, if you have anything, pain with eye movement or any sense that this is decreasing, we would want to treat you, just call me and we'll bring you right in. And she's very reliable. So I wasn't worried about that per se, but yeah, it's interesting. I don't know. I'll have to look at that paper and see if it changes what we should be doing, but I have typically not treated for first or second relapse if they recover well.
Will you consider repeating the antibody?
So I would love to. I actually haven't seen her since that last visit, and I should have done it then, because it'd be very interesting to know if she's now seronegative, then we could be maybe a little more assured that she won't have a relapse. And I was very reassured when she got the 2 vaccinations afterward and didn't have a relapse. But she does follow with primary care at our hospital, so I have looked in her updates and she has told them her vision's fine, so she's just going to call me if there's an issue. So she looks like 2 years out that she's doing well. But yes, I'd love to have it because I assume she turned seronegative, but I don't know.
Thank you.
Just quickly, most patients with MOG become seronegative in between their episodes because it's an episodic phenomenon, and that actually brings up the point that the evidence that the antibody itself is pathogenic is still poor. And to some degree, it's a biomarker, but it is not directly pathogenic in the same way that the aquaporin 4 antibody is. And so I think that to me at least, is a significant part of why we see this heterogeneity of populations and what happens in people who have MOGAD, some doing very well and some not, as opposed to NMO. When you are seropositive, you better be on therapy for life, because otherwise you are going to have a terrible outcome.
So was it a cell-based assay is a question in this case? Okay. So any other thoughts on this excellent case, last case? So is that all? I thank you, Dr. Williams, and I go back to Satya.
Yeah, thank you, Mahesh, for moderating this session. And we had a series of lovely cases today. Thank you, everyone, for joining us, and hope to continue the same trend tomorrow. See you tomorrow then. Bye.
Thank you. Bye.
Thank you. Thank you, everyone.